Well, good morning. And I'm going to ask everyone who's standing if they could find a spot to sit. Well, I'd first like to thank everyone who's here, and more importantly, who's here on time. We've got a large number of registrants who have either been deterred by the weather or other schedule issues. So I expect over the course of the day, we'll see people trickling in. But we decided to go ahead and start because today is first the kickoff of the 9th annual HITLAB Summit. So we've done this, excuse me, we've done this 9 times. During the period of the COVID, we did it virtually, but we still contain the discipline of having an annual discussion around the value of innovation in healthcare. And today will be like all the others. We're going to explore, discuss, and celebrate digital health, and more importantly, digital health as a shorthand for how technology-enabled innovation is driving change in healthcare. Over the last 20 years, HITLAB has conducted 700 projects for our sponsors, and those 700 projects have all focused on, focused on the question of how do we make improvements in healthcare, and how do we use technology as an important component of that value improvement. And so I'm going to say first, we've learned a lot about what works, what doesn't work, what wanted to work but didn't, so you learn from failure as well. And so there's some key issues of success I'm going to ask for you to think about during the 18 different sessions we're going to have today. So think about it. In the next 7 hours, not counting lunch and breaks, we're going to have 18 different sessions and discussions, presentations, dialogue, exchanges of points of view, and more importantly, an interesting presentation of some very ambitious young entrepreneurial businesses who are wanting to make a difference in healthcare. So it's going to be a rich and very, very varied day. But from my perspective, some of the important things to keep in mind are the kinds of things that we answer for our sponsors. HITLAB answers for its sponsors. First, can something work? Is this concept, is this idea, is this ambition plausible? So can it work? The second question that shortly follows, if we think it can work, is will it work? Will the chosen components that need to work together to produce new value in some fashion actually integrate, actually connect, actually bring about changes in behavior, changes in therapeutic outcomes? The critical question that comes as third is, does it work? Can you actually collect and show evidence that the introduction of technology-enabled innovation bring about changes in clinical outcomes, bring about changes in economic outcomes? What is the evidence? And we go at it with the rigor of clinical investigations. Does it work to try to prove the case? Because, excuse me, not enough coffee. And oh, by the way, I live in Florida, so this is tough on my sinuses up here. There's 2 dimensions of value that should be proven. First, value of outcomes, and then secondly, economic value. Because the question is, not only does it work in terms of producing value for patients or value for institutions, but who's going to pay for it? So as a patient, I want to be taken care of, but someone else pays for taking care of me in most cases, whether it's the government or whether it's insurance or whether it's employers. The question that follows that proof is this a sustainable business? Not is it a sustainable technology, but is it a sustainable business? Is this a business that can view it view its value proposition in terms of a market, view its value proposition in terms of the economic forces that have got to be maintained to create what I'll call a gross margin outcome. And then finally, what will it take to accelerate diffusion? Because with hundreds of solutions fighting for market space, what you want is rapid diffusion of the best ideas, because those are the ones that will become sustainable. So those 5 questions: can it work? Will it work? Does it work? Is it sustainable? And what will it take to accelerate it? Are fundamental, not just to the work that HITLAB does, but more importantly, fundamental to everything that's going on in the world of innovation and healthcare. So to illustrate innovation in healthcare, we've invited this morning the CEO of FFF Enterprises, Patrick Schmidt, to tell us a little bit about their ambition, about their progress, about their intentions, and how they're going about embracing innovation in their business. Now, for those of you who don't know FFF, they have a very interesting tagline: helping healthcare care. They're in the business of supporting the delivery of healthcare, to those people who are most in need. They're a leading supplier of critical care biopharmaceuticals, plasma products, and vaccines. They've been in business for 35 years. They're a $3 billion privately held company. And they have chosen in the last year or so to actually aggressively establish a vector of innovation within their organization to take the best ideas for serving their patients and their customers and turn them into really useful new solutions that augment and flank the core businesses of FFF. So I'm going to ask Patrick to join us up here and share his thoughts on how does a well-established company aggressively embrace digital healthcare. Patrick.
John, thank you for the kind words and welcome and good morning. Today's, in case you're not aware, is Giving Thursday. To those who've been given much are responsible for much, so dig deep and give heartily today. As John said, my name is Patrick Schmidt. I'm the Chief Executive of FFF Enterprises, or 3F or Triple F. It's kind of hard to say. John, you did a great job. And the parent of FFF, our wholesale division, New Factor, R&I Technology, which we have displayed in the lobby, InCircle, and most recently, Clear Trust. I hope everyone had a beautiful and peaceful Thanksgiving holiday. Unfortunately, we know not everybody did. So thank you for this morning, for coming this morning. Allow me to spend a few times with you at the beginning of HITLAB's 2022 Innovators Summit on the beautiful campus of Columbia University. As I was preparing for the event over the past several days, I thought it made sense to learn a little bit more about Columbia University. So thanks to Wikipedia, I discovered Columbia, established in 1754, has a $13.3 billion endowment fund, among the largest of any academic institution. Its illustrious alumni, faculty, and staff has included 7 founding fathers of the United States, 4 U.S. presidents, 33 foreign heads of state, 2 secretaries generals of the United Nations, 10 Supreme Court justices, 100 Nobel laureates, 125 National Academy of Science members, and I find this one interesting, 53 living billionaires, 22 Olympic medalists, 33 Academy Award winners, 125 Pulitzer Prize winners, and importantly, what brings us here today, an accelerator labs for technology firms. So it seems appropriate at this time to thank Stan Kashnowski, Terry Antimano, and again, John Hammett, and the faculty at HITLabs for inviting us here this morning. So how did a company you likely never heard of, founded by a man you certainly never met or heard of, having played for 2 NFL Hall of Fame inducted football coaches, end up here today? That's the same question I'm asking myself. There is only one plausible cause: providence, divine providence. These are the lens I see the world through. It is in the same spirit of Columbia University's motto, "In thy light shall we see light." Beginning with a $100 investment in 1988, in a similar spirit expressed in the English translation of our Latin motto, fortune favors fortitude. FFF was born. Not with the intent of being here today. FFF began as a means to an end. That end, my life plan, was to coach professional football. We created FFF during a severe shortage of patient examination gloves in 1988. Some of us are old enough to remember when dentists would work on you without gloves on. And so the shortage was caused by the CDC's release of universal precautions against HIV. Our plan was to borrow $80,000 from an Italian friend of mine, buy one container of exam gloves, split $20,000 in profit, and coach football for the rest of my life. In retrospect, it was the first unmet healthcare need we thought we had identified. It wasn't. Thousands of other people were ahead of us, and by the time our imported container arrived, the shortage had long been resolved. Having to quickly scramble to modify our original plan, remember, we're on the hook for the $80,000 from the Italian guy, we identified a company that operated 700 dialysis clinics. Having found the person in the organization responsible for purchasing exam gloves, we learned abruptly from her, they're coming out of our ears too. It was at this point, I asked a divinely inspired question that changed my life. What would you buy if we had it? Had she not answered, we, and all our teammates here from FFF today would not be here. Since then, I've dedicated over half my life to doing God's work to fulfill seemingly endless unmet needs, helping healthcare care for patients. You will not hear me utter or aspire to disintermediation or disruption. An unmet need is something someone else cannot do or won't do. It really is a matter of will, or as my mom used to say, when there is a will, there is a way, especially if it's God's will. Likewise, if we had chosen any other name besides FFF, we certainly would not be here today. This is why we believe providence is at work in our improbable existence. However, the whole tale is for another day and another time. From our very humble beginnings in the spare bedroom of a rented house, we have steadfastly focused on finding solutions to fulfilling unmet needs in healthcare distribution, high-touch home infusion, specialty pharmacy, for deployment of critical care pharmaceuticals and biologics to save countless lives, speed time to therapy, reducing the cost of care while improving healthcare's ability to care for patients. We recognized long ago that technology was a business accelerator. We have invested tens of millions of dollars in state-of-the-art ERP systems, warehouse management systems, e-commerce, cloud, distributed workplace communication systems, CRM, AI, and ML. We are intent on digitizing the pharmaceutical supply chain, bringing visibility and transparency to a broken and deceptive drug distribution system. From a 7-year self-funded study named Insights, acronym for Immunological and Neurological Study of Immune Globulin Habits, Treatments, and Standards, we applied our surprising study conclusions and built algorithms to help insurers identify $2.5 billion of potential waste in a $12 billion therapeutic category of a finite, precious resource. Later in the conference, you'll have the opportunity virtually to meet Dr. Todd Levine. He and a colleague, Dr. Jonathan Katz, were the inspiration behind our clinical decision support system and wholly owned subsidiary named InCircle. It started very simply with Patrick, there is a need to collect data suggested by Dr. Levine, another unmet need. In case you're not aware, as I was not, InCircle is a geometric term describing the largest circle that fits inside a triangle, visually depicting the patient as the circle, touching 3 sides of the triangle, each side representing the payer, provider, and producer of the drugs, sophisticated medical device, or digital therapeutic. InCircle's mission and purpose are simple. Make sure the right patient will respond to the right drug and eliminate what one payer/customer referred to as unrighteous spend or wasteful spend. I have personally sat in meetings where payer executives had made statements to the effect that all specialty drugs using an InCircle-like system will be prior authorized this way in the future. From our perspective, it is fundamentally much more profound. We believe everyone in America and on the planet should have access to medical and clinical experts in every disease and therapeutic area. Everyone includes everyone, no matter what you look like, where you live, how much money you make, and who you choose to love. We all deserve expert medical and clinical oversight. Only through technology can this be enabled. We were inspired recently to take a step further in this direction after hearing a medical director from a large national payer participate on a panel at the recent Association of Value-Based Cancer Care held here in New York City in October. He said prior authorization and utilization management are the blunt instruments we have at our disposal as a payer. How does it make you feel we're using blunt instruments to determine who and what gets covered by insurers? It did not exactly make my confidence soar. I internalize everything. What if it were my loved ones, what if it was me or my loved ones around the receiving end of that coverage determination? FFF's investment in Clear Trust and Encircle is our information technology response to replace the blunt instruments payers are using. We want to help payers manage the impossible task of managing increasingly costly and complex therapies. So don't miss Scott Kornhauser, EVP of Clear Trust, and Bert Zwigenhoff's session later today, which will describe in more detail our value-based contracting application. We believe this has the potential to obsolete the current cumbersome prior authorization process, speeding time to therapy initiation, which translates into money and life saved. Many of you may recognize Bert as the founder of AVBCC. He is also a dear friend of mine here in the front, and Scott's right over there. Thank you, Scott. So changing gears a little bit. How many of you know someone who is struggling with substance abuse who may be in danger of a drug or fentanyl poisoning overdose? Do you know we're on track for 148,000 people to die from drug overdoses in the next year? I woke up yesterday morning to yet another daily article about the drug overdose epidemic. This one on why Black men are dying at an alarming rate from drug overdoses. 148,000 from all walks of life this year and 107,000 last year. This is the public health crisis of our time. Many of these deaths are preventable. The reversal agent, nasal naloxone spray, needs to be within an arm's reach of every overdose emergency episode possible, free of charge. Sadly, this is the most shocking and unexpected unmet need we've discovered in our 34-year history. It is something I am personally spending much of my time on. I am reminded of the passage from the book of Esther in the Old Testament, where Mordecai said to Esther, "Who knows if perhaps you were made for such a time as this?" I feel we have been specifically called to use the distribution, dispensing, and information technology assets we have assembled, created, developed, and deployed to reverse the insidious tide of overdose deaths, a national epidemic of epic proportions. You cannot rehabilitate and help people from the strongholds of addiction unless you rescue them from the overdose episode that is within minutes of ending their lives and shattering others. Later today, our Chief Operating Officer, Shay Reed, will share with you our set of right now inventory technology solutions, R&I for short. Joining Shay will be Brad Foltz, who leads the initiative for us as our VP and General Manager. They will be showcasing in the lobby our R&I secure cabinet. We are in the process of standing up 36 forward deployed, connected micro 3PL sites around the country for rare, critical, expensive medical devices and specialty drugs that require special handling and storage solutions to be nearby the patients needing these treatments. While not specifically designed to address the opioid overdose crisis, our R&I secure cabinet has unparalleled capabilities, innovations, and use cases that Brad and Shay will share with you later. Our other R&I technology solutions, R&I Ready and R&I Cloud, are assets we intend to deploy to combat the opioid overdose crisis. We will be able to know exactly how much naloxone is in each location, the lot number, expiration date, and how much has been dispensed into a community, either through our wholesale channel FFF or our discrete direct-to-consumer channel New Factor. This data shockingly does not exist today. Currently, there is no way to measure effectiveness or fragility of access to overdose reversal medications. We are blind to the information. Our technology will provide the needed visibility and automatic replenishment. Our goal is to share this information with HITA's OD map that tracks and issues overdose spike alerts to subscribers around the country. Our data will allow OD map to create an naloxone overlay able to match naloxone availability with overdose spike alerts. In case you are not aware, HITA stands for High Intensity Drug Trafficking Area. There are 32 areas designated as such in the United States. Think of a spike alert as smoke that rises from a fire. With our technology, we'll be able to in real time to identify the exact location and amount of naloxone in the vicinity of dangerous fentanyl-laced drug overdoses, and in essence, put water directly on the fire. Another unmet need. Remember, unmet need is cannot or will not, thus saving lives. I'd like to make one thing abundantly clear. We are not attempting to create a solution to a problem we help cause. We, as a specialty distributor licensed in all 50 states, did not ship hundreds of millions of opioids and unchecked suspicious orders to cities, counties, and states, which, in the words of Sam Quinones, author of Dreamland, the book telling the story of how the opioid crisis began, characterized such uncontrolled distribution as tenderizing a whole new generation of addicts. In fact, we have an unblemished regulatory and distribution history, and today marks the 12,563rd day of counterfeit-free drug distribution from our nationwide network of state-of-the-art distribution and dispensing pharmacies. We consider our network hallowed ground. No other wholesaler of our size or scope can make or support such a claim. Our very disciplined distribution model of buying only from pharma manufacturers and shipping only to licensed providers, had everyone adopted it, would have precluded the need for a federal drug security supply chain act. So I would like to thank Stan again and the faculty here at Columbia University HITLAB for inviting us and encouraging us to share a little bit about the leading edge solutions and the problems we're trying to help solve. They have helped guide and persuade us to launch our own innovation hub we're calling Forum Innovations. Forum, a space where ideas can be exchanged, a medium for open discussions, powered by FFF and spelled with 3 Fs. I bet you saw that coming. Our logo, FFF, looking to the future, looking to the horizon, our future plus innovation. John Hahn, our CIO, and Todd Augustine, our VP of Digital Health and Analytics, first proposed the idea of an innovation hub when they committed, I think promised, by doing so, we could move faster and more cost effectively. It was the cost effectiveness that caught my attention and convinced me. So their further encouragement, along with Wayne Tuller, our CFO, who could not be here today, led us to accept this invitation to share with you this morning. So thank you, John and Todd and Wayne, who's not here. I would also like to acknowledge our General Counsel, Aya Salim, who still relatively new to our ranks, is here with us this morning, coming from nearby New Jersey, who, without the pandemic opening our minds and horizons to consider senior, highly qualified remote participants, would likely not be here today. So welcome, Aya. Like all of our team, all of our amazing team, you have all been such a delightful blessing. Providence yet again, God Almighty still in charge. So from our initial $100 investment, we have grown to a multi-billion-dollar private enterprise, and by the grace of God, attracted and retained talented, experienced, loving, and caring teammates, all deeply committed to helping healthcare care. Thank you again for your time and attention this morning. It's been an honor to speak with you. So may God bless the rest of this day, the days ahead, and all the rest of your days, no matter how many they're numbered. So thank you very much.
That is a fantastic kickoff speech and talk again for such an important meeting. The first time in 3 years that we've had this Digital Health Summit live in person in New York City. New York City is back and it's open. And many of you I know stayed here last night who flew in from out of town and have already told stories about being in Times Square, being back on the West Side, being back in central New York. And Midtown, and just seeing how alive it is. And it's great to have everyone here. And we couldn't have done this without our tremendous support. Then support provided by FFF, provided by Merck Global Innovation Fund, by Fenwick, and by Piper, and certainly Playing Forward, and all the good folks at MRG and Recovery Response, Information Media Corporation, and BlockCube, the blockchain clinical trials company. So many sponsors and so many people supported us in bringing this together. So thank them. Just a round of applause for the people who supported this. Today's meeting is going to be focused on several critical emerging components of digital health that have come about over the last 3 years with the unprecedented medical technology response to the COVID virus, and how it's now precipitated into this new digital health reset. So as the tree bends in the wind, sometimes it snaps and sometimes it sways back to center point. We've seen over the last year now this swaying back to a center point, not entirely, but somewhat. And we've seen the infrastructure for healthcare delivery at a very deep and very fundamental way being changed. We saw it as a reaction in March of 20 and going through the rest of 20 and 21. And now we've seen it as a response with new health plans providing virtual first technologies and services, with companies like Transcarent providing these sorts of using traditional MSA infrastructure, but now digitizing a lot of the delivery where providers are being paid upfront and not have to fight for claims dollars. Now reinventing how healthcare delivery will look, not just today, but over the next 10 years. And very much like what we saw with managed care in 1990, where it was a small fraction of the US healthcare system, by 2000, it was almost the entire healthcare system. We're seeing now this digital infrastructure being put into place very quietly, but nonetheless, very massively, to provide digital services, not just on healthcare delivery, but also clinical trials. Decentralized clinical trials, which was a buzzword that came about with the pandemic, is now very much becoming more of something that life science companies, academic medical centers, CROs are investing in heavily. And we're seeing that grow tremendously as well. Remote patient monitoring, like what we see with Peter Nemi's company, Recovery Response, we're seeing now that the ability to rehab at home is very much an actualization, is very much a reality. And so that kind of modeling that we're seeing build is something that won't happen overnight. So it's not a one-year revolution, but it is a revolution. It is something that over the next 10 years, that sort of digitization of healthcare delivery and life sciences, a lot of what Patrick just talked about in his opening keynote is being built, is happening. And we're seeing some of the seeds of that already come to fruition today. To talk more about that is our next panel with Sarah Chotsky and Juan Jimenez and Sabrina Runbeck. And they're going to be talking a little bit about another key theme of the meeting today, which includes things like digital therapeutics, decentralized clinical trials, and other types of really important issues that are rising in digital healthcare, but it also diversity, equity, and inclusion. As we've seen digitization grow in healthcare, starting with a lot of what happened in the .com 90s, we saw new efforts to embolden and to empower clinicians and providers around the world to bring patients digital technologies and allow them to improve outcomes, accessibility, and affordability through digital interventions. And part of what we're seeing now are those models being built where it empowers patients to empower themselves. And so we're going to hear a little bit about that now with Sarah and Juan and Sabrina. So please welcome our next panel to talk about health equity and digital health.
Thanks for everyone for joining us today, and we'll just do a brief, quick introduction. Sarah, would you like to start?
Sure. Good morning, everyone. I'm Sarah Chotsky. I am the Director of Research here at HITLAB. I'm a public health sociologist by training, but I've always worked in very applied settings, originally focused on mental health services, and for almost 10 years now, exclusively in digital health. So excited to be here.
Well, I'm Juan Jimenez, co-founder and CEO of AccuCardia. First of all, I want to thank HITLAB for the invitation. I'm so happy to be back on campus. Last time I was here was 14 years ago, so I'm so happy to be back today. We co-founded AccuCardia in a nutshell to save lives. Currently, there are different amazing devices, amazing information being generated by consumer, clinical, inpatient, outpatient devices, but that information is not properly analyzed or managed by the current workflows. And in AccuCardia, we have built the platform that is able to ingest device agnostic ECG signal coming from different devices and prepare in a way that is useful for physicians and clinicians and reimbursable by several payers.
Great. I'm Sabrina Rumbach. My background is in cardiothoracic surgery as a PA. When I was really burned out, working 80 hours per week, and I know one of the big issues in healthcare nowadays is staff turnover, and we're losing providers and nurses left and right. So I went back to my root in neuroscience and public health, and really thinking about how do we optimize the way that we deliver care? How do we engage with our staff so they're not leaving us? And how do we use technology to better bridge the gap? And now as a director of people and clinical outcome for MRG Health, that's our focus, to reduce staff work struggles and then improve patient satisfaction. And on the back end, we can actually increase profitability for our providers. And so one of the definitely thing that's close to me is access to care. We know on average, clinicians are seeing about 25 patients a day. So if you think about an 8-hour workday, that's less than 15 minutes per patient. And no wonder anybody who go to subspecialty and primary care physicians, they're waiting for weeks to be seen. And how would that impact us as individuals, seeing our family have to wait for care? And so that's one thing I would love for you guys to discuss. While we're using digital technology, what are you seeing as a truly barrier to those access to care issues?
First of all, I believe that technology is the only way to be able to alleviate the access of care in America. There are 15 million Americans living in medically underserved areas, and 99 million, close to 30% of the population, living in healthcare worker shortage areas. So by recruiting more clinicians or doctors by itself is not going to solve the problem. So first of all, I believe that clinical workflows and standard of care need to include digital health solutions being developed by traditional healthcare companies, pharma companies, but also early stage companies like ours. I believe that that is essential to be able to provide information that doesn't add more burden for clinicians, but help them in their overall care of patients.
Sarah?
Yeah, I mean, just to piggyback on what you said, Juan, I think burden is the key issue. And I think it's a key issue, as you know, thankfully, we're talking about a lot now, and I'm sure we're going to talk a lot about that today and for the next 3 days about burden and burnout and reducing clinician burnout. But, you know, patients are burned out too, you know, even if they are nearby logistically a care provider, even if they can get an appointment, you know, that's not necessarily even the last mile. Someone with a chronic condition has to attend to their health a lot and sort of need to be seen a lot. How can we make it easier to be a patient? How can we, you know, keep them at home as much as possible? And I think that's what I love about AccuCardia and the possibility that we have with something like AccuBeat is, you know, it's one of the solutions that lets us start to think very realistically, how can we keep patients at home where they're comfortable and not sort of pile on, you know, the burden that is sometimes, you know, being a patient with a chronic disease.
Exactly. And I think that's why, like, I run a podcast show for the past 2.5 years. And then the big thing to highlight is, what are the innovations? How are we celebrating medicine nowadays instead of figuring out or trying to put a negative spin on what are we not doing right. And so that also come into how are we using clinical trials and really be able to leverage wearables such as AccuBeat to help our cardiac patients. That's part of my natural background. So Juan, would you like to expand?
Sure, let me give some background on AccuBeat. AccuBeat is one of our platforms for AccuCardia platform to perform clinical analysis on short-term electrocardiogram tracings, coming from clinical devices such as an event monitor, a Holter, or even a consumer wearable device such as the Apple Watch, Fitbit, and Samsung Watch. We believe that besides designing clinical studies and trials with diversity and inclusion in its design, bringing different population for background, gender, identity, as well as ethnic background and socioeconomical background as well. That is good by itself, but given that there are certain groups in society that have less flexibility in the work schedules, that we need to bring clinical solutions that be able to get that information needed from a trial at home or at work. So we reduce the burden of participants going to sites for multiple testing and multiple interviews and reducing the compliance rate. So AccuBeat, we have proposing using AccuBeat to perform QT and QTC monitoring, and QT and QTC monitoring is very important for many clinical trials, but nowadays in the new era of the immune therapy drugs, we need to monitor that not only in the trial, but also post administering those drugs. And AccuBeat provides that, help using the consumer device and providing automated analysis on that information and be able to provide that in a way to a physician that doesn't add more burden to their own workflows.
Sarah?
Yeah, and just to build on that from a research perspective, the reason I think I'm up here is because we, HITLAB and AccuCardia worked together recently on a study of AccuBeat. And I think the other piece that is important to kind of recognize is, the study that we did was the first in what will, be a series leading up to a, more super robust clinical trial. But these studies offer us the opportunity to look at how these devices are used in real life with real people. In this case, it was our first step. So we're using an Apple Watch to collect the data to, see, all right, does this work how we think it's going to work? And, amen, it did. But it also gave us a chance as researchers to look at, I think often what can be overlooked, but it's going to be really important to that last mile is like, well, what's it like for that patient to put the watch on for themselves? And do they understand how it needs to be placed? How are they being onboarded to the technology? I think more and more we have the technology to do what we want to do. That's not the problem. It's really hammering out, what does this look like for somebody who, isn't super savvy with technology, who's very busy, doesn't have a lot of flexibility in their life to, attend to their data collection 2 hours a day, those sorts of things. So it was a great opportunity, I think, to do what I think is some of the most important last mile work, which is, what does this look like for patients and for clinicians who might not be used to incorporating, technology into their practice in such a way quite yet.
Exactly. I think that being said, it leads to a good point of if we're creating devices just for our own knowledge, or is it really for patient? Because if we're creating something that the patient don't know how to use, or they won't use at all, then it's pointless. And we also know nowadays there are a lot of devices out on the market. Perhaps one person who has a blood pressure cuff at home have an iWatch for their monitoring EEG, and other people have sleep apnea. Each of them have a different app and they don't communicate with each other. So it can be very challenging for our patient population at the same time. And so that being said, I think a big movement is all about how do we take care of the patient the best way we can. And most of these is because we know by study, 50% of the elderly population have AFib undetected. And for the arrhythmia issues with QT prolongation, that has a lot of drug interactions and then cause people to go into the hospital using emergency room. And so when we consider in population health and adaptability, how can we really be able to create these wearable devices or technology that are affordable and at the same time easy for people to use?
So I'd like to, in terms of interconnectivity, easy to integrate, innovators and new technologies need to be assess the current workflows and create a product that integrates with the status quo. And in AcuCardia, what they have done is we have built an API-based product in which our product can be interconnected with different remote patient monitoring software currently available. It can interact with the EHR system. It can interact with different software used by different practice and clinics. So that way we can help and avoid one situation that you mentioned, that adding more products that create more burden for both patients, clinicians, and payers. And in terms of one point that I'd like to add as well is regarding the diversity and inclusion from the get-go that I forgot to mention in the previous statement. It is that as AcuCardia, being a diverse company from the get-go, 99% of our team come from underrepresented groups in the nation. In the first clinical study, building clinical validation, we wanted to design the study with the help of HITLAB and the SUNY Downstate team that represented those groups that we want to target. So that's something that also we wanted to highlight as part of the study.
Yeah, I think it was really great to partner with SUNY Downstate for this because of where it's located and because of the team. We had the opportunity to put action where words. I mean, it's wonderful to hear more and more people who are building devices, people who are building systems to think about diversity and inclusion. But this was action. We were really able to recruit a really diverse sample and feel like we were, being very representative when we're saying, we're in the right direction. So yeah, it's great. I'm thankful for that because it's hard to do alone, but to have multiple teams who are dedicated and committed to doing that. Yeah, made it great.
Yeah, I appreciate you for being here and then to talk about this big topic, and definitely would not be able to really discuss in detail in 15 minutes, and then definitely a longer conversation to go. I appreciate you guys for being here.
Thank you.
Thanks, Sabrina.
Thank you, Sabrina. Good job.
Fantastic presentation and panel. Sarah will also be leading a panel now to talk even further about what digital health is doing in terms of solving these issues around diversity, equity, and inclusion, but now looking at chronic pain management, at-home management for folks in that category. And joining her today are two extraordinary leaders in this area, Sean Smith from One True Health and Ziggy Afaran from Hospital for Special Surgery. They are still getting mic'd up. So on that note, one of the things that we're also doing is we're taking questions online. So either going through the Zoom chat that is enabled with people around the world watching this. By the way, we're the only digital health meeting that is hybrid, live streamed around the world for free. So people are able to watch this and see all of our sessions for free using Zoom and linking in there. And they will also be available on our YouTube channel. So be sure to subscribe to HITLAB on YouTube to see whenever these sessions are being dropped, which will come out over the next 2 weeks, also for free. And stay tuned on those as well. So next up, Sarah, Ziggy, and Sean.
Awesome. Thanks. Before we start, I'm going to ask, I forgot to bring my phone with me. Hey, Jerry, Can I have the 5-minute warning? Thank you. Great. So thank you, everyone, for sticking with us. I'm thankful to be here with Sean Smith and Dr. Ziggy Arfine. And I'd love to, just start with some quick introductions for our audience.
Thanks. Hello, everyone. I'm currently Vice President of Strategy and Operations at Hospital of Special Surgery, or HSS, particularly an innovation unit called HSS Health. Prior background as an attending physician, and then worked in management consulting, venture capital, and a startup.
And my name is Sean Smith. I'm with One True Health. We're a family of companies based out of Austin, Texas. Our care management company provides virtual first preventative care primarily for Medicare eligible seniors suffering from chronic and acute conditions. And we have a technology company that's focused on a personal health record and a patient engagement platform to give seniors actionable insights on what they can do to get healthy and to stay healthy.
Awesome. Great. Thanks. So let's dive right in. So as Dan mentioned, today we're going to be sort of talking about how to solve, how to better solve for these, for the issue of sort of ongoing chronic disease care, as well as acute care. And so my first question, Sean, I'll start with you. As we know, our population is aging pretty soon. By end of decade, we're going to have a lot more of boomers entering into Medicare. I'm following close behind. And so, what do you see as some of the biggest challenges for health systems as, we get this population, this larger proportion of the population who are suffering from chronic disease?
Well, it's a huge problem. It's already $3 trillion is spent on managing chronic and acute conditions, from diabetes to hypertension to heart disease. And 43 million seniors suffer from 2 or more chronic conditions. So there certainly is the lion's share of that issue is coming from the senior population. And as you're right, the boomers are headed towards being Medicare eligible. The biggest challenges, though, really have happened during COVID. And that's the challenges of clinical staffing and patient engagement. So let's take one of them individually, or take them individually. Clinical staffing, everyone heard about the Great Resignation, right? We've had a lot of nurses that have left, didn't want to garb up and be in the hospital system. There's certainly a serious issue in rural communities, especially. They got hit hard with respect to the Great Resignation. They're having a hard time doing transitional care management, case management, loss of nurses. It's really important for rural communities to keep patients within their catchment area, and they're having difficulty doing that. So clinical staffing really exacerbated that problem. They can't follow patients home to help assist them with their chronic and acute conditions. Second is only 40% of American seniors actually saw a doctor in person or through telehealth during the pandemic. So now you have a problem of engagement. These same clinical practices are trying to reacquire their patient, if you will, and to bring them back without it being hair on fire into the emergency department. So how do you go engage that population that's been out of the healthcare system, help them to manage their chronic and acute conditions so they don't go hair on fire to the emergency department, and then bring them back in appropriately into the health system for revenue generating encounters from clinical practices to hospitals? So I would say clinical staffing and patient engagement are the 2 biggest challenges as we go post-pandemic to manage chronic and acute conditions.
Thanks. No, I hear you, and I hear, that staffing issue all the time now, and I've seen some really interesting solutions coming out around that. I'm curious, Ziggy, are you seeing the same thing in terms of HSS and more broadly?
Yes, I think certainly those are true. As I think about particularly chronic conditions, but chronic and acute conditions and that aging, increased burden, I suppose I always think about the 4 levers of viewing healthcare through cost, quality, experience, and access. And really on all of those accounts, you have increased pressures. Cost is either staffing, inflation, maybe the supplies, as we've heard earlier. Quality, people always want better and better quality. It's a competitive market too within that. There's also then the experience. In a way, the big tech spoil us with having good experiences, so we want those also understandably with healthcare with that. And so with the pressures on those, but the good thing is, and I suppose we're here, is technology is kind of the answer on all those levers. You can apply technology on all of that cost, quality, experience, and access. But the challenge, I guess, I've seen within healthcare systems, and it's not unique to HSS at all, not even unique to the United States, actually, with that, is the industry itself is busy with day-to-day operations, which are high risk. It's risk averse naturally. Coming from the pharma side of the 30-year evidence that you have to adopt any technology, and it's often human capital focused too, either thinking about doctors and nurses or thinking about the patients. And so effectively, I suppose I think about the question of how quickly can the health systems adopt technology is where you could then solve the staffing problem, solve the engagement problem as well.
Right, so there's that last mile of, how do we get the evidence? What level of evidence do we need? How fast can we get you the evidence?
That's- Yes, because ultimately, I suppose within a healthcare system, it's driven by providers, and providers, will come with their lens, how they're trained.
Sure. Great, thanks. Super interesting. So, Sean, I'm going to come back to you for a second because you mentioned One True Health is building a personal health record. Would love to hear a little bit about that and why, sort of, what gap is that filling in this puzzle we've been talking about?
Well, it's just been something that's been big on our heart is, again, patient engagement, and how do you find ways using technology to really capture the interest of patients and give them the information, the actionable insights they need to get healthy and to stay healthy. And, I find it interesting. I'm company's based in Austin, Texas. Here I am in New York. If I were to go to an ATM on the street, I would get a pretty decent picture of my financial health. But if I get hit by a bus on the street, that emergency department physician will have absolutely no information on me, my, medication contraindications, how to take care of me. And why is that in today's digital age? So how do we, it's not really a regulatory issue anymore. The 21st Century Cures Act has provided the ability for me as a patient through consent to go get electronic copies out of all electronic health records all across the nation. But what do I do with it? EHRs are designed for practitioners to deliver care appropriately to the patient. That's what they're designed for. They may have a patient portal, but they're not really meant. They're very localized. So, if I get seen here in New York, then that information is not going to go back to Austin, Texas with me. So, I have the ability of getting it, but when I get it, it's going to be a copy of something I don't understand as a patient. So how do we create a personal health record that has all the retrospective data without the inaccuracies, without the duplications, in a, with data extracted to provide clinical meaning to me of what's happened retrospectively, add in remote patient monitoring devices, wearables, social determinants of health information. How do I get a real, complete, vetted, actionable picture of who I am and my health? And then the insights on what I can do to get healthy and to stay healthy, which no traditional EHR provides today either, right? So how do I take that care plan? You see seniors walking out the door with the stacks of instructions that they don't read and they don't understand, right? How do we solve those two problems? And that's what we're working on at One True Health.
Oh, that's really interesting too. I've heard this idea of a personal health record, but a little more dry than you're describing. Like you're really talking about, much as we talk about decision support for clinicians, kind of decision support for patients.
No, absolutely. And not in decision support, but really something that I could say, this is mine. And why can't I share it now electronically if I get hit by the bus with the emergency department physician? Here's what happened to me in Utah and in Texas and in Georgia. Give you more information to deliver care to me, but also, again, those actionable insights, because as you know, I'm in that sandwich generation, 9% of adult Americans, 82-year-old dad. I've got a son in college, right? And what I wouldn't do to make sure that I knew if my dad's taking his medications, did he walk today? How's he doing with respect to his sleep apnea and with his other issues? So I think for caregivers, for family members they want to be involved. They want to help with the care. They want to help their aging senior parents. So I'd love to do that. But again, it comes to information that's available, understandable, and actionable. How do we do that?
Well, no, Sean, you just take me back to some frontline memories where, I can think of, patient with a huge scar down the front, and you say, oh, what operation was it? I don't remember. I was in hospital for a month. And then you're dealing with an abdominal pain. Of course, that's going to have an impact. Or, I take 5 medications. Well, which ones? Well, there's a pink one, there's a white one, there's a big brown one. Understandable. And then spending an hour sometimes on the phone trying to figure out who. I suppose just to add to that, I find this, first of all, I think it's great what you're doing, and I think really needed. Already could have happened yesterday, ideally. So while you work on the hard part, just to add a bit of thought, I see it somewhat as changing a bit of the social contract between patients and the provider. So often the provider would have had the information, would have had all the data, and then power lies with whoever has the information. And so while the provider had the power and some responsibility, ultimately still the patient, and we've all been there, is left actually with the operational practice of navigating their journey, but without really the tools to help them do that. So I feel that, Sean, as you solve that and maybe other companies do and adopt it, is that with a patient, and we're all patients, get to have your own record, I can think of already like 3 things that would improve. I think you'd immediately get better educated once next to your name you have this condition. You know, then it's visceral, and now you've got information search tools. That's one. Or in the case of, again, as HSS, we're now providing patients more information digitally. You've got better coordination to what you say, whether you're traveling from Texas to New York across systems. You just don't need to remember what those 5 pills are or which operation you had. But the doctors and the providers can manage that. And I think with that also is there's some level of transparency and quality, going back to those 4 aspects. I just know as a provider, when I know a patient's reading it, you know, you're just automatically doubly careful about what word you say or how you put it, or it's a chance to share more information. So I think there's a lot to be gained from that personal health record being real. And then if you add all the things that you say, social determinants, genetics, I mean, wow.
Very good. All right, so we have the vision. Everybody get to work. Ziggy, I would love if you could talk for a little bit about, we prior to this, were talking about digital therapeutics in terms of, you know, we see more and more out there for managing chronic conditions. But what about acute conditions, you know, and should we start thinking about digital therapeutics more, you know, in acute situations? Is there compatibility there? Is there opportunity there? I'd love to hear your thoughts.
Yeah, thanks, Sarah. I mean, I guess short answer is yes, but the longer answer is there's a reason why I think chronic conditions get more than acute. Having more time to be there, staying longer, they are the lion's share the burden of costs, so that naturally attracts interest. But also I think there's a fundamental business challenge with an acute care versus a chronic care condition, because acute is often a one-off. It's, you know, it's not, you're going to get typically subscriptions, repeat loyalty, engagement to that aspect. And so it's harder to make, and then a smaller market to make that business case. I think also thinking back again to cost, quality, access, and experience, when you're in an acute situation, let's say you've injured your leg, you're more likely to say, I'm just going to pay what it takes. I don't care how much pain there is because I'm already in pain. If I have to wait 3 hours, I'll wait 3 hours. And so again, just harder to make a business case around it. Having said all that, HSS has created a business for it, which is just announced 2 months ago, and we were supported by $20 million of venture capital investment, and it's called Right Move Health, or Right Move Health powered by HSS. And this is for musculoskeletal injuries. It's a virtual physical therapy triage and treatment platform. So while there's existing companies out there where you can get your exercises either sent to you on videos and do it, this is really thinking about, again, all those 4 levels of cost, quality, experience, and access in saying you can it's a B2B business where you'd immediately, employee can call a physical therapist at will, same time, have a live person triage them, and then be able to say where they can be directed to. Because if you think without that, your current options are, you might go straight to an orthopedic surgeon, then you enter into an MRI, maybe an operation, maybe not, maybe a repeated appointment, an emergency room, it's going to be high cost, long wait, your primary care physician, if you can get in, how that is, a PT, which you're not sure if you really need or not. And then of course you figure things out at home. So you immediately get that PT level advice that can then, if you truly need emergency room, primary care physician, orthopedics, put you there. But if you need PT, you're immediately funneled through to have live one-on-one sessions, which you can arrange. And of course, you've got the digital technology solution where you've got your information, your education, ability to schedule, and then have those live sessions with more feedback. It's more engaging, thinking of the engagement aspect, and go through sessions to hopefully then lead you to a better outcome. You know, it's more cost efficient and a nicer experience. So I think it can be done. We're certainly working on that and happy to talk about that afterwards with anyone there is, but it is challenging compared to the chronic conditions.
I can see this applying to cardiac rehab. You can see it applying in a lot of other areas other than musculoskeletal. It's exciting. I think you're finding a solution again to what we talked about with the staffing problem, right? You're using technology, you're using triage to help make the right decisions because there just isn't in the old pre-pandemic way of doing it, a way of doing the right triage and informing the patient with the right therapy and the right course of action. So I'm very excited for HSS and what you're doing and that leadership.
Well, thank you. And to say, you know, just as far as putting some more specifics on the cost, that's a $380 billion market. You think depending, you know, what you believe, a quarter up to a half sometimes of surgeries could have been avoided for a plethora of reasons. You can imagine the costs that puts in. To the quality aspect, at HSS, we've been voted by US News the #1 orthopedic provider for the last 13 years. We've got a 160-year history and more than 100-year PT department. We can now give that out to rural areas through the virtual, who may not have access to a PT, let alone one that's, if you like, we might say HSS, you know, trained level. So it gives you that aspect, the experience of having it immediately, you know, and then access. That's something you can always try and get out there, but by going through large employers, hopefully that gets out into millions of hands.
Yeah, what you said, Ziggy, really resonates with me in terms of, you know, historically, we've expected patients to sort of maneuver a system without knowledge or tools. Well, I actually broke my leg this summer. It was like, I didn't know what to do. I never broke my leg before. Where do you go? And what level? I didn't know it was broken. I went around for a month, so being able to give patients the tools then to maneuver a system, more effectively.
And you might have Sean's personal record if you.
I could be like.
Sounds like a good combination.
It's great. All right. Looks like we have used our time. Thank you both so much. Really enjoyed the conversation.
Thank you.
Thank you, sir.
Well, thank you very much, Sarah. And again, just another level deeper into this digital health reset that we're seeing along the lines of payer, provider, pharma, and most importantly, patient. And to talk about that and to talk about one of the underlying components of all of those different relationships is data, and how data is the new currency in healthcare, and how important that is to not just understand where it is and how we can use it, but also to ensure that we have the highest level of integrity when we are using data and helping it to improve patient outcomes, access, and accessibility. Really the heart of all the work we do at HITLAB around the world. One of the world experts to talk about this is someone who is truly the architects of this new digital health infrastructure that we're seeing, someone who's been building it through building partnerships, funding these massive programs with one of the world's largest digital healthcare funds, is Bill Taranto from the Merck Global Health Innovation Fund. Bill.
Well, good morning, good afternoon, good evening I know there's a lot of people on Zoom from wherever you're calling in. I appreciate you allowing me to speak to you today. I'm going to try to do something to walk the stage a little bit, not because I have anything against podiums, but because I have the Italian affliction where I have to move when I speak and I can't stand at the podium. For those of you who heard me speak before, and those of you who haven't, as Stan said, my name is Bill Taranto, and I'm president of the Merck Global Health Innovation Fund. And we're one of Merck's funds that's 100% dedicated to digital health. One of our primary investment thesis that we have used since we started the fund, and something actually was developed even before I joined Merck, was that we have this idea that data is the currency we're going to use to transact in the future healthcare market. And what that means is if you actually looked at our portfolio, every single one of our companies are actually data companies, whether they're capturing data, throwing off data, analyzing data, monitoring data, you know, accessing patient data. It's all about data to us. And that's really one of our primary investment thesis. And then when I was talking to Stan, one of the things that we realized, we've never actually probably talked about, well, why is that one of our investment thesis? And what does it really mean to the pharmaceutical industry and the healthcare industry when we talk about data and why it's important? So what I'm going to cover today is just kind of why, why do I think, and why does the fund think that this, this is an important concept about really data being that currency we're going to use to transact in the future healthcare market. See if we can get this to. All right. Maybe I'm not doing this. There we go. So there's a lot of things happening in data. There's tons of data coming from, all around, whether it's, electronic medical records, Internet of Things, telehealth, remote monitoring, all the omics, AI, consumer health. It's a tremendous amount of healthcare data that's being generated. And part of the problem is, what do we do with all that data? But if you actually, looked at all the data that was, generated last year, it's amazing that if you stacked it up, it's the equivalent of over 2 million miles high of stacked CD-ROMs. It's just a tremendous amount of data that's being generated. And the question is, how do we turn that data into something useful or make it an outcome that's important to the industry? So the first trend I want to talk about is sort of the movement to value-based care. And this is a really busy slide. And my point is, I'm not going to talk about everything on this slide, but I just want to point out a couple things. On my or your left, what's interesting is that half the payers and providers, are really interested in moving to value-based contracts, but we kind of see that a majority of them have actually implemented, a small amount of these contracts to date. And the reason for that really is it's not easy to do because you need analytics, technology, and people to do that. And a lot of the payers and providers don't have the infrastructure yet to fully implement these kinds of tools moving forward. And they also have concerns about, how they're going to measure outcomes. They have concerns about containing costs. And the real question is, does this actually really work? So a lot of them aren't quite sure that it works, but they feel that they need to move to this type of contracting. And again, to do this, it's really is all going to be centered around the use of data. But the key thing is really just following the money. What are the trends? And whether you're fee for service, whether you're paying individually for all these services, whether it's pre-admission, Part A, Part B, post-acute care, or readmissions, or you're moving to this value-based model where it's a fully integrated payment system, the punchline is it actually doesn't really matter at all which model you're using. Because in both models, payers use healthcare data to determine what they're going to pay for. And what that leads to is ultimately data is that currency we're going to use to transact in the future healthcare market. We've got to have data, but we have to have data in a way that can be used to drive an outcome. That's the ultimate piece of the technology that is the hardest piece to do moving forward. So I want to give you kind of an example of one company, and for full transparency, this company is in our portfolio. It's a company called Datavant. And what's interesting is they're tokenizing across 500 plus multimodal data sources in order to get a longitudinal patient data view that's not only secure, but safe. And for life science companies, this is important to us. So it can help us maybe identify, do better patient identification, better patient stratification, better drug performance. Providers can enable population health, care pathway design. Then we see payers can understand risk, fraud prevention, and value-based contracting. But the way to really think about it is just, it's a tremendous amount of structured and unstructured data that's being generated. And then, their secret sauce is how do they just take all this disparate data and turn it into something meaningful and something that each of these players in the industry can use to drive better outcomes. And again, ultimately, that's what it's about, is to drive better outcomes within the industry. But there's a lot of these type of companies. Datavant isn't the only one. And we'll get to that, in a minute of what's happening in the industry. But I want to talk a little bit about why this is really important to the pharmaceutical industry. we not only generate a tremendous amount of data through our clinical studies and all the work that we do, but we buy a lot of data as well in order to do a lot of things to help the value chain. And whether you're talking through pre-approval, post-approval, or the ecosystem infrastructure, there's a lot of use cases that pharma's interested in working on, and these are pretty universal to most pharmaceutical companies. It's not just Merck only. But the key thing is, but what's the value? And I think if you start to think about drug development, that's one of the most key areas that we're interested in the use of data, because we're trying to design and execute smarter clinical trials where we have better products, cheaper and faster approvals, and longer product lifespan. That's kind of the big piece that pharma is driving towards. So we see a lot of investments in this particular part of the space, whether it's AI for drug discovery, where we're trying to do better patient identification, patient stratification. We're trying to identify new molecules. It's probably one of the more important spaces of which data is becoming important. Market access and value, can we demonstrate the product value? That's still a common practice within pharma, whether it's patient access support or pharmacoeconomic evidence. We're still trying to drive, what that meaningful value is for the use of the product. And then we have the patient and provider experience, where we're enhancing outcomes, and whether it's expanded indications, optimizing product use, or even reduce side effects. Again, that's all based on how we look at data and how we have access to data and how we can use that data in a way that provides better value to the industry. We're moving towards precision medicine. It's still early within precision medicine, but we certainly have tools in the diagnostic market that allow us to, again, better identify patients, better identify conditions, but it also can lead to better products. And really, I think most importantly to pharma is that right patient, right place, right time concept. That's what we're driving towards. And again, this whole data concept is around establishing that. And of course, the digital infrastructure, real world evidence, real world data is the primary infrastructure of how we're going to move forward with all these value propositions across the pharma value chain. So again, when you look at this, even for our industry, again, it just shows you when we use that term, data is the currency. Without the right types of data, we can't do any of this in the right way that we want to do it. And thinking about how we move forward in the future is how we have better access, better curation, better analytics, around data and what we can do with it as an industry. So let's talk a little bit about real world data and the kind of companies that play within this space. You kind of have three different sort of offerings. You have sort of companies that are data focused, those that have more of that hybrid offering where it's more access to usable data, and then you have sort of the insight focused companies. And the way this chart works is sort of the blue dot just represents right now what one might consider leaders within these respective sort of spaces. And this is just a small sampling. This is not even close to the sheer number of companies that are playing within this space. But what you see though is working across the value chain from pre-approval to post-approval. And the most companies sit in sort of that hybrid offering space is what we've seen to date. And as I mentioned earlier, Datavant is one of our portfolio companies, but there's certainly lots of different companies that do a lot of different things across the value chain. The least kind of companies we see is sort of this insight focus only company. In reality, is the reason you see the hybrid sort of model is it allows these companies to drive the most revenue and build the most capabilities they can build. But again, I think what you're seeing is and I'll show you in a few slides sort of what's happening within the market. This RWE space is probably one of the fastest growing space in the data space, and what these companies can do, not only for our industry, but for the entire healthcare industry. So if we look at some of the business models, you kind of have three sort of business models that are out there. You got ones that focus serially on data, those that focus, only on technology, and those that focus on the services. And what's interesting is the technology only focused ones, it's kind of rare. We don't really see a lot of them. And it's really the lack of in-house staffing needed to use the technology. It's hard to find data scientists, hard to find the right people to do that kind of work. So we tend to see more on what would be your left-hand side, the data side of the type of companies, and it matches again what we saw on the previous slide, where you have then the middle group that does that more hybrid sort of approach. And then very few so far on the full service side, partly simply because there's more revenue to be generated if you're on the data side, but you still need all three of these to work. That's the key what this slide is talking about. In order to, really drive that data being the currency, you've got to have the data, the technology, and the services all combined to try to deliver what the end user wants to be delivered. And again, just an interesting number of companies that probably most of you all have seen or know. But what's kind of interesting as an investor, which I am, is what's happening within the market. There's a tremendous amount of M&A activity in this space. This is probably the space that has the largest valuations of any digital health space, the most activity that's happening. And part of it is just because there's tremendous amounts of revenue to be generated from this area. And so what we see is, lots of M&A activity. As I said earlier, we were part of Ciox, which got acquired by Datavant. That's why we're in Datavant today. We're an investor also in Trinetics today still, even though Carlyle acquired them, but we stayed in to work with Carlyle to help build the company further. And what set it all off, probably originally back in 2018 was Roche acquisition of Flatiron. And what ended up happening is the industry needed a response to what was happening with that acquisition. Pharma didn't want to be dependent only on one sort of data provider, partly because that there could be a potential breach at some point, and just having a single pharma owning that capability led to pharma then pushing for different types of companies in this space. And that's why you're seeing this proliferation of companies. And the fundraising has been unbelievable. We saw last year and maybe even the year before some outrageous valuations in a lot of the digital health space. But I think where we saw the valuations sort of be able to match the revenue and where they have held strong is within this space. And you can just see the raising that's going on in the valuation and the amount of capital raised. It takes a tremendous amount of capital to build these types of companies to do the things that they want to do. But they don't have any problem raising the capital they need to raise. And they actually do have the valuations to support the capital raise that they're doing. So what this should just tell you is, if you're an entrepreneur or an investor, this is actually an interesting space to be in. It's a good space to build companies. It's a good space to make money if you're an entrepreneur. And of course, it's a good space to make money if you're an investor like myself. But more importantly, what we're building is really good companies that service the right part of the industry and a company that's needed. One of the things that we talk about when we invest for GHI is making sure that these assets exist in the world. And it's not so much for Merck to acquire them. It's about Merck working with them and learning how to use the capabilities to make them a better company. And it's okay if our competitors use them because the secret sauce is what each of these companies do with them. But we need these types of companies to exist in the world. And that's why we invest in them. But the market's showing that, from a payer provider and pharma industry, they want these companies to exist as well. So it's a really big industry raising a lot of capital, and hopefully as these mature, providing the type of services that the industry needs and provides the outcomes that we're looking for. So that was my talk. I know we only have a couple minutes left. I didn't know if anybody had any questions for me. So I left a couple minutes for questions, and I'm next on a panel. But if anybody had any questions around this particular topic, I'm happy to answer them. Might have to come up to the mic.
Hello. Hi. I'll make them two brief questions, hopefully. One is, there seems to be a new type of startup that's starting to come into the ecosystem, a company called Seekster, another company called Pluto, where they're taking a decentralized or federated approach and pulling that data so that that way it's not stored in one place, so it's more secure. Some of them are ONC certified. Do you see that disrupting or adding on to the ecosystem as it currently exists? And then the other is there's a huge amount of privacy laws that are starting to come into play in terms of accessing data, where patients are now taking active roles and looking through consent as to how that data is being gathered. So while you have companies that are now leveraging that data and trying to build assets on top of it, you have more activism that's trying to mirror what's happening in Europe with GDPR and figure out where is that data coming, who is accessing my data, and how is it being used. Do you see that affecting the ecosystem? Thank you.
Yeah. So on the first question, I think I see it as an add-on, but one of the things we're also seeing in this industry is consolidation. No one company, does 100% of everything. And what they find is they need to fill their gaps. So I think these potential sort of add-on companies, they're not disruptive in it all. They're additive. And I think eventually they're good acquisition targets to fill in, the gaps that are missing. I think on the data privacy, I think that's always going to be an issue. I just recently did a trip to Germany. It's interesting there that, they don't even have EMRs yet there, and their data security and privacy laws are extremely strict, at least compared to what you see here. I think for a good thing, regulatory is going to help the situation. I think it's really interesting how patients take more control of their data. It's one thing to have their, access to your own data. It's another thing to understand what any of all that means and what kind of decision making you have around that. But I still think any regulatory and compliance rules around HIPAA and data security and privacy and storage is important for this industry. And interestingly enough, that's a kind of even a whole nother set of sort of investments you can make that are outside of just these sort of data companies. There's a whole host of companies that just specialize in that one area of data security, privacy, and storage. So I just look at it as the more, the better, the stricter, the better. We want to protect patient privacy and patient data, but these companies aren't going anywhere anytime soon. So they're just gonna be more regulated, I think, as time goes on. Any other questions? Nope. Okay.
Hi, Bill. I'm Rama from LockU. My question relates to the technology absorption barriers that are there in our industry. Historically, we've been a little reluctant. COVID has pushed it. Given your experience and expertise, how do you see the lay of the land out there in the future in terms of speed of technology absorption by the pharma and the life science industry?
I think it depends on, for pharma, it depends on the technology. For example, in the sort of the e-clinical space, the clinical trial space, we're slower to adopt the new technology, not because the technology doesn't work, but we have a tried and true way of doing clinical trials, and it's difficult to make that sort of switch. So I think you'll find, in that space, probably adoption is going to be a lot slower. I think in other areas, like as it relates to RWD, as it relates, to the use of technology and drug discovery, you're seeing a lot more faster adoption. In fact, we're making a lot of investments in early stage AI and drug discovery. We're still making a lot of sort of that real world evidence, real world data investments. We really haven't done much in the clinical trial space, partly because we're not sure how it's going to evolve. And again, what the adoption is. So I think it's just dependent on what the technology is and what at least pharma's viewpoint on adopting. We also see, like in the DTX market, for example, there's slow adoption so far from pharma in that space, and partly probably because it gets to the clinical trial question. We're used to doing, a double-blind, placebo-controlled clinical trial, and a lot of these DTXs don't necessarily follow that rigor, but we kind of want that rigor to happen. And so, you don't necessarily see the adoption as of yet until they maybe follow the rigor of what we're used to with the therapeutic. And then certainly, in those types of tools that, the profit pool is less than a therapeutic. So there's a lot of different reasons why you'll see adoption happening or not happening within the pharma industry. But, I think as it relates to your question, it's more of it depends on the type of technology.
Thank you.
All right, I know we have a panel to do, so I thank you very much. Appreciate your time today. I'm here all day, so if you have any other questions for me, just pull me aside. I'm happy to chat with all of you. Thank you.
We're back out there.
Yeah.
That's great, Bill. Well, thank you very much. And I think that's really on front of mind for a lot of people that are trying to create these digital technologies to help people, not just in the United States and North America, but around the world, and not just the wealthiest 1 billion, but all 8 billion people now. As we've recently found, the count has hit 8 billion mark for the number of folks living on the planet. So, and again, the importance of investing in being able to architect and create these new sustainable and scalable models for delivering affordable and accessible healthcare to people. It has several different components. And so now to talk about those will be Bill again, talking with Paxson from North Pond Ventures and Ian from Fenwick to have a little bit more detail, build a little bit more color around what's happening to build these equitable and scalable models. Bill.
Yep. Thanks, Dan. Great to see everyone. Thanks for coming out today. My name is Ian Goldstein. I'm a partner at Fenwick & West. I spend my time sort of working with venture and strategic investors, including Bill and his team at Merck, and then spend a lot of time working with digital health, life sciences, and other technology startups all around the ecosystem. So as Stan said, we're going to talk about funding, right? The funding environment has certainly changed, we'll say, over the course of the last year. And we're going to get perspective from, Bill from a strategic investor perspective, and then from Paxton from the financial VC perspective to really sort of analyze like what are they seeing in terms of market trends on the funding environment today, and what do they see on the horizon? How have terms changed? And how does that affect exit opportunities and how to think about growing your business? So I'll just start off and ask sort of maybe Paxton, when you start, because Bill, you already introduced yourself, and then we'll get right into it.
Thank you. So Paxton Major, Vice President here at North Pond Ventures. Just the maybe brief commercial on North Pond. So $2 billion under management, investing out of a $750 million vehicle. About a third of our portfolio is what we call digital health, digital life science. So we invest software, computation, data platforms, all the way from drug discovery, preclinical development, lab software, biomanufacturing, bioprocessing, clinical development. And then maybe what's most interesting today is care transformation and precision medicine. So we do the whole spectrum of life science in healthcare. Series A through Series C is really our sweet spot. Some type of product market fit, doesn't necessarily need to be revenue generating, but at least there's some inclination that there's a market for the technology. Typical investment size, $10 to $20 million. We can't go smaller, we can go earlier, we can go later. So we really do see the whole spectrum of digital health. I would say we have about 20 or so companies now in the space, 65 overall. So we also have a drug development biotech arm, as well as a tools and diagnostics arm.
Great, thanks, Paxton. Bill, anything you want to sort of add to what you already mentioned on your prior discussion?
I think everybody
All right,
kind of got my intro.
good. Well, let's jump right in. So, Bill, so how have things changed over the last 12 months from a sort of funding environment, like ecosystem perspective?
Yeah, so I think for us, one of the big things, and and certainly for a lot of our co-investors, probably the biggest thing that happened in 2022 was the amount of debt that was raised by the companies, partly because they previously raised at rounds or valuations that were rather high, and certainly trying to raise above that just wasn't going to happen, and probably weren't quite ready to do any kind of cram down or recap. And so we did a lot of debt. And of course, with that, then, happens, we're just kicking the can down the road. But I think that was the biggest trend that I saw, and a more stabilization, I think, of new investments we did, lower valuations. They started to come down, not dramatically, but certainly came down quite a bit. But I think that was the kind of probably two things I saw in this year that just changed the way we were investing. Was just, I think we did 9 follow-on investments, all were debt, of some of the follow-ons we did. And that's quite a bit of debt, not anything we typically want to do, but we're here to support the companies and keep them going. But I think we just kick the can down the road.
And is that mostly, insider convertible note rounds?
It's all insider convertible note rounds. Couple of them we did when we brought in, some new investors that wanted to just continue with debt, but 95% were all insider convertible note rounds.
Yep. Paxton seeing similar trends?
Yeah, I think we're certainly seeing similar trends. I think getting capital into new investments is very difficult right now. So we've seen a really big slowdown in terms of the number of new investments investors are making. I think the public markets have come down. There's a ton of dry powder out there, so it gives you a sense that people have really started to halt their activity. So I think there has been this look internally, a lot of investors, of how can we help our companies bridge through what everyone thinks is going to be a really difficult 2023. So you need to make sure that you have the dry powder to support your companies. They have the capital. I think there's been some cut on FTEs and pulling back burn to, again, extend runway, but ultimately you can't go too far down that road because you might threaten the asset and threaten the business. So it's been a little bit of a threading the needle of how can we reduce burn, how can we be focused, spend on what's most important while also still supporting growth and getting these businesses through 2023 into 2024.
And I'm curious, and question for both of you, do you see a distinction in those trends if you're thinking sort of later stage company versus earlier stage companies, right? Or sort of seed and A companies struggling with the same kinds of trends that, B and later companies are?
Yeah, well, I would say the earlier stage probably struggled more to raise capital. I think the more stable, we call them series C or later growth stage companies, and that's where we tend to invest more. We're probably had a little better ability to maintain a runway of cash, maybe make some, cutbacks if need be, but not at the expense of the business just because of their size. So I think at least from our portfolio viewpoint, the later stage ones did much better. And I think the earlier stage probably still are struggling to raise.
Mm-hmm.
Yeah, I might have a slightly different perspective. So I think if you look at the numbers, I think funding dollars in digital health is down something like 50% Q3 versus Q2. But the number of investments in earlier stage is down something like 10 to 15%. So, and I think Series C or later represents about 5% of the current total dollars in Q3. So I do think there's still a lot of activity in early stage companies. I think the dollar values of those raises might be slightly smaller, but I think if you're looking at a 3, 4, 5 year exit horizon, investors still have a lot of hope for this asset class and hope for the future that you can, once the markets rebound, get a reasonable exit. And I think the valuations on a lot of these later stage companies have come under fire as the markets have crashed. But to Bill's point, I think when you're in that later stage, you have a little bit more flexibility with your cost structure and your revenue to extend runway. And I think part of the data is misleading because I think a lot of these later stage deals just haven't necessarily been announced. A lot of them have been done behind closed doors, either convertible notes, insider rounds, down rounds, and they're not being announced with the same fanfare we saw in 2021, where you raised the big 100 million round, big up round, and there's a lot of excitement around it. So I do think the data is a little misleading, but I also think it tells a compelling story.
Yeah, and I would agree with that because what we certainly with our own portfolio, part of it was just trying to get through 22, 23, and we're making sure they just had enough cash to survive. There was no reason to advertise that, right?
Mm-hmm.
You just, you all agreed as an insider to put whatever you had to put in. Okay, we've at least now project out to, whatever first quarter 24, second quarter 24. You did what you needed to do to keep the company moving, and there's no reason to press release on that. To your point. Yeah.
So looking ahead towards 23, do you anticipate the headwinds easing up at some point in 23, or you think 23 is going to be sort of a tough funding environment for digital health companies to raise?
Yeah, I think the general sentiment is that 2023 is going to be hard, if not harder than 2022. I think interest rates are going to continue to rise. Inflation is now more broad-based. It's not just supply chain issues. It's not just energy. I think there's risk of recession. Growth is slowing. So I still think there are a lot of these headwinds. The IPO markets, I think, are still closed. There's something like 300 companies waiting to go public. So what does that mean for the next crop of businesses when the markets do finally open? So I do expect a lot of more difficult rounds in 2023. And again, we've had companies try to extend and push, but at some point you run into a wall and you can't extend anymore, you can't cut. And so I do think there's going to be a continued pattern here that we've seen now in the late 2022. But I still think there's a lot of dry powder, as I said, it's historic highs. So I still think there's enough out there. I think the best businesses are still getting all investors to consolidate on them. They're raising at healthy multiples, healthy rounds, clean structure. But I think there's a longer tail of businesses that are going to see a tough sledding in 2023.
Yeah.
And I would agree. I would say though, we also look at it, obviously with the debt raising, with the rising interest rates, raising debt again is probably not an option for most companies. But we also look at it we call it the dented can approach. And what it just really means is that there's a lot of great companies out there that are wonderful companies, maybe raised at a little too high of a valuation. There's actually nothing wrong with the company. And they're great companies to come in, perhaps, if you have enough dry powder to recap, work with, partners like North Pond to consolidate assets into bigger assets. So we actually look at it more as an opportunity, believe it or not. I mean, our portfolio is pretty stable for the most part, but we have a couple in there there's a day of reckoning coming. But again, we look at try to, more positively that, yeah, maybe for some of the newer rounds we're going to do, they're going to be smaller, they're going to be, maybe less valuation, but at least for our own current portfolio and current existing assets that had been funded in 22 and 23, I still think there's a wonderful opportunity to potentially come in and again, if they're willing, recap some of these companies at a slightly lower, but not a tremendously lower valuation, but get cash in them because they're really good companies, just got caught in that high valuation sort of market that is not sustainable for the P&L that they have.
Yeah, so I'm curious, maybe you could sort of share some thoughts and some guidance on how to sort of think about what that looks like, right? I think it's been a long time since we've had an environment where down rounds and recaps and other sort of creative financing structures are going to be not necessarily the norm, but more common. And so what can sort of a digital health company that, let's say, is going to be needing to raise in 23, like what kind of terms are they going to be looking for? And how should they be thinking about that kind of approach to funding?
Yeah, I think at the end of the day, a business needs capital. We always call it food and water, and you need food and water to survive. And sometimes it's hard to get food and water, but I think we've been trying to message that you need to be open to those kinds of, not necessarily down rounds, but a valuation that's more reflective of the current market dynamics, or terms that are more reflective of current market dynamics. So maybe seniority on the lick stack, or maybe you're even starting to see some liquidation preferences. Maybe in some rare case, it's participating preferreds. And on the convertible note side, maybe you're seeing a bigger discount, you're seeing higher dividends, you're seeing maybe even some warrant coverage, maybe a change in control. But I think the goal is to live to see another day, to fight another day. And I think that's the messaging, is that companies and investors need to meet in the middle, because ultimately investors are beholden to LPs and they have an expectation. And so you need certain terms to make your investment, but we're still very excited about everything that's going on in the space and we want to support these companies, but there are just sometimes discussions on how can we make these dynamics work for both parties so we can get back to the good work of building these companies.
Mm-hmm.
Yeah, I think Paxton said it, it's meet in the middle. You can't be too harsh because you might destroy the company in itself if you come in with a massive cram down and take everybody's equity. But there's lots of creative ways, whether it's preferences, it's all sorts of things you can do. A flat round is sometimes even acceptable versus even a down round if you can add, some extra incentives for the investor group. And what I would say, most investors are willing to work with the company because Paxton's right. We're all trying to build good, solid companies that have good, solid returns for their investor base. And you just have to be creative. But we're very bullish as well as Paxton is that we think there's a lot of good opportunity for new companies to be funded and current companies, if you can work with them in the right way, recap them in a way that's fair to everybody, but get them to keep going and exist in the world.
Yeah. Any tips for CEOs and executive teams on how to really sort of facilitate a good sort of board and investor dynamic in advance of one of those rounds? One of the things that I, am sort of consistently coaching my CEO clients on is exactly that. Be like, this is a time to be much more proactive about making connections and building relationships with your investor base, with your board, and making sure that they're connected to each other so that when the time comes for difficult conversations, like the relationships are strong and current. So curious what you both see. You sit on a lot of boards and you have these conversations all the time. Like what are some tips on how to make that a really effective board dynamic and investor dynamic? And what are things to watch out for?
I think one of the things is have the conversations way early. One of the things that drives me nuts, and it still happens, is you get a board call and says, "Oh, we're out of cash in 5 months," right? And it's like, well, that's not what you were showing us. We don't. That's too short of a time frame, right? You got to plan. My advice is here is let's plan well in advance with your investor group, and how we're going to talk to new investors of what is the true timing to give yourself enough time to raise the capital you need to raise. Because what ends up happening is the shorter that time frame is, the worse it gets for you. That's the problem, because now you're desperate for money, and people see that. And even your own investor base sees that. But I think the planning, and just as you said, the open conversation, but way sooner than ever expected. And I think that's probably the biggest learning lesson for me as a board member is pushing those conversations. Yeah, I know you have enough cash to last 12 months, but that 12 months is going to be on you before you know it. Let's talk now about what our next game plan is.
Yeah, I think we're giving very similar advice that funding cycles are 6 to 9 months, and it's not necessarily a full-fledged raise. Data room, you're going and talking to all the investors, but building those relationships, starting to seed the market, having conversations, and then alignment between investors and board of what are we trying to accomplish? What's an acceptable makeup of the round in the financing, so that when push comes to shove, everyone's pushing in the same direction, and you don't go to one investor and they say one thing, you go to a different board member and they say another thing, because I think that can tank a financing. And on the flip side, from an investor perspective, we're starting to make those early discussions. Is okay, maybe deal activity is slower right now. We're not making as many new investments, but there's still amazing opportunities out there. And so we want to get ahead of those funding cycles and start to build those relationships with folks, so that when they do pick their head up finally, that we're in a good position. We built that relationship. So it's not first time you're meeting us, 2-week sprint diligence, and then all of a sudden you have someone in your boardroom that you met for 2 weeks.
Yep. Another sort of piece of the puzzle that I either see sort of as a very effective piece of the puzzle, and also like the absence of it is a real problem, and that is sort of the independent director seat, right? When you have an effective independent director, that person or persons can really be tremendously valuable in sort of helping the CEO navigate and helping the investors navigate like a challenging environment. But I think too often you see either that role not being filled or not being filled effectively. And I'm curious sort of what you're seeing on your portfolio company boards. And if there are gaps in that role, like how can a company fill that role sooner rather than later?
Yeah, I think independent directors are critical. I think it's really dangerous to have that seat open. I think we've also seen where sometimes independent director might not be truly unbiased. They might be more aligned to management. They might be more aligned to the investor base, but really having someone that's there on behalf of the company, on behalf of all shareholders, and can be that unbiased mediator between sometimes two groups that have opposing views, I think is critical to navigate difficult times. So it's a big emphasis for us to have that seat filled effectively.
Yeah, I think it's important to have that independent director, but it's sometimes really hard because even the growth companies are really startup companies in a sense. And, when you're coming in, even as a new lead investor, you're negotiating for your board seat and then they've already had the established setup. And, where do you push for that independent seat, saying, okay, who loses their seat? And so it's a tough dynamic, certainly as the rounds progress further. Be interesting to see them be smart about it in the earlier rounds to have that independent seat already having been established. I'm all for them, but it's kind of funny. They're hard to get in, to be honest with you. And that's to your point about that's a dilemma as well.
Yeah, it is. So I'm curious, so pivoting towards, instead of funding, pivoting towards how the current environment sort of is going to affect exits, right? For your portfolio companies or what you're seeing out there, the companies that might have to, Bill, I think as you mentioned, might have to pivot towards a combination or an exit transaction instead of doing a financing round. How have you seen the current funding environment impact the exit environment? And how should companies be sort of thinking about positioning themselves for one of those two alternatives?
Yeah, I mean, I think, we normally exit 3 to 5 companies a year, and we did 2 this year, and everything's been pushed. Partly because the expected value of the company is not being met in the offers that we're seeing. The alternatives aren't always as great. This healthcare SPAC market has not performed to what one would have wanted, and so that maybe not always an option. The IPO market is can still be very valuable, delayed, but most companies within digital health actually exit privately. That's where your market is. And the question is, do you take the time to keep building the company by investing in it and just waiting it out until the market sort of rebounds a bit? And that's kind of the approach we're taking. Is we don't have to exit immediately on anything, and trying to invest in the company to help it grow and meet its numbers where it can maybe build back up to the type of valuation that they need is an okay move. But I can tell you, we have a couple in our portfolio that just for different reasons we'll sell them, but maybe not quite as what we wanted, but it's what the market's offering, and it's just time to get out. But we'd rather try to keep building the companies.
Again, I think totally agree. I think the goal is to build companies and get them through this current window. But I do think in some circumstances, having that dual track, being opportunistic and being open to a hungry buyer is a strong path. I still think we're seeing M&A and we're still seeing hungry buyers, and they might be circling because of the threat on valuations. And so they see an opportunity, and you're starting to see that. But ultimately the goal is to build a transformative company. And I think, Bill, you mentioned it earlier, is that there is some increasing consolidation efforts in some of these spaces of, can we combine multiple assets to strengthen their financial profile and set them up for more significant growth and an easier raise in the future. So you are in certain markets, I think you mentioned one, data is a particular one where you're seeing a lot of consolidation. I think clinical trial space is another one, where in 2021, there may have been a large swath of companies that raised, and now they're all fighting for position, but maybe together they're stronger than apart.
Yeah. So so last question, and then we'll maybe open it up for 1 or 2 questions from the audience. What do you see sort of your best CEOs, your best portfolio companies doing today, right? What 2 or 3 things do you think are really the hallmarks of like navigating the choppy waters? Like what are the best companies doing right now?
I certainly think they manage cash very well. They prioritize really well. You can't do everything, but they understand what parts of the business that they have to invest in now and what can wait. So I think they intimately understand their business. They understand their customer and the customer needs still, better. The funny thing is, just because you founded the company doesn't mean you know how to sell the product that but these companies that are doing really well kind of get all facets of managing the business, like a true, established P&L run business that, you would see on the NASDAQ or, the Fortune 500 kind of companies, even though they're much smaller, but they operate with that kind of mentality of how to survive and move forward.
And I think the one piece I might add is I think the great CEOs in our portfolio are also thinking about the company and how do you create a really exciting environment for their employees to continue to thrive and be excited about what they're doing despite maybe difficult financing environment. Because I think the most important thing for any company is the people behind it, and CEOs that can manage that and still get people excited every day is a critical piece of it.
Fantastic. Jerry, Stan, do we have time for one or two questions? No? No? I'm getting the nod. No, we don't. But so thanks, Bill. Thanks,
Thank you.
Paxton. Appreciate it.
Thank you.
So again, the lessons learned that we're picking up here are incredible, and having three experts who are at the core of this digital health reset and are looking at how to build new companies, architect new models, business models, and patient outcomes models. We're seeing now more than ever that this is happening at a faster rate than ever. Not as fast as it was 2 years ago, but again, what is the reset? It's about this new prevalence of seeing new models being built slowly but gradually and effectively, scaling carefully so that we do have sustainability in our healthcare system. One group that knows a lot about finding good models and then being able to scale them in a sustainable fashion is Startup Health. And over the last 20 years, Unity Stokes and Stephen Krein have been phenomenally successful at being able to take these models, find them first of all, and then find ways to make sure that they're incorporated into the healthcare system and support them through their venture and their ability to reach out to patients all over the country, all over the world, to help build models that are going to help not only improve the healthcare system, but also make it more affordable for patients around the world. And we're lucky enough to have Steve here with us today to talk a little bit about some of the values and some of the ethics of building and scaling models in startups today. Steve.
Hey, thank you. Yeah, all right. Good morning. It's great to see everybody today. Let's see if my clicker's working here. There we go. My presentation isn't up. If I can get it up, that'd be great. But it's great to be here with everybody. How many entrepreneurs in the audience? If you could just raise your hand if you're an entrepreneur running a startup, building a startup, want to build a startup. How many investors? Okay, excellent. Students? Industry? Excellent. Philanthropists? Any families or foundations? Excellent. Well, I'm really excited to be here. It's great to be back in real life. My name is Stephen Krein. I'm the co-founder of an organization called Startup Health that launched in 2011. And for the last 12 years, we have been building an ecosystem of entrepreneurs and innovators that are collaborating to solve the biggest health challenges in the world. I've been an entrepreneur for almost 30 years. I graduated law school in 1995 and started my first company, took it public and sold it, and got enamored by a couple of themes that we wove together to launch Startup Health. And one of those themes was the power of peer networks, the idea that entrepreneurs and innovators both need each other, but can benefit from being connected with each other, both from an emotional standpoint, support standpoint, but also access and so many other things. I was in an organization called YPO, and I saw the power of what happens when you connect entrepreneurs all over the world together in a single community. The other theme that I got exposed to early on in my entrepreneurial career was the power of entrepreneurial coaching and how powerful it is to wrap your head around the idea that a mindset of an entrepreneur and everybody that surrounds the entrepreneur, it's critical to actually support. And like any great athlete, they need coaches too. And so I got invited to join a program and learn the power of recalibrating every quarter on your mindset and your goals and your plan so that you can execute for the long term. And the third theme was the power of storytelling and narratives and the idea of using progress and setbacks
to demonstrate for other people how they might help or work with or benefit from your organization. And so watch brands and organizations tell the stories of progress, share the progress. And we wove those three themes together in 2011 to create an organization that had a mission to inspire and educate and invest in entrepreneurs who, I'm going to go back one, see if I can go back one. There we go. Invest in entrepreneurs who share a mindset, share a value system, but more importantly, share an ambition to solve the greatest health challenges of our time. And we use this health moonshot metaphor because the moon landing, while it was a really big goal in 1961 to land a man on the moon and bring him safely back, what transpired after that was that 400,000 people and 20,000 companies collaborated together for a decade to do one goal: land a man on the moon and bring him safely back. And everybody had a unique ability that they brought to the table. Each person, each organization had a job to do. And together they kept focused on the goal. And that enabled everybody to work together. And so from our standpoint, that's been the framework of this health moonshot ecosystem. Like preventing, managing, and curing diabetes can't be done alone. It needs to be done through collaboration. Destigmatizing mental health, youth mental health, and helping young teenagers get the help they need through solutions that, again, aren't going to come from any one company or any one organization. They're going to be built through collaboration. So we've established a framework to bring companies into startup health, put them into a program we call it Startup Health Academy that gives them a framework to get from the R&D stage to seed stage to early stage and growth stage. And for us, the whole framework of this Moonshot Academy and Startup Health Academy is to think about the 3 steps it takes to achieve a moonshot, from the R&D phase to seed, early, and growth. The idea is to get through commercialization and scale. We've broken down startup health into the 3 parts I mentioned were the framework of what were the underpinnings: coaching, quarterly recalibration workshops, monthly peer circles for the entrepreneurs to get together, weekly office hours, and a whole toolbox of strategic thinking tools to help them with shortcuts of thinking about how to navigate through every one of these stages: fundraising, customer development, team building. We also have built a media organization inside of Startup Health to tell these stories. We have magazines and podcasts and newsletters and events like the Startup Health Festival we had 2 weeks ago in Vegas at Health to give the entrepreneurs a stage on a regular basis. Startup Health is more like a university than an accelerator in that we bring companies through every stage and present them with and provide them with opportunities to get in front of investors, customers, and partners. And then finally, the collaboration networks that we've established to give everybody an opportunity to connect, the entrepreneurs to connect with each other, investors that are stage appropriate, seed stage, early stage, growth stage, customers and strategics, families and foundations, impact aligned people and organizations to work with these entrepreneurs. And together, all of these are about helping the entrepreneurs escape the valleys of death. The valleys of death from the lab to becoming a seed stage company, from a seed stage company to becoming an early stage company, let's call it Series A, Series B, Series C, and then finally all the way navigate to scale. From our standpoint, healthcare is a long game. It's a very complicated industry, and Startup Health has designed a community, a platform, and a program to help the entrepreneurs succeed. The 2 newest moonshots that we launched have provided us with a framework to go deep within categories. One around type 1 diabetes, which we launched earlier this year, that is going to actually have a cohort of companies going through Startup Health Academy that are just focused on type 1 diabetes innovation, preventing, managing, and curing, all of them. And then we're going to have a health equity moonshot launching in the first quarter of next year as well, to bring the underserved not into focus just at the founder level, but at the board level, the team level, and the client or customer or patient level. So from our standpoint, it's using these moonshot themes to catalyze collaboration and bring entrepreneurs and innovators and customers and partners together. The title of my talk today was really designed around this idea of digital health investing. That was what was on the agenda when I looked at it. And I kind of wanted to bring you some stats just to give you some context for not where we are in 2022 as much as where we've come since 2013. And you can see in the green, they're the first 3 quarters of every year. So you can kind of see that we've grown significantly. If you go back to 2012 and 11, it was under $1 billion, but you've seen it kind of double and multiply over the years. Clearly, COVID was an outlier year. There was a tremendous amount of investment at a feverish pace across all industries, digital health included. And it's retreated a lot this year, but it's still higher than pre-pandemic levels. And from our standpoint, the idea that there's now an established category of digital health solutions, connected devices, getting the visibility at the venture capital, at the foundation, at the family office level, very important. But I want to make sure that we focus on not just the numbers that are up here, but who are investing in these companies. There has been for decades a lot of philanthropy going towards grants and research and development. We believe, and what we think we have seen clearly, is the establishment of an industry that is willing to fund, get things out of R&D and into commercialization and scale. So when you look at a couple of the dimensions of this, one is to look global, not just here in the US, but globally. You can see, if you just look at the stats from Q3, New York was by far the largest of the regions inside of the United States, followed by San Francisco and Boston. But these are obviously signaling that you see across the board, funding is happening everywhere, innovation is happening everywhere. And when you look globally across the world, you see that companies are being started and funded everywhere. And that is why Startup Health from the very beginning has been focused on global innovation, global collaboration, global support. One of the other elements to look at is what's being funded. And some of the biggest fundings are actually in clinical workflow. And I established this theme around clinical workflow just to touch on one point, which is that the business of healthcare, right? There's a lot of innovation needed to improve the patient experience, to improve the clinical workflow, to improve everything happening at the patient level. And when you look at the companies and where they're located, you can again see this is not a regional game. That's very important because what a lot of people do is stay siloed in their region, either investing or starting companies. What we feel from the very beginning was important was breaking down the traditional silos, the regional silos, the thematic silos, and again, pushing this theme of collaboration. 2 more little quick touch points. The median deal size, while it has fallen this year, it is still higher than it's been, except for last year, in terms of median deal size and what's being funded. Again, coming back from $2 million deals to upwards of $18 million deals as a median over the last 8 or 9 years. The thing that underscores all of this, though, from my standpoint, is how we help the 450 companies in Startup Health and the 50 to 100 new companies we bring on every year, how we help them navigate markets like this, which, to be honest with you, are a great opportunity for all entrepreneurs, because what it means is we're focusing on a flight to good quality companies. And what really is behind every good quality company are great founders and entrepreneurs building those companies. And the one thing we've seen across our 450 companies that have collectively raised over $5 billion, have an enterprise value of $27 billion, and have looked at what's working and what's not working, the core values of the entrepreneurs is the single biggest indicator of success and failure. And most importantly, the most often ignored things when people look at the quality of companies. And so we have a series of different scorecards that we use to decide who's coming into Startup Health, who we're backing, who's getting supported. And one of the scorecards we have found to be incredibly valuable during these times is looking at the core values in particular of the entrepreneurs. The 5 items on the left-hand side are the 5 values that we have established, give us a good signal of the entrepreneurs that are going to succeed or not, that we want to back or not, or that they need to kind of get in zone. The first is the mindset, having a transformational mindset. It sounds like an easy thing to think about, but most entrepreneurs and oftentimes investors putting pressure on those entrepreneurs gets them focused on being transactional. So lots of entrepreneurs start out very ambitious with a clear vision of what they want to accomplish, only to find that they're getting pushed into transactional thinking. So again, keeping entrepreneurs in that transformational zone on the right side of the scorecard versus the failure zone is a very important thing, but mindset matters most. It prevents fundraisers from happening. It prevents teams from joining or teams from staying. It prevents lots of things that otherwise are preventable. The second is a really wonderful framework that I've really taken a liking to. There's a book called Anti-Fragile that talked about the difference between being resilient and anti-fragile. And the idea of being resilient is wonderful. You can get beat up, you can get so many obstacles thrown at you and you keep getting back up. But being anti-fragile is getting stronger from that chaos, from that volatility. And so we look for anti-fragile entrepreneurs, bringing in anti-fragility into the conversation, recognizing it's going to be hard and it's going to be hard for a long time. But if you recalibrate every quarter, if you recalibrate every month, if you've got a community of other entrepreneurs and partners that are supporting what you're doing, staying anti-fragile is a lot easier, and you can thrive and grow from moments like this where there's a lot of chaos and volatility in the market. The third is being batteries included. If you've ever seen me talk at HITLAB before anywhere else, I talk a lot about being batteries included, giving energy versus batteries not included, sucking energy out. And so looking for batteries included relationships across the board, your personal life and your professional life. For entrepreneurs who give energy to things, they look for boards, investors, partners who are as good during bad times as good times. And so being batteries included means being mindful of your energy and making sure that you surround yourself with other batteries included people. The fourth core value is around unique ability collaboration. I talked about that moonshot framework where everyone's got a unique ability to bring to the table, recognizing that your growth comes from unique abilities collaborating both inside your company and outside your company. And the last one I have found also to be incredibly important as you put together your seed round, as you put together A, B, C round, is to think about making sure that you're aligned with investors and partners who care about double bottom line impact. If they're only focused on financial return and they don't care about the impact you're trying to make in this sector, for our companies, we think that's dead on arrival. Because the idea of focusing on what the impact can be needs to be matched with that financial return. And so our whole model has been to keep making sure that everyone in startup health, around startup health, shares this ambition to be double bottom line impact focused. So these core values are market agnostic. And during market times like this, we find that these core values are a great moment for the entrepreneurs to recalibrate with themselves, with their partners, with their teams, with their boards. And for this, the core values of a community of entrepreneurs gives me a great deal of confidence that the entrepreneurs coming into startup health today, or they've been in startup health for 10 years, that have and share these core values will be successful in any market. And quite frankly, during this moment of time where it's one of the greatest times in history to be an entrepreneur in healthcare, for those who don't believe that, you're not going to find that batteries not included, don't have a seat at the table with the entrepreneurs that are looking for people who share that ambition and mindset. So that's a big highlight of what's going on in the market, core values, startup health, and Stan, great job to you, John, and the team on putting another great health innovation summit. Thank you very much.
Well done. Thank you. And thank you, Steve. It shows you not only how digital health has emerged over the last 10 years, really over the last 20 years, and coming out of the .com era, and then again, looking at the definition of digital health in the book, The Creative Destruction of Medicine, and talking about bringing bioinformatics and biomedical informatics together to create a digital patient, digital populations, and digital health. And that's really where the infrastructure like Startup Health and like all of the other organizations you're hearing about and learning about today has really come about, has emerged, has evolved into the kinds of impact that we're seeing and that we're studying on a regular basis at HITLAB. And a part of that infrastructure is the incentivizing and the identifying and the support and scaling of new business models, innovative business models in AI, in cancer, in digital therapeutics, and things like that, and different infrastructure that supports decentralized trials, remote patient monitoring, and these new types of business models to support patient outcomes. And what HITLAB has done in conjunction with New York City Economic Development Corporation about 6 years ago was to start something called the Breakthrough Challenge and the Breakthrough Alliance. The Breakthrough Alliance is a group of member companies that has helped smaller businesses and smaller startups gain their footing through mentorship, funding, and studies and promotion, and really making sure that the digital health ecosystem at the seed stage, at the A stage levels, have a support network within the Breakthrough Alliance. And it includes large health plans, large hospital systems, large life science companies. It includes large investment groups and venture capital companies and government agencies as a part of the Breakthrough Alliance member network. We'd love to have you join if you are interested. Either connect with me on LinkedIn or shoot us an email. But the Breakthrough Challenge is a part of the Breakthrough Alliance with the New York City EDC, and the challenge features a different call to action each semester. This semester, we focused on AI and cancer companies. And with that, now we have 4 judges, and Nico Canaris, who is the Breakthrough Alliance manager, and we'll be going through and hearing from 5 finalists who were selected by dozens of judges amongst hundreds of entrants from around the world. And we'll have 5 finalists now present their, you'll hear their pitches on a pre-recorded video, and we'll have some Q&A from the judges. And then the judges will go into a backroom session to deliberate on their winners 1, 2, and 3. And then we'll have 2 honorary mentions, and we'll go from there. So with that, I'm happy to introduce to you Nico Canaris, the Breakthrough Alliance Challenge Manager. Nico.
Hi, everyone. Thank you, Stan, for that great introduction to the Breakthrough Alliance Challenge. Again, just want to say hello. We hope you've enjoyed the summit so far and that you're excited as we are to finally have this challenge be live and in person. We do have our finalists who will be on stage virtually with us. And we have some pre-recorded pitches in which we'll present to you guys so that you can see the amazing organizations that we are working with. So again, the Breakthrough Alliance is excited to welcome the finalists today who will pitch their digital health solutions. Our finalists were chosen from over 150 applications from around the world, which were reviewed and scored by a panel of independent judges and Breakthrough board members. So I would like to take this opportunity to also thank you for all the screening judges who took time out of their days to review the numerous applications that we got in and help pick our top 5 finalists. So as Stan introduced the Breakthrough Alliance, I just would like to highlight some of the benefits of being a part of the Breakthrough Alliance. For example, fostering connections between digital health innovators and industry leaders, in addition to gaining exclusive access, investment opportunities, partnership opportunities, and working closely with our research and evaluation team to help conduct these rapid cycle evaluations for these emerging solutions and companies that we are working with. In addition to mentorship, partnership, and also gaining insights into the future of digital health techs by seeing, the results of all the studies in which we are able to conduct here at HITLAB. Okay, yes. So as I said, we had some great screening judges. Thank you to all those who are virtual right now watching. We really appreciate all of your expertise and hard work in which you put in reviewing our applications. And I would also like to welcome our 4 judges who will be judging in person while the pitches are happening. We have Zena Manji from Haleon, Jim Mago from Edge One Medical, Bill Toronto, who you saw speak before from the Merck Global Health Innovation Fund, and Sabrina Runbeck from MRG Health. So our beautiful judges. You guys are going to come down. We also would like to take this time to thank everyone at HITLAB who's put together this amazing event. It's great to see everybody in person live and be able to meet some of the people that we've been chatting with, virtually for so long. I know this is my first in-person event, and I'm so excited to be here and again to see all these lovely faces straight in front of me. So while we're getting set up with the judges, our offerings for our three top finalists. Our first place gets a research study article and presentation at a HITLAB symposium and summit, a podcast feature, in addition to a cut social media video. If you guys haven't heard any of the podcasts yet, please go and take a visit. Jerry's been doing a great job managing that. Our second place winner will receive a research study, a symposium presentation, and an article publication. And then our third place winner will receive a research study and a podcast feature. Again, all sponsored by HITLAB and the Breakthrough Alliance in order to help these startups for the future. So our fall 2022 finalists, who everyone is joining us virtually, we have Conversio Health, Eva Health, Genus Connect, Ruby Textion, and Deliberate AI. These are 5 amazing companies that we hope you enjoy in our next feature as we present our pre-recorded pitches. So once the pitches are played, our judges will have the opportunity to ask the company representatives, CEOs, founders, any questions they might have in order to further score their digital health solutions. So put it together for our 5 finalists and our great judges. So up first will be Deliberate AI.
How we do this, let me just kind of set the scene with the fact that this really is a key societal challenge. It's highly prevalent. We see this as a major public health issue. It's the leading cause of disability worldwide. It's very costly. Mental health alone is now the largest category of US healthcare spending. Now, the problem we see is that we're really relying on subjective assessments here for these disorders, and that creates issues across diagnostics, treatment, and clinical trials. So in diagnostic, we see a high degree of misdiagnosis, specifically in primary care. Often we see also late diagnosis of neurodegenerative diseases, really limiting the impact novel medications can have. In treatment, we see a trial and error approach. We really see a lack of proper outcome tracking that goes beyond patient self-reports of surveys, which very few fill out. Overall, we see limited remission and a lot of residual symptoms. And in clinical trials, we see kind of this very low approval rate, much lower than other therapeutic areas. And on top of that, the problem is that they are very likely, twice as likely to fail in phase 3. So at the end of the R&D cycle, very expensive failures. So we've put together a team that kind of comprises clinical psychology, psychiatry, computer science, to really put to the front, kind of the frontiers of science and make this more objectively measurable. My background is through lived experience. I'm the only non-doctorate here in the team, but really experiencing myself the frustration of getting a proper diagnosis, figuring out what the right treatment is, and then knowing whether it's working is something that we need to change. We're also lucky to have a couple of great advisors on the computer science side, as well as kind of psychiatry. Renee Collins, the chair of psychiatry here at Mount Sinai. And by combining their insights, we're able to tackle this problem effectively. Now, what we do, we've built Multitude, which is an AI platform that kind of currently takes in audio-visual input, and from that extracts the most comprehensive set of biomarkers. And just to visualize that, this is Jeremy, one of our senior data scientists. Using a regular Zoom call, we zoom into his face, put on facial landmarks, analyze his facial expression activities, analyze his focal characteristics. So on the right, you see a few of what are hundreds of features we're extracting. Now, what we do a little bit differently, we know these biomarkers, in contrast to other areas of medicine, are not as strongly correlated with the outcomes we care about, or are not as much explaining the variance. So what we're doing is we're applying multimodal machine learning to combine these into outcomes that are relevant. And also we're able to incorporate other signals in addition to these peripheral behavioral biomarkers using neuroimaging or blood-based biomarkers. Now, the outputs we create are what we call biomarker constellations, or AI-COAs. AI-COAs directly predicts the endpoints the FDA care about, while biomarker constellations are more objective measurements, quantified measurements of symptom constructs. The products we deliver are licensing out our platform to biopharma for biomarker discovery and phenotyping. We're pursuing our own FDA qualifications to enhance endpoints in clinical trials. And for healthcare, we provide passive measurement-based care by plugging into our system and passively monitoring progress over the course of treatment. And soon we'll be able to use this for screening and diagnostics as well. This chart shows the power of our platform. We are the world's first we've developed the world's first regression model that predicts the endpoints the FDA cares about in depression and anxiety, Hamilton depression, Hamilton anxiety, at a level that actually exceeds the reliability of human raters in trials. So this is obviously very exciting. We're pursuing a separate FDA qualification as a drug development tool for this. And once approved, this can reduce clinical trial sizes between 10 to 30%, so significant impact. The other use case, really, as I mentioned, endpoint enhancement. We're working with a rare disease company to better measure efficacy of their treatment. We've just been selected by DARPA for a suicide prevention program, and we're also working with UPMC in Pittsburgh on a large-scale, 700-scale adolescent study to better predict suicide ideation. We're working on a late-stage OCD trial to better predict who's going to be responsive to the treatment. Our platform also would allow better and more granular detection of side effects, such as tardive dyskinesia with neuroleptics. And we've just started a pilot with New York's largest healthcare system around embedding this in healthcare. And we're also working with several mental health clinics on the same across the US. We see the market upwards of $7 billion with the larger, shorter-term, near-term opportunity in clinical trials, but also in diagnostics and treatment. That was my first overview. Happy to take any questions. Thank you.
Thank you to Deliberate AI for that great presentation. So we're going to actually take 2 minutes for the judges to ask any questions they may have for Mark, who is pinned on the screen currently, regarding anything said in the presentation. So take it away, judges.
Hi, Mark. This is Zena Manji. I had a question about the validity of the tools at the multimodal analysis. Could you speak a little bit about your validation model and how far you are?
Yeah, so the graphs I showed are based on a 10-fold cross-validation. So this now includes hundreds of recordings of assessments. So the current results that we're showing actually shows our models being more reliable than what we see typically in clinical trials. And actually our anxiety model exceeds every single reliability of each single rater in our data set. So we're now, this data set has now been submitted by the FDA. We still need to add additional diversity and additional volume to it to be able to get it fully qualified, but that's where we are today.
Any other questions from the judges?
This is Jim McGough. Mark, I had a question. In terms of your first part programs or clients, are you working with some pharma right now? Can you comment on any of these publicly?
Yes, we can't necessarily name names, but we are working on a late stage trial for OCD with a medical device company. And we're currently closing 2 contracts, one with a rare disease company where we're better measuring efficacy and potentially developing a companion diagnostic, and one where this is across different indications for using our platform for better stratification.
Okay, so I think that is time for the judges' questions. Thank you guys so much. I really appreciate it. And thank you, Mark, for being present to represent Deliberate AI. Everyone, round of applause. So next up, we have Eva Health.
Good afternoon, Carl Anna here with Eva Health, and excited to talk about how we're thinking about redefining the caregiving experience for millions. And so Eva is inspired by our journey as caregiver. It takes a village to raise a child, but it also takes a village to care for elderlies, for parents. And at Eva, we know that we have gone through that experience. So if we take a macro view of what's happening from a caregiving perspective, right? Aging population, more and more, seniors are looking for that personalized, care or need more care, right? At the same time, the ratio of caregivers to patient is declining. And we can see that trend. If you look at your left-hand side, you can see that trend declining years over year. So focusing on dementia, that's crisis I just explained is even worse, right? Besides the millions of folks that are going through that journey, every year, 500,000 of families becomes, caregivers for a loved one with dementia or mild cognitive impairment. So the challenge we identified is really threefold. One is really, how do I navigate from a day to day, the challenges of caregiving? A second is, how do I pay for things? It's expensive to care for an elderly, and especially an elderly with dementia. But what are the things I need to know? What are some of the resources even available to me? And that's a challenge for a lot of families. And thirdly, it's really, how do I plan for that caregiving journey that can be lengthy, from 5 to 8 years on an average? So our solution, Eva, we're creating that ecosystem that really help the family really manage, right? By providing personalized and simplified, guidance along the journey, pay for things. So to figure out, how do I, as a family member, as a caregiver, how do I manage, my finances? How do I find resources to help me pay for things? And how do I align these resources? Thirdly, to really, plan for that future, that long journey. So from a product perspective, when we say, ecosystem, Eva, right, really, it's infusing, technology, AI, right, to help the family, through that caregiving journey, creating that companion, bring about the right resources at the community. So bring the resources that are close to the family, bring them to bear, right, to really, encapsulate, if you will, that family that's going through that journey, and create those processes, those structures to enable better care management. How do I pay for things that I mentioned? So how do we bring the right resources? How do we bring the right tool, right, to the family to better manage the financial burden that they have, as they go into that caregiving journey. From a business model perspective, it's really, kind of twofold, really like a subscription model at that early stage, from $0 to $19, and then going to our growth stage where it's really a B2B approach, where we go towards, working closely with employer-sponsored plan, etc. The market size, for dementia, it's large, right? And that's typical for healthcare. We're looking at $135 billion of total available market. So from a traction perspective, we've been working, partnering with key health system or community organization to really bring Eva to families. We've won a couple of awards and looking forward to be part of more competition and join others and bring them to our ecosystem. We have so far over 2,000 families that are on our waiting list. So looking forward to release Eva 360 and make it available. Here we are, the founders of Eva. We are, that's me, Carl and Surab. Has a cough, he can join today, part of the recording. But also besides us, we have an extended team of clinician caregivers and researchers, etc., as you can see here. So the last piece is really, would love for HITLAB to join Eva, or Eva to join HITLAB, and really creating, communities that can always, care for you. With that, thank you very much.
Thank you so much to Eva Health, and we have Sarb here to answer any questions that the judges might have for them. Whenever you guys are ready.
Hi, this is Bill Toronto. I have a question just on your platform, and you think about caregiving more holistically. For example, have you thought about eventually expanding for example, give access to clinical trials, for patients that maybe failed on a therapy or can't seem to get the right kind of treatment that they have, even for dementia. But it's more about just expanding the platform and what you're thinking about.
Absolutely. And I guess you can hear me clearly. Yeah, absolutely. That's the idea, right? It's to how do you also bring that partnership closer with the families, not just the patient, but their family members. And so it works both ways, right? The access to the clinical trials, that's one important element of it. But also there are other avenues where life sciences companies can work more closely with these families as they are going through this journey. And in the process with their consent, obviously, get access to some more holistic data that is coming in and that is being generated from a more day-to-day perspective about the evolving needs in the condition itself.
I was also curious, you said you have 2,000 patients waiting to be on board. Do you currently have any participant on your platform? And what's the barrier to onboard those 2,000 patients?
So we had done, we completed a beta trial essentially, and now we just redesigned based on that feedback. We are gearing up for that market release, so to speak. Initially, we'll be working with both some of those partners that you saw. So we are preparing for those pilots. This is actually the right time for it. We are building those partnerships in a couple of key geographies and getting up for that pilot as well. We already have some of those families eager to jump on the platform. So it's all about getting it, the final release out in the market.
Okay, and that is it for the questions. Thank you so much for being here and representing Eva Health. We really enjoyed listening to your pitch. And thank you for the wonderful questions. So next up, we have Conversio Health.
Good morning, everyone. My name is Neb Mukherjee, and I'm the Chief Growth Officer of Conversio Health. Great to be here at the summit, and definitely looking forward to giving you some context around who we are and what we do. I'll get right into it. Conversio is a 10-year-old company focused on providing care delivery around COPD asthma. I'm sure many folks here are well educated around the impact of COPD asthma and really how much of a impactful disease it is, both from a cost perspective, roughly $30,000 average cost of a hospitalization for a COPD patient, a little bit less on the asthma side. Some of this is due to either poor form that patients are taught to have when they're using their classic inhalers, lack of education, some financial barriers as well that they face given how expensive the medications can be. So we offer a all-encompass program that not only includes a care management service model, but also medications and DME as well that I can provide some further context around in just a little bit. From a customer perspective, we serve both Medicare and Medicaid patients, as well as partnering with risk-bearing providers as well. To date, we've worked with several thousands of patients, and the number's only growing year over year. To really think about our solution, it's best to kind of think about it in three components. There's the long-acting nebulizer medications itself that we deploy. So we are an in-house mail-order pharmacy. We also provide portable smart devices that I'll talk about in just a second that are helping to deliver those medications that we provide. Again, these are all nebulizer-based medications, and we're providing the portable nebulizers that deliver those medications as well to the patients. This is kind of managed by a technology platform called Conversio Connect that engages and educates those patients, also helps capture crucial patient data, and we're able to deliver virtual pulmonary rehab to patients to really help manage them, especially coming out of an acute encounter from the hospital or any other facility. Kind of wrapped around all this is our care management service model, where we employ pharmacists, respiratory therapists, health coaches, among others, to really help the patients with things like medication non-adherence, effectiveness, and of course, preventing ED and inpatient utilization. All of this to really improve critical outcomes that our partners are thinking about, whether it's on the cost side, lowering the pharmacy and medical costs, decreasing hospitalizations, increasing satisfaction, obviously that being so important now with caps in the payer and provider world. Our onboarding process begins with identifying high risk and rising risk patients that we do using AI and ML techniques. We are capturing data both from the payer and using our own data to really analyze who would be those patients that absolutely need our engagement and our medications the most. And after that, we're outreaching those folks with our care team members who invite those patients to join the program. They confirm medical history. They can conduct a health status assessment. They also evaluate medication therapy, as well as send over an optimized medication treatment plan to the provider in accordance to gold standard COPD prescribing guidelines. After the provider prescribes the medication, we then ship that corresponding medication and a welcome kit directly to the patient's home. And then immediately after getting the medications, we're engaging with the patients on an ongoing basis to ensure that they're not having any barriers to treatment, that we're answering questions, that we're getting them continuous education as well. On average, we're speaking to every patient about 13 times a year. So about 1+ touch point to every patient, which really helps on the experience point. I won't spend too much time on this slide. This is basically honing in on the fact that we are the only company in the space that provides nebulizer-based medications across every drug class within COPD asthma. You'll see here on the right there, commercially available inhalers. Mostly in every drug class, commercially available nebulizer medications. There's a couple of gaps in the market. So this kind of helps us really differentiate our ability to provide a across the breadth and depth of different patient populations who need different types of medications. All of these are provided at no cost for the member. The plans provide this without any copay to the member, so it takes away the financial barrier as well. From a portable device perspective, you see here on the left a picture of what we call SmartNeb. It's our portable nebulizer device. It's literally the size of a iPhone, actually a little bit smaller. So again, not too much bigger really than an inhaler. It is Bluetooth enabled, so allows us to capture in real time adherence data that gets populated into the Conversio Connect app. Charges for 4 hours, so you can use this for several weeks actually, given that the average speed of it's just a couple minutes, and again really helps us deliver to the patient better drug delivery, given that this is a inhaler. Ultrafine particles for optimizing lung deposition. It detects breathing as well, and there's the ease of use and being portable, very convenient for the patient. For those folks that decide that they do want to stay on the inhaler, we also provide commercially inhaler drugs as well for a small patient population who decide not to switch. We also provide a smart device for the inhaler called SmartCap that also records real-time adherence and inhaler technique. There's some noises and lights that kind of pop up. You see here on the right there, the green light that kind of identifies that the patient did the correct job of taking the inhaler as well. And can capture other types of data. It's a spirometer as well, and there's training and education that's happening, as well as the patient's kind of taking the inhaler with that SmartCap device. The Conversio Connect app, which aggregates over 300 plus devices into the app. We can aggregate data from smart watches, glucometers, scales, pulse oxes, and whatnot. We're able to do in-app messaging and video chat with the patients that our clinicians on staff do. There's virtual pulmonary rehab as well, which I'll talk about in a second. And we can also kind of share these data points with family, with caregivers, with providers and other folks as well within the care team. So really helps from an engagement perspective and care journey management perspective as well.
Thank you for your 5-minute pitch. We will have 2 minutes again for questions when Dev is pulled up on the screen. Hi, Dev. How's it going?
Hey.
If you guys have any questions for Dev.
But still want the education and whatnot. There's videos. There's
this is Jim. Question for you. Conversio, your platform, I mean, is that a combination product that you're providing both the drug delivery and a drug? Are you guys the actual manufacturer of the drug? And thus, are you registered with the FDA, or
or is it, how do you describe that situation?
Yeah, registered with the FDA. So we're a mail order pharmacy based out of California. So we're providing the drugs as well as the services and the technology that I was talking about. So combination of both the technology, the drug, and the service, kind of wrap that up in a PMPM model to the payers and the providers.
Hi, Dev. This is Zena Manji. I had a question about your analytics on demographics. Do you see a difference in success factors depending on the demographic of the patient engagement?
Yeah, I would say while we generally do work more so on the Medicare side, the Medicaid side definitely a little bit lower on the engagement averages. So like I said before, on average, we'll touch a patient 13 times a year. That average is actually both on the Medicaid and the Medicare. Obviously, the Medicaid side brings it down. But I think overall, given that the cost is such a big barrier for Medicaid patients specifically, the ability to kind of dispense drugs on an ongoing basis and keep patients on the drug over a longer period of time is something that we've been super successful with.
Okay, and that's about time for the questions. Thank you so much, Deb. Let's give one last round of applause for Conversio Health. Our next innovator will be from Genius Connect.
In the sense of purpose. What a treat to be here with you virtually. I'm a big fan of HITLAB, love the caliber of people, the ideas, and the sense of purpose. I'm excited to share an innovation with you, born from necessity, and I look forward to answering your questions. So let's begin. Wouldn't it be great if one word in 60 seconds could improve outcomes, care equity, and connected care across the continuum? And yes, it is great. We call it Genus Codes with 211411. To help visualize what we're talking about, let's dive right in to a quick example at hospital discharge. The clinician asks the patient or family caregiver to text a word like discharge to 211411. This puts in motion a series of basic reminders and videos that help them understand the discharge process, how to access the portal, order medications, and properly secure their first follow-up appointment, while also putting in place community resources. Saving the clinician time, getting the patient and family member off to a positive start leads to better outcomes, improved quality scores, and stronger community connections. We're talking about a solution that's easy for organizations to begin now, and it fits in the human workflow. Now let's take a look at the tools for improving engagements and connections. The solution is built on top of the Genus platform, a content delivery and communication system based on care physics, the science of engagement, with the functionality of social media, YouTube, WhatsApp, Zoom, and a full content management and delivery system, and a care app all bundled together. Each of the major tool sets on the platform were built on feedback, studies, and market insights from amazing partners. From our fall prevention study with the University of Michigan, we created Genus Tiles, a way of delivering interactive content, videos, PDFs, questions. And with our remote patient management partners, we created Genus Pathways, a way of organizing and streamlining content delivery based on defined needs. With Meals on Wheels, we discovered the importance of humor for daily engagement. And with our IRB study with the area agency and the local hospital, we were able to test the Genus coaching tools and our socialization program that pairs users together to watch videos, sing karaoke, and have fun. Ultimately, it was our pilot with Henry Ford's transplant group that got us to see firsthand the importance of coming up with a solution that could be onboarded by patients and the clinical staff within seconds. What we learned with the transplant group is the inspiration behind the innovation we're here to talk about today. And I want to go through this in detail. What we learned here will impact everyone watching this presentation. We had built a really cool tool to record, play, and share discharge instructions. And when it came time to roll it out, asking patients to open up their phone, go to the store, download an app, to find it, to register it, and use it was almost impossible in the real clinical workflow. As many of you can relate, asking somebody to download an app while you're watching in a hospital environment simply doesn't work. We had to find a way to take minutes and turn it into seconds. Doing so in a way that brought peace of mind for the patients and families and saved the clinical team time. As we built out the solution, we did so with scale and market connection in mind. Genus codes and 211411 can now onboard just about any device, software, service, or patient, connecting caregivers, communities, and partners in seconds. Let's take a look at exactly how this works. The number 211411 is easy to say, easy to remember, and trusted at a nationwide level. Genus codes define the goal, the needs of the partner, resources, and puts in motion meaningful interactions and content. The system is also fully interactive, and this works across the care continuum from hospital discharge through hospice, all together on the 211 network. Genus care codes and 211411 can be used in a variety of markets to onboard and engage your audiences. Organizations like the Breast Density Foundations ask their audience to text a word like check your chart to 211411 to empower their audience with meaningful resources and reminders. So let's go ahead and ask you to give it a try. Text the word HITLAB to 211411. That's HITLAB to 211411. A great way to learn more about this service and how it can be used within your market space. This innovation comes from being there. It's scalable and ready to go today, impacts the right elements on care, and it's sustainable. And we're happy to announce we just signed our first $1 million plus license. Thank you. Looking forward to your questions and some really good conversations.
Thank you, Joe, for that presentation on Genius Connect. Give a round of applause for Joe. Who we have here also. And if the judges have any questions for Joe.
Hi, Joe. This is Sabrina. I see one of the challenges from a provider side was discharge is every surgical or hospitalization, there's a different thing that people wanted to pay attention to. The instruction is going to be different. So how are you able to compensate all these varieties to make tens of thousands of videos for each hospital or each subspecialty?
So most of the organizations already have exactly what they want to put in motion at time. What the code does, and it's unique by discharge event, puts on their device the materials and the videos that they want that audience to see. It's kind of like journey mapping and saying, okay, in this case, we're sending an elderly person home who's had a fall in Boston. What is the right material that we want to put on their phone or their family's phone in the reminders we want them to see about how to make an appointment, local resources, maybe it's area agency or Meals on Wheels. You can have a generic code for a system that they can start with right away, and then modify those codes to complement the exact need that they're looking for, whether that's being used in the clinical environment in the hospital or in the field. When you're sitting there with the patient, you're looking and saying, you know what? What's great is each clinician really only needs to know a few codes that's relevant for them. And that code identifies the hospital, the unit, and the need, and begins that automatic follow-up to put that in motion. And that might be a care app that you want to put on there or a device. So it's the partner themselves already have that material. This just complements what they have, make sure it ends up on their phone and communicates the way we do today. If that answers that question.
That's actually all we have for the questions too. Thank you so much, Joe. Really appreciate it. One last round of applause. Thanks, Joe. And our next presentation will be from Rubitection.
Hello, my name is Dr. Santa Gaspard, and I'm the CEO of Rubitection and the primary inventor of its technology. I spent my PhD developing the core technology behind Rubitection with the vision of improving healthcare. Rubitection is addressing a growing global healthcare problem known as chronic wounds. More specifically, we're starting out with chronic pressure injury wounds or bed sore wounds by providing caregivers with a low-cost early detection and management tool to help save the lives of vulnerable patients like Superman, or in this case, wealthy actor Christopher Reeves, who lost his life to a severe bed sore that went all the way down to his bone. Early detection could have saved his life, and he's not alone because bed sores affect 2.3 million people every year, killing 60,000 of them needlessly. This is because if you can detect the condition early, you can prevent it from developing. However, the early diagnostic test is manual and unreliable, and it has limited utility on darker skin tones, putting people of color at over 2 times greater risk of developing the most severe case of the condition, while costing the U.S. healthcare system over $22 billion in treatment costs each year. With the primary at-risk population being the elderly, doubling to over 85 million people in the next 25 years, this is soon going to be an avalanche of costs and a huge healthcare problem for families and facilities, both of whom are actively looking for low-cost early detection and management solutions. We're addressing that need with the Ribitect assessment system. It's a patented optical device that allows any user to detect the condition at its earliest stage and monitor it as it progresses to an advanced wound. To use the technology, you first take a picture of the skin to support sizing and classification, and then use our measurement device to assess risk, vascular health, and inflammation. We then take that data and process it to develop personalized care management plans, as well as to support remote patient monitoring, allowing patients to benefit from decreased recovery time, a reduction in readmission rates, improved patient safety, a reduction in cost by over 98%, as well as the opportunity to create a new revenue stream through remote patient monitoring that can yield over $250,000 a year. Compared to our competition, we combine both early assessment tools and advanced monitoring tools into one simple device that's low cost, easy to use, and can be used in any healthcare environment, from the home to the hospital, allowing us to dominate a $4.3 billion US market, which includes sales to home care, nursing home, and hospitals, where hospitals will be our initial target market, where we will sell the product using a razor blade model. With this model, we can generate over $265,000 a year per facility. To get access to this market, we are currently focused on prototype development and pilot testing before moving on to product development and initial sales to our beta test sites, before fully launching to the broader market in 2024 with the support of strategic sales and distribution partners. With those partners, we can grow to over $240 million within 6 years of launching the product on the market. And we already have a growing pipeline of customers, which includes hospitals and nursing homes that have contacted us to either purchase a solution or clinically collaborate. We've also secured 5 letters of interest from potential corporate sales and distribution partners, validating the market and our opportunity to scale and grow. To date, we've already raised $1 million in pre-seed funding. We've used that to develop a click-through prototype of our software system, as well as a functional device of our measurement wand. Testing of our system shows that we can detect that early diagnostic biomarker with 100% accuracy. The data you're looking at is data on white skin. We can also make similar measurements on Asian skin, as well as on Black skin tones. The team behind Ribitection includes myself, I'm the CEO and founder. Dr. Hines develops our custom algorithms, and Michael Schilling supports prototype design and fabrication. We've surrounded ourselves with experts in the field, from expertise in FDA and regulation to product development and manufacturing and clinical. As a team, we're dedicated to solving this problem. When we looked at the broader impact of our solution, we realized that bed sores were just the beginning. By taking the same technology and applying it to other healthcare conditions, from diabetic foot ulcers to surgical wounds and chronic dermatological conditions, we realized we can increase our market to over $36 billion in a largely untapped skincare market to help save lives and reduce costs. So today we're raising $2 million in seed financing to support technology development and clinical testing. We're also looking to engage with care providers, corporate partners, and clinical test sites as piloting that we hope the Breakthrough Alliance can assist us with. So today I invite you to join our revolution to reimagine skincare based on data-driven analytics and to do well while doing good. Because no one should die from a bed sore. Not Superman, not anyone in your family, and not anyone in my family. Thank you.
And thank you for Rubytection for that presentation. So we have Sana here to answer any questions that the judges may have. Hi, Sana.
Hi, this is Bill. I'm curious, just because this is a new market to me, just what's the reimbursement market? So assuming you get through all your clinical trials and FDA approval, is this something that's typically been reimbursed, or you have to get reimbursement codes?
Right now, there's no reimbursement codes because it's part of nursing care. So it's an out-of-pocket expense for the facilities, but there's such a huge ROI for hospitals because it's a penalized event. So they lose Medicare payment, they have to pay out of pocket for costs, that it's a great investment for them to recoup some of that direct payment cost that they have to make.
Senator, this is Jim, and just you're selling like the devices to them, or is there going to be like a model annual subscription for support? Can you give us a little more understanding of how the revenue model will work?
Yeah, so we have, we're combining the software and the hardware together for hospitals and making recurring revenue from a disposable cover. In a home care setting, we unbundle the hardware and software, so there's a subscription model. For higher level analytics around patient care and performance and outcome, we'll have a separate either subscription or licensing model where they can get some of that data to understand how the impact of the device over years and between facilities. So it's a reimbursement or SaaS model based on the market that we're targeting at the time.
Any other questions for Sana? Great, thank you so much, and thank you for your presentation. We really appreciate it. One last round of applause for all of our presenters. So we're going to take a brief break where we have our keynote speaker, and the judges will come out and discuss who our 3 winners will be. So please help me introduce Amy West, Head of U.S. Digital Transformation and Innovation at Novo Nordisk. How are you? See me up behind you. Hi. Good afternoon, everyone. Thank you for this opportunity to have a chat with you. Again, I'm Amy West. I'm with Novo Nordisk, and I head up our digital transformation and innovation organization for the US. And just a question, I assume my slides are ready to go. And what I want to talk about today is, do I have slides? Some slides up? Just a quick question. Let's see. Jessica, just a question. Do I have my slides up? Are they available? Yeah, oh, perfect, okay. All right, so thank you. So as we're waiting for that, I'm gonna be talking a little bit about how we can unlock healthcare innovation with human-centric design, and why is that important? And really, the root of this, it all starts with a problem. And when we think about healthcare in general and chronic disease, and in my case, working for Novo Nordisk, we have a very large portfolio in diabetes, which is a serious chronic health condition. And the situation with this disease state is that I think there are close to 500,000 people in the world globally that have diabetes. And it's estimated that by 2045, almost 740 million people are going to have diabetes. But of those people that have it, only half of them have been diagnosed. Only half of them are aware they have this very serious disease. And of those people who have been diagnosed, 7 out of 10 are having a suboptimal experience and outcome in treating or trying to manage their disease state. And that also leads to premature deaths. We have over 4 million people dying from diabetes globally every year, and those numbers are going to continue to go up. And what's interesting to me is that this in and of itself is a global pandemic, if you think about it. And it's been amazing, though, over the many years, all the healthcare innovation that's gone into addressing this disease state alone, not to mention the many others that are out there.
And there's been tremendous improvement in the way we diagnose, treat, and manage diabetes. Our medications have continued to improve. Our delivery devices and systems have continued to improve. And Novo Nordisk, as an example, we're celebrating our 100 years this coming year. And we've been innovating in this space for a long time, as well as our colleagues and competitors in other pharma companies and other areas of the ecosystem. And yet with all this improvement and innovation, the problem is getting worse. And so I think it's fair to say that the elephant in the room, as we probably all know, is that medication alone isn't enough. When we think about the changing needs of in the healthcare space and what people need. And as pharma, we're just so focused on the medication, but we have to think beyond that. And that's where we see the rise of focus on emerging technologies. And I think a lot of folks in this room are involved in this space. All the amazing promise that we see with artificial intelligence, machine learning, robotics, 3D printing of organs, potentially an actual pancreas that is 3D printed and workable. The Internet of Things, voice activation technology, all of these emerging spaces show enormous promise in the healthcare space. They've been leveraged in other industries and other verticals. How can we now leverage this really cool technology and innovation in the healthcare space? But the challenge there is we also don't want to be glamorized by the shiny object. It's very easy to do that. And I see that a lot when I look at what's happening with the pharma manufacturers in particular. It's what's the cool idea? How do we apply it to our area of the business? Or how do we apply it in order to meet the needs of our customers? And you go after it and you end up creating a solution looking for a problem. We've got to really flip that, where the real elephant in the room is flipping it requires us to be truly patient-centric. And I think we all talk about it in the healthcare space, whether you're a manufacturer, a provider, a health system, a payer, we all say that we're patient-centric. But at the end of the day, we often take an inside-out approach to solving problems for our customers. We really, in order to create disruption and truly reverse the high incidence of these disease states that we're seeing, we have to take an inside-out approach and look at what is our customer's problem to solve. Be truly patient-centric. And that requires us to see the patient as a person first. And in pharma, we look at the example of Novo Nordisk. A lot of our patients have diabetes. We see you as a person with diabetes. You need to treat this. We look at the clinical biomarkers. We look at the clinical data. We look at all the things that are applying to you as a person who is sick. But that's not how any of us lives our lives. We are people. We have many interests. And the reality is, from a statistical standpoint, a majority of influencers that impact our ability to engage in our health and wellness sit outside of the clinic setting and the clinical data sets. It's all those social determinants of health considerations, the socioeconomic status that we have, our physical environment, where we live, the community in which we live, our behaviors and our motivators, all of those things that are part of everyday life that sit outside of seeing a doctor, getting your medication, dealing with being sick. And it's all of those things that we need to be focused on, because as pharma or as healthcare entities, we're only focused on that small, statistically, it's roughly 20% of influence from a clinical setting. That's really where we're focused. And we're missing the bigger picture and the bigger opportunity to understand our customers as people first and how they prefer to be understood. And so that's where this idea of true healthcare innovation is going to start with human-centric design. Design for the person, not the technology. If you design for the person and the technology follows that and fulfills it, you will create a value and a benefit for the customer that can then be shared through to your organization, your business, whatever your objective and remit is. So it is that that connectivity between solving for the customer's root cause pain point, applying the technology or the innovation to meet that need and pull it through. That's where you're going to truly develop that shared value. And there are some very traditional ways that you can approach that. Ooh, sorry, here we go. I'm a little ahead. I've just kind of been going through my presentation here. I'll stop for a second because I do think, can you go back a slide? I think this is a quote that I love to share. It's from Peter Diamandis, who is the co-founder and executive chairman of Singularity University. And I'm not sure if you're familiar with this organization or not, but it's a community of futurists. And they come together and they look at the global world wicked problems, and they try to find innovative ways to solve for these and create greater equity across the world, whether it's healthcare or energy or water or any of the deficiencies that we have globally. And I've been to a number of their programs, and their executive program is excellent. But Peter says, become enamored of the problem, not the solution. And I think that ties in very well to this need to be focused on the patient first. What is their problem to solve? Because if you start there, you're going to have a much greater opportunity to arrive at the right solution and derive the shared value that you're looking for. And again, that requires us to think about the patient as a person, and someone like Susan here in the healthcare setting, we see Susan as a person who's trying to manage her RA. And we think about her in those clinical data points. But the reality is Susan is a grandmother. She was recently widowed. She's now having to take on all the things that her husband used to do for her, managing the finances, managing the household. She's looking to downsize. It's a lot. It's overwhelming. And she's also looking to have a life. She wants to spend time with her grandchildren. She wants to be with her bridge group, and she loves to read. So she's balancing all these things, and the RA is something that she has to deal with in the background. So we have to see Susan for all of these things, not just the fact that she is someone who's been diagnosed with RA. And again, these are just the statistics around how the majority of influencers that impact your ability to engage in your health and wellness really sit outside the clinic setting. And again, the healthcare players really only focus on that very small percentage. And it just statistically, it shows the impact that you're going to have. And so again, how do we truly take that inside out approach? I'm sorry, the outside in approach, and understand our customer as a person first. And this requires us to see them through empathetic eyes, to connect with them emotionally. And there are traditional tools that we can use to get at that. So traditional market research, interviewing, ethnographic research, social listening, all of these things that can give us the insights that we need to better understand the holistic individual and not just the sick aspect of this individual. And again, if we take a human-centered design approach, tools like design thinking to solve for the problem that our customers have, what is their pain point? What do they need in order to have an outcome or a quality of life aspect that they're looking for? And then apply the different technologies or innovations or other modalities that could potentially solve for that. And if you can find a connection there where you've addressed the problem with an innovative solution, the benefit will follow for the business. And so the idea is that at the center of all of that, you find that shared value. If you start with understanding your patient as a person first, your customer as a person first, holistically, understanding their pain point, their root cause problems, solve for that, and pull it through to get that shared value for the organization. And that is how, in my experience, the importance of really unlocking the healthcare innovation. It's all about that, delivering that shared value, and it's putting the customer at the center of the solutioning. So again, I would just close with always focus on what is the problem to solve, what is our customer's problem to solve. Become enamored of that, and the solution will come to you. I don't know if there's time for questions, but we're happy to take any that you might have. You good? Oh, do we see? I think I see a hand. Yes.
Hi, thanks for the presentation. So my question is that you have mentioned the principle of people-centered care. Are there any concrete design or process you can recommend to the audience? Thank you.
Sure, thank you. So from a process standpoint, again, I think that there are tools out there. Innovation isn't something that's just coming out of the ether. There are methodologies and tools that can be used. For example, the design thinking models where you are starting with, what is the customer's problem to solve, and do some work and put some rigor around convergent and divergent thinking about what truly is that root cause pain point. And then through that process, look at what's going on in the industry today and outside of the industry to see how people have potentially applied an innovation or a technology to address a similar problem, or how something is being used in a different industry, and test those different sort of modalities against solutioning for this problem. And so these types of tools are really good to start with. And I think that there's a lot of, again, this idea of rapid test and learn is also really critical. You can do that very efficiently without spending a lot of money and get, the outcome is going to be something, it's sort of an empirical process where you learn quickly, and as you go, you adjust the direction of the potential solutioning based on what you're actually learning and the real experience that you're having. Any other questions? Okay, you good? Thank you.
Thank you to Amy. We have our finalists, our 3 winners, that we are going to have our lovely HITLAB members present with us. So for 3rd place, if everyone can just come up. So I would like to start by thanking all of our finalists, all of our judges, everybody who's helped make this project what it is. And we will announce our honorable mentions first. Our 2 honorable mentions from the challenge will be Genius Connect and Eva Health. So give them a round of applause. Thank you guys so much. So in 3rd place, presented by Rachel Figueroa, we have Conversio Health. And we're going to try and pin you guys up on the screen so that we have a nice picture all together. 2nd place will go to Ruby Tection, delivered by Greg Bauer. And in 1st place, we have Deliberate AI, presented by John Hammett. Once again, I would like to thank everybody who is involved with this project, and congratulations to our 3 winners and our 5 finalists. Thank you.
What a tremendous morning and a lot of topics covered. Again, thank you to Nico Canaris for that tremendous effort. It took about 6 months of efforts just in putting together the prizes and putting together all of the campaigns to get the word out, get the hundreds of applications in, and then go through the judging process with all the judges outside of the lab that were involved. And then obviously coordinating all of this with the program. And thank you, Amy West, really inspirational as always to hear from you and all the good work that you're doing, not just in diabetes and digital health, but in global health. So really impressed and very gracious and grateful for your time and your generosity here today. So with that, we have the long awaited lunch break. So now please do take a half hour and get to meet some of the colleagues that are here from all over the world, from Argentina to across Europe and the West Coast. And we will meet back here at 1 o'clock. Talk to you soon.
Vamos.
want to stay at the podium or do you want to walk around? Sorry, is it hard to get mic'd up? Don't mic you up. And Jared, do you have the slides? Good afternoon, Columbia University. Welcome back to the 2022 Digital Health Day and the HITLAB Innovators Summit. As you can see, we have a tremendous agenda stacked up for this afternoon, and we're excited to lead that off. And these discussions around digital transformation and making sense of digital health and its growth by presenting and by hosting and welcoming one of our favorite professors, tenured, permanent at Columbia Business School, Professor Raj Gopalan, who will talk about from an outsider standpoint, since he's not from healthcare per se, but a brilliant mind, brilliant economist, and he'll present some outside thoughts on what we can do to make healthcare better. Professor.
Thank you. Thank you. And, I know I've been slaughtered with the dreaded post-lunch session. I'll keep it short, just 15 minutes. So what am I going to do? So I'm going to talk about this company called Teladoc. I'm sure most of you know about this company. And the idea is just take a look at their valuations, maybe stress test their business model, if you will, with fundamentals, and maybe leave a few ideas on what to look for and where might this company be going. So let's start with, maybe we should just go back a little bit. Look at that stock price roller coaster, right? I mean, this was pretty common. Most companies kind of crested around, early 2021, partly because interest rates were low. When interest rates are low, discount rates are low, so valuations go up. And then, of course, things have fallen by roughly 90-odd%. So the market cap for Teladoc was roughly $4.5 billion or so when I was putting this together a couple of days back. Revenue of $2 billion. And of course, they make GAAP losses, minus $0.43 billion. And I usually like to start with the balance sheet. I'm sure lots of numbers here. People kind of maybe, if your eyes are glazing over, the way to read these balance sheets is to usually start at the bottom and then go and try and understand a couple of big numbers, right? That's what I do. So 17 billion roughly of assets. And as you can see, most of that happens to be goodwill and intangibles. What does that mean? that usually means these things have been acquired through, either an acquisition that was paid for through cash or paid for through stock. If you take those two assets out, there's not a whole lot, at least in terms of conventional assets. Now, one of the claims I want to make here is that at least 75% of that, I think, has probably gone up in smoke. And I'll try to justify what I mean by that. So let's now flip over and maybe look at the liability side. This is the liability side, not a lot in terms of liabilities, a fairly big shareholder equity number, which is mostly, as we discussed, supported by those two intangible assets, right? And if you dig deeper, again, I try and understand one or two big deals that the company entered into. So as you probably know, the two big acquisitions they made, a company called Livongo and a company called InTouch. So let's look at Livongo, for instance. They paid roughly 13.8 bill, some of it through cash, some of it through stock. This disclosure tells you what they paid for. And it turns out 12.79 of that is quote unquote goodwill. And there's some client relationships which they paid roughly $1 billion for. And you see a similar version of that deal for InTouch. So, you do some simple elementary math. Teladoc trades at 4.4 bill, revenue of roughly 2 bill. So let's say 2.1x. You apply 2.1x to the Livongo and the InTouch payments that we made. That effectively means roughly 12.5 odd billion of goodwill and intangibles probably have lost value. So it turns out in the third quarter of 2022, in this year, they've roughly written off about 9.6. So this tells you that at least around 3 bill odd probably needs to be written off as they go through this exercise. So what's the big idea here? The goodwill write-downs are fine, but the question is, when we make these acquisitions, how much are we paying for these customers? Are we hooked to making acquisitions to keep reporting revenue increases? That's the other thing to worry about. And that's what I turn to next. So this is their income statement. Revenue has gone up roughly by $938 million. We'll come back and talk about costs in a bit. And one of the guiding principles that I propose is very simple elementary economics. But as you know, sometimes common sense is not common. So just break revenue down into quantity, price, currency. Break costs down into fixed costs, meaning costs that don't change a whole lot given a certain range of volume, plus the so-called variable costs, which would mean that, if there's more activity, more volume, you have more costs. It's like elementary stuff. Having said that, figuring this out from the financial statements is not that elementary. It's actually quite complicated, partly because disclosures are not all that great. So let's start with revenue. So if you look at, say, revenue increases here, Teladoc reports two types of revenue: access revenue and visits revenue. And again, you guys are the experts, so I'm just going to propose a few hypotheses. If you think I'm out to lunch, tell me. It's good to know. So the access revenue, what's going on with that? 1.7 bill of access revenue, roughly. Revenue went up by around 810 mil. The visit revenue is up by about 30 mil. So my understanding is that this is something like the Netflix model, where you're basically selling subscriptions, and then you're also billing people when they actually come to visit your clinic or some kind of physical facility. So let's try and understand, why were they able to report 810 as revenue? So these are excerpts from the financial statements that you don't have to worry about as much. I'll just cut to the chase. So I tried constructing a simple model. It looks like they have 53.6 million members. They charge roughly $232 per month times 12. So I'm able to reconstruct the US revenue. When I tried signing up to this service, it looks like the retail membership is quite high. It's like roughly around $100 a year. So I was not able to make sense of what's going on. If the retail price is 100, why is the company only booking roughly $2.32 per month, which is roughly like $30 in annual revenue? So that's something I don't quite get. Maybe there's something else going on here. But what am I looking for? The classic idea, right? How much more can you report as revenue by either squeezing out incremental fees versus adding quantity of members. It turns out, as you can imagine, a small increase in the fee, which went up from $1.12 to $2.32, explains most of the revenue increase, because a small increase on a large base is a lot of money. And how much of this revenue increase was explained by quantity? That's relatively small, 1.8 million new customers, 232 per month, time 12 months, roughly 50 million. So what's the takeaway here? The obvious question being, how much more can you squeeze out in terms of revenue increases, right? Given competition. And revenue increases are a far more efficient way to add revenue than going and finding new customers. So they've acquired 1.8 million customers last year. If you go and look at the rate of acquisition, that's kind of falling over time, which goes back to my earlier point about Livengo and the others. If you go and buy companies, it's fantastic, except you're paying a big price to buy those companies. So how much is your organic growth versus how much is your acquired growth? More important, what kind of price are we paying for the acquired growth? Because all these goodwill and intangible write-downs, all that is too esoteric. Only the accountants kind of understand that. But in terms of plain economics, it simply means we paid a lot of money to acquire one customer. And more important, are we hooked to acquisitions to be able to report revenue growth, as opposed to maybe able to grow revenue organically. So I repeat this exercise with the visit business. Here, things get a bit opaque. I didn't quite, at least I don't feel super comfortable with what I've come up with. So they have 15.4 million visits. They reported around 254 million in visit revenue, which tells me that the average revenue per visit is roughly $16.50. When I repeat this for changes for the year, the average revenue seems to have fallen to around 7, which simply perhaps means post-COVID, people are visiting clinics much more than they used to before. So the visit revenue, by and large, seems to be a bit of a wash with the visit costs. So the way to effectively book more revenue seems to be a price increase. The question is, how viable is that? Now let's take a quick look at the costs. Again, separating fixed and variable costs is incredibly difficult. And you look at the rate of growth of costs, that's kind of going up astronomically. Advertising is up 84%, sales costs are up 63%, tech is up around 89%. So most of these companies usually sell the story that they are scale businesses. So what does a scale business mean? It's elementary economics. You spend a bunch of fixed cost, and at some point, you've created enough quote unquote network effects or tipping point or scale or whatever fancy word you want to use. And then the incremental unit that you sell is mostly contribution margin that goes into profits, meaning it's very profitable, right? I frankly haven't really seen that textbook model work well, except for maybe Facebook or something like that. But Facebook, of course, got into trouble for unrelated reasons. So what am I looking for? I'm looking for two things. Have these fixed costs somewhat stabilized, right? And are we seeing the so-called tipping point, or the idea being that if I increase sales, most of that ends up becoming profit? That's what I'm trying to look for before I try to take you into the data. So what do I see? Again, a lot of this is quite opaque. I mean, I was trying to do something very simple. Look for unit economics. How much does a member cost me? How much does a visit cost me? It was fairly hard to figure that out. But without dragging you through the details, what I came up with was the costs of a visit roughly work out to $10 a visit. The revenue worked out to roughly 16 odd a visit. Maybe there is some money being made through visits, but most of it is being made through membership. So what does it take to acquire these members? So if you go through some simple math here, I came up with roughly $1.4 odd billion of fixed costs. So that roughly tells you something about break even, right? At the very minimum, you want to pay for these fixed costs. And in my definition of fixed costs, I haven't included things like intangibles and so on. This is before tax, before capacity costs. In terms of just fixed operating costs, am I able to break even, right? So that's what I'm trying to do here. And then you can back out and work out how many more customers do you need to be able to pay for this. The other way to triangulate this data, take the stock price. So the stock price was roughly $29 a share, 166 million shares. That's how we roughly get our $4.8 billion of market cap. they have no earnings. If they did, I'd talk about that, but all this is future growth. So what does that mean for me as a CFO or as an investor? I need an EPS of roughly 3.19 per share, which multiplied by 166 million shares means I need to make $529 odd million in recurring earnings, not revenue minus cost, right? Then this becomes a little more understandable. Why? Because I have a membership base of roughly 54 million members, which means, again, common sense, I need to be able to extract $10 in post-tax income every year to be able to even justify my 4 billion valuation, which remember is roughly 5% of what it was at the peak, right? So again, a lot of this is plain common sense. I need to either increase members, or I need to squeeze more price increases from the members, or I need to cut costs. These are the only three ways in which business works. But at least it gives you a sense for the hurdle, or what do I need to do to be able to grow into my market price type analysis, which I personally find interesting and helpful, and hopefully you do as well. And the question, and this, you're better equipped to answer this question than I am, given the increasing competition in the space, is that going to happen? Can they squeeze out $10 if they were to keep all their 54 million members in post-tax income? Or can they go acquire new members? Or can they cut costs? So one way to stress test this story is to, again, look at so-called momentum. So I went and looked at the 3 quarters that have elapsed since the annual numbers came out. So this is some data from the third quarter 10Q, which is the quarterly report. So they've managed to increase members from 53.6 to 57.8 million members. That's interesting. So the rate of growth is roughly around 4 million members in the first 9 months. Prices, however, are a problem. So they've managed to squeeze out $2.60 as opposed to $2.32. So what does that mean? 28-cent increase, which is not bad, but it's still getting harder. So you're kind of hitting your resistance points in some sense in the market. So they managed to squeeze 28 cents out of every member. Visit revenue seems to have fallen, but since I don't have a good handle on visits, I'm not going to spend too much time worrying about that. The one thing that did bother me, look at ad spending. Ad spending went up by 170 mil for incremental revenue of 290 mil. What does that mean? I'm basically spending 50 cents to make $1 in revenue. You could always argue there's a lifetime value to the customer, et cetera, and I buy all that, but this is still a bit disturbing. When your revenue goes up by $1 and your ad costs to attract that revenue went up by half of that number. Steady state fixed costs, again, seem to have gone up. Initially, we'd come up with a 1.4 number. It's probably closer to like 1.7. And again, this notion of, are we scaling? Where is this so-called tipping point? It's kind of worth asking ourselves over and over again. And I know I'm running out of time. I'll just make one more point and let you be. Stock options. So this is an industry, as you know, where companies are fairly generous in giving out equity. But some of the numbers that I saw were interesting and somewhat worrisome. This share count has more than doubled. So as of 12/21, they had about 71 million shares. As of the end of third quarter 22, roughly 160 million shares. A lot of it, granted, was used for acquisitions. They bought the Livongo and so on, mostly through equity, 64 million shares. They have a whole bunch of convertible debt on their balance sheet, which makes enormous sense because you're sharing risk with the others. If the option is in the money, people convert, otherwise they don't, that's okay. That's around 10 million shares. But look at employees. They've given away roughly 4.5 million shares and 12 million more outstanding. So that's roughly 7.5% of the company. So that's something else to keep an eye on. And the accounting system in general undercounts the share compensation that gets given out. And sadly, it's the elementary law of economics. People don't value free. If you undercount something, they overuse that resource. And this is one more application of that is the share-based compensation idea. So bottom line, I've dragged you through a lot of numbers after lunch in 15 minutes. So is it worth worrying about all this? And I would say yes, regardless of who you are. Whether you're an investor, a CEO, or a board member, it's pretty important to worry about financial sustainability and at least make sure that the big picture story hangs together, makes sense. If something is too good to be true or too bad to be real, at least ask some hard questions. So that's all I had. I can go on and on, but thank you.
Thank you, sir. Well done. Again, another viewpoint and point of view from outside of healthcare to better understand what's happening inside healthcare and what we need to do as an ecosystem to improve healthcare through digital. And coming up now is Dr. Mark Zhang from an institution. It's a fairly old institution, small liberal arts college in Boston. And he will be talking a little bit more about digital health and some of the brilliant things they're doing at Harvard. Mark.
Thanks so much for having me. It's a real pleasure and a privilege to be here. Look at this. I'm going to see if this actually works. It's not a technology conversation or presentation without technical difficulties. So I'm going to just test to see if this works. Let's see here. Well, that's me. So I pressed the button and the camera went to me. Let's see if it'll go to my presentation. While this is going, I'll do a quick intro. My name is Mark Zhang. I'm a physician, a palliative care physician, and also a clinical informatician. I'm the Associate Chief Medical Information Officer for Digital Innovation at Brigham and Women's. And I lead a group called the Digital Innovation Hub. And our team is really the team that supports kind of a lot of emerging technologies in digital health for our organization. I'm really excited to kind of talk to you about one of our newer kind of efforts, which is really supporting the creation of a community for medical extended reality. So let's see if this actually works. Clicker isn't working. Yeah. This feels good though. This feels absolutely right. So as we work through this, I'll just kind of give you an overview of the iHub. So the Digital Innovation Hub really is the Center for Digital Health at Brigham and Women's. We're part of Mass General Brigham, which is a large healthcare system. It's the largest in New England with 2 academic medical centers, one being Mass General and the other being Brigham and Women's Hospital. We are part of Brigham and Women's Hospital. So this building is not the Innovation Hub. This is Hale, which is where our it's one of our newest buildings with a lot of our outpatient centers. And on the 3rd floor is where the Digital Innovation Hub is. Our team kind of functions in 4 major ways. We provide solutions delivery for the organization, custom applications, or implementing vendor solutions. We offer what we call innovation consults. For anyone at the Brigham who has an idea in digital health, we'll listen to them, give them advice, and then follow them longitudinally. And when they're ready to pilot, we'll help them pilot their project within the organization through a mechanism we call the Digital Health Innovation Group, which is essentially a collection of all the different folks who might need to be aware of a digital pilot happening in the system. And we do this on a monthly basis. We give people advice, and importantly, we give consistent advice at one time for the project. So it's been shown to really help kind of move these projects along within our organization. The 3rd and 4th thing that we do is we truly are a hub. So external companies that want to engage with Brigham, they can reach out to the iHub and we'll try and make a fit. And if there's a fit, we'll help support that work, possibly through DIG. And the 4th is we function as a true lighthouse for digital innovation for the organization. And prior to COVID, we would do events like once a quarter, partnering with groups like Y Combinator or Microsoft or other groups to do these events. Since COVID, we've had an opportunity to kind of think about how we do events moving forward. And one of the things that we also wanted to try and support, this is actually our team, we're a small team, is these new emerging technologies that are coming into healthcare where there really isn't a subject matter expert within our central organization. And how we wanted to think about this was, well, how do we become that subject matter expert when maybe someone, like there isn't one within our team? So we started this effort, we're calling it Next Up. And the Next Up kind of process, we're focused first on extended reality. is really thinking about how do we look at these emerging technologies through the lens of someone with very little subject matter expertise, but gaining that and also adding value to our organization. Why did we pick extended reality? Well, we started this about a little bit over a year ago. And at that time, we were still my team, we were still very much in a hybrid mode. We were using VR kind of for fun since we were at home anyways. And there was just all this additional talk about how the metaverse was going to happen. And, this McKinsey report came up estimating something like potentially $5 trillion worth of potential value in this. And we were thinking, well, what's the impact of this type of technology in healthcare? And none of us actually really knew. We were really just consumers of this. So as we thought about, well, how would we approach this? We kind of looked through this model. I'm a physician by training. So when I think about these things, I think about it through the lens of a physician. And there's this medical education axiom. And this is how we learn how to do procedures. It's called see one, do one, teach one. So we thought about it through this see, do, teach phase. And the first was, well, we wanted to better understand what kind of exists currently in medical XR. Is this a thing? If it is, what's the current state of art in the industry? But then critically, what we also did was we did an internal landscape scan. So, Mass General Brigham is a very big organization, powerhouse research hub. And, one of the things we wanted to better understand is, well, are people doing this? Are they researching this? Is there already a nucleus of people that are doing work in MXR? So we started with this both external and internal landscape scan. And what we actually found was internally at MGB, we found over 21 XR projects already in flight, more than $3 million of NIH funding already at our organization, 5 sites, 3 types of extended reality being researched, VR, MR, and AR, and also 2 core centers that already existed within our system. One within radiology at Mass General Hospital, the AR VR lab, and then our Stratus Center at the Brigham, which is our simulation center. And it was pretty exciting. And also what we found was that none of these groups really interacted with each other. Everyone was still very much in a silo. So with that, what we actually did was we transitioned really to this do phase, which was really started in the late spring, early summer. And with that, when we realized we had over 100 people doing work, 20 research projects and these 2 core sites, what we wanted to do was really create this community at MGB. And that's what we've really been doing since spring. And we've been doing this through a couple of things. The first is a digital community. And how we've done that is using our teams. We're a Microsoft shop at MGB, so we created a Teams channel and included everyone that we saw doing this work into one channel. And we try and moderate it and we post content. We just want to keep one central store for all these people doing this great work. We've created a newsletter that we send out monthly. And then more recently, we actually started doing in-person events. We call them XR Club. We've done 3 of them already, and we're actually doing our fourth one tomorrow. And that really is a venue for people all across MGB to come in. We'll provide food, and we'll have one researcher or a group kind of talk about their work, and then enable a time to collaborate and discuss. And it's really created a pretty incredible community. On top of that, what we've been doing is also working with our industry partners, because as I said earlier, part of this work is really talking with the industry and understanding what the current lay of the land is. And we're using XR Club as a great venue to actually have a place for industry to talk with our MGB community, and hopefully more opportunities kind of grow from there. So that's been incredibly exciting. We've actually started a transition to the teach. So this work, when I talk about it was the iHub, but also we're an academic center. So we have a lot of residents and medical students and learners that rotate through our program. And this is Dr. Eva Sheldon. She's a first-year internal medicine resident at the Brigham, prelim into derm. And she did a lot of the base work looking at what the current research was at MGB in XR. And she was able to present this, and hopefully this will be the first of many kind of publications as we transition to this teach phase. Okay, so that's what we've been doing at MGB. Well, in parallel, what I realized, I was actually just talking to some colleagues in a previous during lunch, and we were talking about just kind of the state of digital health. And when I think of digital health, I think it's an incredibly exciting place. It's kind of my job. That's what I do. But in many ways, what we're seeing are these incredible solutions where the foundations are still being built already. It's like these skyscrapers are being built, but the roads aren't there. And it's doubly that for medical XR, this emerging technology where it's still pretty early, and a lot of these very fundamental things, like how do you actually deploy these types of headsets at scale in a safe, reliable way? What is the verified MDM solution? There are a few external ones, third-party ones, but there isn't like a standard pathway to kind of deploy these tools. So how do you do that? And what are just like some of these terminologies? No one's really kind of standardized that either. And what we found is that there actually isn't a medical society during our kind of C phase. There's no medical society for this work, even though we saw externally that there were quite a few researchers and clinicians across the United States and the world doing this work. So as part of our effort at MGB, we also created the American Medical Extended Reality Association. It is the medical society for MXR. It is officially 7 weeks old, so congratulations. And thanks. Thanks. And our goal is really to help kind of advance the entire field. So our mission, this is actually something that some of our original founders, and it's not just at the Brigham, it's actually a group across the United States, and actually we have a couple international members now. And we're really trying to advance the science and practice of medical extended reality through care delivery, scientific investigation, innovation, education, advocacy, and community. And it's a really exciting time. What is our vision? Well, you know, over the past year, what I've realized doing this work is that, you know, what first started as kind of a fun tool to kind of pass the time during our hybrid work sessions, really, I've become convinced that XR, extended reality, the umbrella for VR, MR, and AR, is truly going to happen at some point. You know, it's just a matter of when. And it's only a hop, skip, and a leap to say that if it's going to happen just in general, there clearly will be impacts, and there already are in medicine. So because of that, what we want to do is we want to create this 21st century medical society to help kind of shape that and help move it forward. And I think it's an incredibly exciting time for technologies like this. So I'll stop, but what I'll just kind of say is we are 7 weeks old. We're still kind of figuring this out. So if there's interest, one of our core principles is that we're an interprofessional, interdisciplinary, inclusive organization. So it's not just for physicians. We really want to try and make this work. And if you're interested, please think about joining. With that, I'll kind of stop and thank you.
Well done. Yeah, thank you, sir. So again, Mark, thank you for that very informative presentation on your research and your work that you're doing. And again, the area of clinical informatics and digital health and how clinical informatics helps to support this idea of the digital human and digital populations is critical. And we're seeing better technologies, more disruptive technologies than ever before in that area. And next up, we have HITLAB's own Lisa Crimes with Shay Reed from FFF to talk a little bit more about disruptive technologies in life sciences. Shay.
Or the clicker. Awesome. Well, Stan just introduced you, but Shay, I'm very excited to hear about this. Presentation title is the best, right? What are you waiting for? So what are you waiting for? Tell us about FFF and what's going on there.
Yeah, so Patrick did a great job of introducing the company this morning, and we're our core business is distribution. We're the supply chain and logistics experts within our industry, and I thought it would be appropriate. There we go. Too far. If you go back to 1991, that was somewhat of a pivotal point in human history, at least in my opinion. It was a point before, the most rapid development of innovation in our history had occurred. In 1991, Van Halen, so I'm kind of dating myself a little bit here. This was like the it band of the 80s, came out with a song named Right Now. And part of the lyrics of that song was, what are you waiting for? Right now, it means everything. And the same thing in 1991, another unique thing that happened, that was the year that the internet became commercially available with unrestricted use. And for a lot of industries, take fast moving consumer goods, they started focusing on that right now moment. The right now moment when you and I, as consumers, were at the register and we purchased one of the gadgets, a tube of toothpaste, and it immediately recorded the sale of that merchandise and sent upstream messages back to distributors, back to manufacturers that one had just been bought in the supply chain and it needed to be replenished. And it began this innovation and allowed many industries to start taking advantage of the new technology and how they could manage inventory differently and making sure that inventory was placed at the right place where it was being used for the right consumers. Pharma was a little bit different. When you look at the pharmaceutical industry and you look at compare it to the technology and innovation that happened, pharma was very much on the same type of uptrend with all of the new drugs that were being introduced in the 80s and especially the 90s and late 90s with the blockbuster drugs that came on board. You saw, the 80s had a total of about $12 billion of total pharmaceutical revenue, escalating to $40 billion in the 1990s, and then peaked at 122 in 1 year, 122 billion in 2000 and escalated to 2005. Again, great innovations for us as patients and having new drugs on the market. But from a supply chain and logistics standpoint, it created a situation that was basically the right opportunity for bad actors to come in. And because of that, in 2005, Catherine Eben wrote a book that really highlighted what had happened in the industry, particularly from the supply chain and logistics side, with these bad actors coming in and basically introducing counterfeit product. The name of the game was buying low and selling high. And in 2005, the industry and the regulators had to correct that. And literally the industry went from thousands of distributors down to very few. And with that, a lot of focus in the innovation of the industry was placed on anti-counterfeit measures from 2005 forward. But we never really came back to that place as logistics and experts in asking that question about right now. And the right now in our industry is the patient. When the patient is there with the provider and making sure that the provider has the drugs, has the medical devices that's readily available for the patient need. And that's where we've came back to focus at FFF Enterprises through our right now inventory technologies, is making sure that the provider always has what's needed for the patient from a product and a pharmaceutical standpoint. The technology that we've created is basically, it's a cloud ecosystem built on Google Cloud. That is the backbone and the brains of our technology that connects many different devices that are deployed to our customers' locations, that manages, monitors inventory, ensures that the product is kept to temperature, communicates in real time back to us. Again, real time being the right now moment, and also provides immediate information back to distributors, us, when the product needs to be restocked. And also we've architected the technology so that we can also do the right thing and make that real-time information available to our manufacturing partners. We have a couple of different technologies, and as we went through this cycle of development, we focused on one. We had some legacy technology that started with RFID, but making sure that the technology that we built was configurable and scalable and the right fit for the different physicians' offices and pharmacies where it may reside. We have in the demo room, we have two different types of new technology. One is our Flex model, which is a space-saving solution meant for a non-acute area that has maybe a couple of drugs that might be with the Right Now inventory program. And then also we have a secure model, which you can also see. And the secure model is a highly configurable machine. It doesn't require any type of modification to our manufacturer's product prior to going into the technology. It's configurable so that it can have a refrigerated zone or an ambient zone. And again, it works to facilitate the workflow of the provider so that they can do what they're the experts on and taking care of the patient, and leave it to us as a logistics expert to make sure that we're managing and automatically restocking the inventory.
That's awesome. So we can actually see the demo of the devices here too, is what you're saying?
Yeah,
too. So-
absolutely. We have some set up in the back. We'll be happy to show them. My partner, Brad Foltz, or I will be glad to talk with you.
That's awesome. Well, I have just a couple of questions around that. It's fascinating to hear this and how it all comes together too. But so how would this concept benefit more of a pharmaceutical manufacturer beyond what the distributors are providing today?
So again, we've architected the technology for that right now moment.
Yeah.
To my knowledge, there's not another distributor that has technology in place that can communicate back to the manufacturer that there has been real-time usage of your product at a certain facility by a certain provider. And again, I think that the industry is going to be able to do many different things in better managing inventory and inventory placement, which will be a benefit to the manufacturer because they won't need as much inventory in the system. Plus, they'll know more about the usage of the product.
That's great. And how is this technology and service typically funded?
So the way that we've architected the technology, and a lot of technology providers, when you start developing technology, maybe look at a single source of revenue or margin. We believe the technology that we've built provides value to several different parties. One, the provider. Providers, and there's probably many in the audience that can verify this, they want to take care of the patients.
Yeah.
Their expertise are taking care of patients, not managing inventory. We provide value to the providers by managing the inventory, providing immediate restocking notification or automated restocking so that they don't have to worry about having inventory in place. We're basically supplementing FTEs on their part. So there's value where we can extract margin for ourselves and benefit revenue for that service to the provider, but not relying solely on that, because we also want to be able to provide value back to the manufacturer through the information and data. Someone said earlier in one of the presentations, data is the new commerce, and we believe that real-time data is an even better commerce.
It means everything?
It means everything.
That's awesome. Well, I know we had a short chat here today, so I don't know if there's an opportunity for questions, if we even have time for that. And if not, then that means you've said everything. That's awesome. Thank you, Shay.
Thank
This
you.
is so great to hear more, and I appreciate getting to chat with you.
Thank you.
And so in looking at what's been paid for the digital health disruptions that are now going from really rapid deployment and rapid usage during the pandemic, we're seeing more of a paced and cadent flow of digital health disruptions, like what we just saw from Shay in Lisa's interview. And we're seeing that as well in some other areas that have taken hold during the last 5 years. As controversial as certainly Bitcoin and blockchain have become over the last few weeks with some of the news headlines that you read, we're still looking at blockchain as the most secure effort right now to maintain data secrecy, data privacy. And so with that, we're really happy to have a couple of folks who are global experts in this field of healthcare blockchain that happen to be in the tri-state area. And we're going to hear a little bit about this. And again, if you have questions, just step up to the mics that are in the front of the theater and we'd be happy to take those. But we want to make sure that as much as there's a lot of controversy right now around blockchain, we do want to make sure that we're looking at the latest evidence of blockchain in healthcare, what is actually being adopted, what is actually being used, because we know that there are use cases where people are using blockchain successfully in life sciences, in clinical trials, in some healthcare data warehousing. And so the more we learn how to use it appropriately and when to use it appropriately, the better off we're going to be. And so next is Rama Rao and Alex Kahana to talk a lot about blockchain in healthcare. Thank you.
Yeah, good afternoon, everyone. We're really delighted to be over here and want to thank HITLAB and the entire team for this opportunity to be with you. And what we hope to do is demystify some of the issues associated with blockchain, at the same time, reinforce the importance of it in the healthcare world, especially in clinical trials. Yeah. I have Dr. Kahana with me. I've been running BlockCube, which is one of the few pioneers in the area of clinical trial software. And for those cognoscenti over here, we're putting rails for Web3 in the future. But just like one wants to run the New York Marathon, there's no point talking about it when you are basically running 100 yards. And that's what we're trying to do and get that right now. I have Dr. Kahana. So how we'll start is I'd like Dr. Kahana to introduce himself. And because I might go well over the allotted time if I have to start the introductions. Dr. Kahana.
Well, thank you so much. And thank you, HITLAB, for having me. And thank you for being in this session. I'm a pain physician by training. I've always been interested in technology integration in the clinical workflow. And I got exquisitely interested in blockchain and decentralized technologies back in 2013. Took me about, I would say, 2 years to understand it, then wrote a book about it, became an industry leader, which landed me a position at the United Nations as an expert for healthcare and blockchain. And I've been finding myself actually helping countries, mostly in emerging economies in Africa and in Latin America, I would say leapfrogging from Web 1 to Web 3 technologies.
Thanks, Alex. So in the recent past, there's been a lot of talk, as Stan said in the morning, about decentralized clinical trials, the famous DCT, the acronym. Given your experience and expertise, what do you see what DCT is and isn't in today's world?
Well, I think that one of the things that COVID did to us is that we realized whatever we call this, both in healthcare and in life science, this is not working. Be it supply chain and figure out how many hand sanitizers we need or how much toilet paper is missing, all the way to understanding, clinical trials and accelerating drug discovery. And so this idea of virtualization, using telehealth, doing things remotely from home, be it education, shopping, became almost natural that, hey, why don't we also do remote clinical trials? And with the hope that that would be more inclusive, easier, there are some technological adaptations that need to be done and we can leverage upon them. It's unfortunate that it's called decentralized because maybe it's decentralized from a perspective of the process itself, but really what decentralization is about the organization, management, and governance of the data. Because what people call DCT is just virtual, remote, at home, or at facility clinical trial, which is not bad, but it's not decentralized. And what is decentralized in my head, and I'll finish with this, is that the problem of centralization is that it is attack vulnerable, sensor vulnerable, and collusion vulnerable. So we saw states, for example, that don't report exactly COVID. We saw different agencies manipulate numbers. That is the danger when things are done behind closed doors when they're centralized. Decentralization of that, be it permissioned or completely permissionless, where anybody and everybody can see it, that is a different game, which makes it, of course, hack resistant, collusion and assessment resistant. And that's what decentralization means. And to that matter, Blockcube and other companies that are working with that type of tech stack are offering this type of data management.
So let me get to the elephant in the room, which is FTX. So given you're a blockchain expert also, what are your views on the FTX saga and its implication for blockchain in healthcare?
Yeah, what can I say? I think I wrote in one of my LinkedIn posts, and I all, you're all invited to look at my LinkedIn posts, that, this type of fraud does not basically mean that crypto or blockchain is fraudulent. Fraud is fraud is fraud. I think that it is extremely unfortunate because 99 or 98.9% of people don't know what blockchain is. And now because of this story, now they think, okay, blockchain is SBF, and it's called kind of like a cesspool that reminds us of 2008, which really puts a big shadow on all the work that we've been doing since. I think that there's nothing crypto or blockchain specific to what FTX did, and we can have a separate conversation. I don't want to waste too much time on that. The reason why everybody knows it is because blockchain is transparent. So people can look on chain and see what happened, and that things are found in real life. Anybody who goes after crypto Twitter knows in real time who's stealing money, whereas when it happens with banksters, nobody knows what happens, behind the scenes in our illustrious bank and financial system. So I think that it is unfortunate because it has created a reputational damage. The good thing about it is it'll increase the interest and scrutiny of regulation. I hope that the regulation will be permissive and not prohibitive, like in other countries like Switzerland or the UK, where they create sandbox to experiment. And I would like you to think of it more as an emerging technology with new types of business models. Now we can think of new ways, because we're in this world where data is the asset, to do things in a different way as opposed to what we're doing right now.
Kind of makes sense, a lot of sense. And there have been people, I think, for example, the Wall Street Journal had an article on FTX very similar to what you talked about, which is you need to delink the two and look at it as a fraud in a fraud sense, more than the blockchain related.
I just think that, like things, nobody knew about the metaverse until Zuckerberg said Meta. But his vision of Meta is antithetical to what the world of the metaverse is trying to design, just as much as what SBF did is antithetical to what we're trying to build with decentralized finance, decentralized health, and the use cases in health that we do these decentralized technologies.
And that's an interesting point, and that takes me to my other question relating to Web3. So that's considered another area of growth. And how would you see Web3 from a layman's perspective, and how would that help? Or how would we be able to apply it in the area of healthcare for diversity or equity, in healthcare?
Yeah, the problem with these things is that these are technical terms that are described by technologists. And I find it, as a non-technologist myself, to kind of understand what it is. So the explanation I explained, the explanation I gave myself, what is Web3, is what is the number that comes after a web? So, there's the real world, we're here now, and then there's the digital world, all the signals that now we're procuring, including the recording of our talk. In Web 1.1 that started in the 90s, we were just passive, we looked at it. So the computer was the digital representation of, I don't know, the Wall Street Journal, the New York Times. It was static, there was nothing, it was read only. Web 2, which we live now, is read and write. So we're a little bit more interactive. We're uploading, we're downloading, we're posting, we're microblogging. The problem is that the data belongs to the platforms that we use. And so they are owning the data, they're owning my activity, they're not paying me anything, or if they're paying me, it's a fraction of its value. And so Web3, to that extension, is that I'm being part of it. And so we see it either in blockchain, where data becomes a digital asset that we call token, and then I own part of the internet, which is kind of pretty cool to say, oh, okay, so the data I gave 23andMe actually, you know, belongs to me, so I should get royalties from it. But also in the sense of the metaverse, where we're moving into the realm of the phygital, with, you know, we have the extended realities or immersive technologies, where I'm here, but I'm not here, and transported into that world where the computer or the desktop or the mobile or the internet is the portal into that digital world. Web 4, in that, if we follow that logic, Web 4 would be, I'm actually inside the internet, you know, using brain computer interface. I'm just thinking about it. I'm already in a little bit kind of like Matrix, and Web 5, if you wish, I am the internet, and be Elon Musk and I'm the simulation. But I would say that Web 3 is really the more inclusive. I'm not the product of all these platforms. I actually am in a creator economy. I have value, and I receive monetary and non-monetary rewards for the creation.
And how would you see that being applied to the world for diversity and equity?
Well, I think that is the most important question, because the current model, by its design of centralization, is extractive, exploitative, and extractionary. So all these diverse populations are vulnerable populations. We see them in the emerging markets. They're unbanked, they're underbanked. They don't participate in the economic activity that most of us participate in. So this is actually their vehicle of being inclusive, their vehicle to be part of that creator economy, and not say, well, because you don't have enough credit score, or because of you're not from the right ancestry, you can't come into this economic club we live in.
So that takes me now into something more specific. And what are your thoughts in terms of seeing the implication of these technologies in, let's say, rare diseases, for example, where you might have a genetic abnormality in only 9 cases all over the world, or 50 cases or 30 cases, or even more specifically in oncology or neurology, given your medical background?
So I want to divide this, my answer, into two. I'll preface by stating that, first of all, the use cases of decentralized technologies and distributed ledger technology like blockchain, but also federated learning and you know, privacy preserving technologies, from easy to hard would be supply chain, that everybody understands. This real-time demand only, I don't have any buffer kind of changes. The next would be, I would say, identity, self-sovereign identity, credentialing, verifiable credentialing, this movement of professionals from state to state, from country to country, very powerful things that are happening in the United Nations, in the World Food Program, in the WHO. Decentralized clinical trials, again, when it comes to automating and improving operations, that's an easy sell. But when it changes the business model fundamentally, that needs adoption. The next one would be electronic health records, which is really the hot ticket, because that's where all the data sits. And then, of course, for me, what is called DAO, decentralized autonomous organizations, which is a fancy way of saying that is the digital community that you live in. And that is where the second part of the question is, so what does it do for rare diseases and also and oncologics and expensive, you know, treatments that have very small communities? So it changes the way we interact with each other, and it changes the way we fund it. And why do we need to change it? Because if today I'm in a Facebook group, or I'm in Reddit, or I don't know what, the moderator can just shut me off. Whereas in this type of decentralized community, you have that voice, and you have rules of how to behave and not to behave. So
then let me go to my last question. And given the end users that you're seeing, and companies like Blockcube or other companies, how do you see the canvas? How do you see people applying this in real life today?
Well, first of all, I want to congratulate you because, you woke up before everybody else, everybody's waking up now. It's 8 o'clock in the morning. You're what, since 4 o'clock in the morning doing stuff. So you've built and it's waiting and it's ready. So now it's really doing these educational efforts to try to cut through the noise, to try to understand that DCT, what you're saying is not what DCT is. So what is it? Is it crypto? No, it's not crypto, it's blockchain, but it's blockchain. I'm hearing. So there's a lot of education, a lot of information that and various degrees of veracity. And so I see that it'll be more of an evolution rather than a revolution, of a transition from maybe a Web 2, we're now 2.5, to a Web 3. And so that I think I always imagine myself, we're going to be here in 2032 and say, can you remember that in 2022 we were actually, this is how we did it, and this is how we paid for drugs, and users were not considered as early investors through tokens in the drugs that they help promote. So just like when I started being involved in technology, we were called the, what was it? The information superhighways. Like, what the hell is that? And we don't call it anymore. We will have different terminologies, and we will remember these times with a lot of fondness.
Thanks, Alex. Really appreciate that. Do we have, let me check, do we have time for any questions? Otherwise, we'll take questions. One question. Yes, sir.
Be gentle.
So kind of a follow-up question. So is it a use case if you don't own the community, or you don't have control or even influence over the community? Does the entire community have to participate in order to have a use case that's of any value?
So that's a great question. And I would say that there are no communities that are alike. And some communities are more engaged and other communities are less engaged. The point of this type of digitizing the community is to value a lot of activity that currently is not captured, and to promote or incentivize positive behavior and disincentivize poor behavior. So if we take, let's say that we have now the HITLAB group of listeners to this innovative summit. Okay, there's a lot of creative content here. Now, what's the business case for doing this? Just doing this because we want to learn, because we want to share, because we're nice people. That's very hard to capture, and it's very hard to value it. But if we would have, for example, a token, we'd use a stand token. And if you would say, okay, this was a great talk, we get a lot of tokens, or you would participate and ask a lot of questions and you would get a lot of tokens. It would give us a sense of the exchange of the value of the activity that we're doing anyway.
Very good. Thanks.
Well, I think that's all the time that we have. Thank you so much for your attention. Appreciate it.
Thank you, Tori.
Thank you.
She's a powerhouse.
Appreciate it.
Go to Tori.
Yeah. Thanks, Tori.
Nice job, guys.
Okay, great talk on blockchain. And now we're going to talk about in blockchain and clinical trials. And now we're going to talk about clinical trials in retail pharmacy. And with me today is a very impressive executive from Walgreens, Namita Tandon, who is the Chief Clinical Trials Officer at Walgreens and is starting an entrepreneurial venture there on how Walgreens is going to accelerate the adoption of clinical trials in retail pharmacies. Namita, this is an ambitious program. Tell us first a little bit about yourself and your journey.
It's great. Good afternoon, everybody, and thank you for having me and having Walgreens, talk to you all about our story. I joined about a year ago, and it's a new role that was appointed by Roz Brewer. Our new CEO joined us about 18 months ago. And I'm not sure how much you guys have been watching Walgreens, but we recently announced our move into healthcare. And we've made some significant investments and bets, as we develop our own healthcare continuum in primary care, specialty health, as well as home health care. And part of our journey is, how do we start to leverage the pharmacies and our physical footprint to deliver healthcare services in our local communities? And so I joined as part of this journey as the Chief Clinical Trials Officer to really bring and build out a brand new clinical trials business within Walgreens, leverage our physical footprint, leverage our the assets and the investments that we made, and really start to bring trials within our local communities. And we'll talk more about that. But I've spent about 30 years in the life science space between academia, pharma, CROs, as well as in a startup on the data side. So I've seen the good, bad, and ugly when it comes to clinical trials. And we're here to disrupt in how we deliver clinical trials to our patients in our local communities.
That's impressive. And when you're talking about bringing clinical trials to the communities, dive into that a little bit more. Let's double click on that model and why you think, as a clinical trials executive for many years, and really impressive background with everything you've done in clinical trials over the last 10 years, what would you say is going to be the most impactful effort that this will change, and how this will change clinical trials in the future?
Yeah, let me just step back a little bit. From a Walgreens perspective, we've got 9,000 stores and pharmacies across the US. We service about 150 million lives that visit our stores and pharmacies for a variety of reasons, whether it's retail or picking up their scripts. 75% of the US population is within 5 miles of a Walgreens. And so, during the COVID-19 pandemic, we learned a lot. Collectively, the retail pharmacies administered over 270 million vaccinations across the US during a time that was a healthcare crisis, right? So, we rose to the challenge, and it wasn't a one-size-fits-all strategy across our communities in the US. It wasn't a media campaign that drove people to go get their vaccinations and come to their pharmacies. There was a lot of grassroots efforts. There was a lot of community engagement and activation, and really getting consumers and patients educated and empowered to understand the benefits of vaccination, because there was tremendous amount of vaccine hesitation, within these communities, particularly in communities that are under-supported or communities of color. And so we learned a lot during the COVID-19 pandemic. But we also learned that if we spend the time to, activate and work within these communities, we start to break down some of the barriers that exist within these communities, particularly around travel, medical literacy, digital health literacy. I mean, and you go down to the Deep South or in the rural parts of America, there's a lot of variations in how consumers and patients view health. So if you think about that same framework from a clinical trials perspective, is we know that when patients are asked to participate, there's a lot of barriers for participation. Less than 5% of the US population participates in clinical trials. And of that cohort, 75% are white. So no matter how much work we've done, including myself in clinical trials, whether it's bringing technology or, looking at different engagement modalities, digital, what have you, we still haven't moved the needle around access and diversity and equity. So from our perspective is, how do we use our physical footprint, our 9,000 stores and pharmacies across the US? Today, we've got about 200 stores that have been converted as healthcare destinations, where we're delivering healthcare services like screening, diagnostic, and phlebotomy services. We're going to continue to scale and build that roadmap of the types of services that we're going to deliver. But ultimately, it's about hyper-personalizing and making it convenient for patients and consumers to go into their local Walgreens, get the services they need, but ultimately close care gaps. And from a clinical trials perspective, it's the same. Imagine, having their patients to go into the Walgreens locations and having a clinical trial visit completed. It makes it easier. It makes it convenient. We're not here to disrupt the current provider-patient relationship. We recognize patients have to be seen by their providers, have to be seen at AMCs or other healthcare systems. But we also know that retention of patients in trials is a big issue. And so there's a symbiotic relationship that we're developing with many healthcare systems and partners that we have within Walgreens, whereby patients can go be seen at their healthcare system for, complicated visits. But from a follow-up perspective, if they've got to get some simple follow-up visits like, blood draws or qualitative or quantitative types of activities, they can come into a local pharmacy location, have that dialogue with their local pharmacist, and to be able to have that visit completed.
And so when we're looking at patient centricity and we're looking at these equations around patient and physician relationship, clinical trial, principal investigator relationship, what's the future of this look like? Is it looking like 9,000 stores will be clinical trial sites, or will it be some other hybrid version of that?
Good question. I mean, today we've got about of the 200 healthcare destinations that we've converted at Walgreens, and we continue to scale. I think by 2025, we want about 1,000. Today we've got 12 clinical trial centers that have been set up across 5 geographic markets in the US. Our goal by the end of this year is to have about 50. But certainly as we are working closely with manufacturers, drug developers that are looking at ways to decentralize, if I can use that word, I think it changes by definition, but how do we make trials more convenient as we go into local communities? We listen to their needs, and every pharmaceutical company is very different in terms of where they want their trials completed, but more importantly, folks are looking at geographic markets that are highly diverse in populations, are looking at areas like the Deep South or in the Midwest, where it's been a challenge to tap into those patient populations in the past. And so, that's one mode for us at Walgreens, is to be able to leverage that physical footprint, have the local pharmacist work closely with the patient and with the provider, because we want that relationship to be cemented with the physician and the pharmacist to be able to work together and close those care gaps for that patient. The other pieces that we're putting in place, we understand that some patients populations are a bit more savvier, so we're allowing for the digitization of the clinical trial workflow. So telehealth, where states are going to be allowing us to be able to have the patient and the provider engage and complete some of the visits that way. And then certainly with our acquisitions in home healthcare, we have the ability to deliver clinical trial visits and healthcare services at patients' homes too. So we're providing a flexible set of options depending on the types of patient populations that we're looking at for a specific clinical trial. But the idea is to make it convenient and personalized as we support that clinical trial workflow.
It really does support the workflow. It also, and again, if there's questions, it's just fantastic to have Naveed here today, considering how revolutionary and disruptive the model could be going forward. If you have questions, there are 2 mics at the front of the theater. Please feel free to just stand up and we'll recognize you right away. But diversity, equity, inclusion, it's a major theme of this meeting this week. And when you look at this model and its ability to really help enhance that to communities in need, to communities that are remote, that are far away from academic medical centers and super specialty centers. Talk a little bit about your vision and how this new model can really enhance the DEI equation in America.
Yeah, I mean, look, I've spent a lion's share of my career, looking at ways to find different, patient engagement modalities. How do we tap into patients that have never been tapped into before? Those that have been working in clinical trials, understand there's provider fatigue, there's patient fatigue, because we keep tapping into the same AMCs, the same institutions to recruit patients for trials. But the challenge is, like I said, less than 5% of the US population participates in clinical trials. We have a lion's share of this nation that don't even understand what a clinical trial is, let alone have been given the opportunity to participate. So, from a Walgreens perspective, as we're going through this bold journey and taking a 120-year-old company and really transforming the business model as we move into healthcare and into clinical trials, my goal, at least from a clinical trials perspective, is to tackle the access issue, move the needle around that less than 5%, and start bringing trials into communities that have access to. 1. And number 2, we're working very closely with the FDA. As you all know, the FDA has issued some guidance around diversity planning, diversity plans to be submitted as part of the submissions, from a manufacturer's perspective. So we're working with the FDA to kind of help support in those efforts. And also Representative Robin Kelly from the state of Illinois put forth a bill, the NIH diversity bill that's sitting in the House. So we are working with her team and how best to advance that bill. But ultimately, it forces us as an industry to, as we think about the planning of the design of clinical trials and making clinical trials more patient-centric, but also reaching out diverse patient populations that have never been tapped into. So from our perspective, you know, when we get tapped into by manufacturers on protocols, the first thing that we're doing is that we're reviewing the protocols. Typically, you know, inclusion, exclusion criteria, what makes sense. Now, certainly, you know, we sit on a plethora of information, right? We have 150 million lives. We've got access to pharmacy records. We've made some investments to create what I call a real world evidence engine. So we have access to almost 300 million EMR records, both structured and unstructured data. So we're bringing those pieces and parts together to really understand holistically that patient's treatment journey before we start to identify the patient cohort that's eligible for clinical trials. So we're not looking at sending out mass letters to everybody within the Walgreens ecosystem, but it's more about being precise in finding the right patients for trials. And when a manufacturer comes to us on a protocol, and if they're looking to tap into the same geographic markets, we're challenging that. Whereas, you know, we can come out and say, we've got 150,000 or 1 million patients that are eligible for your trial. Are you looking at communities that you've never had access to? So we are challenging our industry partners to start looking at different pockets of this nation that have never been tapped into before.
Yeah, even looking at like Columbia Medical Center, we do a lot of clinical trials in New York City metro area. Walgreens could really extend beyond that network and help us be able to reach patient populations that are just a little bit further away near our Columbia Medical Center outpatient clinics. So, and talking about Columbia, we have a representative from Columbia here with a question. If you could give your name, title, institution, and then question.
Well, you just gave up the institution. So I'm Derek Brand. I'm the Executive Director of Strategic Partnering from Columbia, although this is not a Columbia question, right? So, you know, these aren't going to be, this isn't a CAR-T trial, right? So ideally, where do you think you're best poised to start a new conversation with certain patient groups, right? So what kind of indications do you really feel like you can reach new people, and how would you start doing that?
Yeah, good question. So a couple things, you know, I launched the business in June of this year. And when we launched it, it was a bit of a tsunami because we had a number of manufacturers and healthcare systems reaching out, tossing their protocols and asking us to take a look at it. And so here's how we're handling this. Certainly from identifying patients, you know, within the Walgreens ecosystem, we're disease agnostic, right? So we can easily identify those patients. We can do the outreach because we're the covered entity. And we can start to make those referrals, you know, to AMCs or healthcare systems, what have you. If we're going to bring patients into our locations for trial visits, that's when we have to be a bit more judicious. Oncology trials doesn't necessarily make sense unless we're partnering with the healthcare system. In the case of what I mentioned earlier, that we have a patient go into the healthcare system to get some of the complicated visits completed, but then have the follow-up visit done so that that patient stays on and we start to reduce the dropout rates that we typically see in clinical trials. Our goal, now there are about 8 disease areas that have significant health equity issues, CKD, cardiovascular outcomes, obesity, and diabetes. These are disease areas that we want to tackle from a Walgreens perspective. Why? Because they impact the lion's share of this country. So when we get manufacturers that are looking at areas in the cardiovascular outcomes, diabetes, CKD, because there's a significant population that's impacted, those are trials that we want to prioritize and start using our physical footprint as an opportunity to kind of bring those patients in for those visits to be completed.
That's fantastic. If you could come to the mic and talk about that. But yeah, so obviously, you know, super specialty centers that need super specialty technologies. There are some that just won't be able to be done solo. But yes, please, name, title, organization, question.
Hey, I'm Disha Goswami from Solera Health, and I'm the Digital Health Solutions Director there. I just had a question about, you know, we all know that healthcare data and documentation management is very siloed in our industry, and you're technically introducing a new, you know, place for patients to add their data. So how are you going to be managing the documentation and data perspective from a clinical trial sense too?
Good question. As part of the infrastructure that we've built out, we've created sort of a centralized team, if you will, a clinical operations team, a project management function team that's going to be sort of providing that oversight of the day-to-day activity as we execute the clinical trial. As we collect information on that patient for that particular trial, it will be housed in any sort of EDC or e-source type of system. We're agnostic. I mean, some manufacturers have certain technology partners that they would like for us to implement. Within the Walgreens IT infrastructure, we've configured it in such a way that we can sort of plug and play depending on the tech needs of that specific trial. But so if you decide you want a Medidata EDC system, we can bring in Medidata. We will have, you know, the training of the staff, both the pharmacists, the providers that we have on site, as well as the staff, the site staff that we have as part of our ecosystem to be able to support the incoming of the data and the review of the data that comes in from a QC perspective before it gets transferred over back to the pharmaceutical company.
Great. And another question at the mic, if you could again name a title, organization, and question.
Hi, I'm Yitzi. I'm RWJ Barnabas Health. I'm a nurse by training, and I've been involved in clinical trials for a long time. I was wondering, could you touch on some of the strategies that you are going to use to sort of help keep patients engaged through the through the various milestone processes all the way to the end? Because from what we've seen over, the many number of years of trials have been going on, is that the more visits that they have to make, the less engagement you get. So
Yep.
the more success that you have is with less engagement and less sort of like interruption in my daily life. Can you touch on how Walgreens is going to sort of approach that?
It's a great question. You know, from our perspective, the community engagement activation is going to be so key. Now, we recognize we can't do this alone. So we're being very intentional and thoughtful about the ecosystem of partners that we bring into bear to help support in this process. Certainly COVID-19 gave us tremendous learnings where we partnered with national coalition partners that have local chapters, if you will, as we started to work with them to, number one, first, create that baseline understanding of what a clinical trial is. Like I talked on earlier, I was in Alabama visiting one of our locations, so the first year I spent a lot of time across the nation and going to our locations. And I had a chance to talk to some folks that were coming into our location. I said, look, we want to do clinical trials, within this Walgreens location. And I got responses, two types of responses that I got from people. Number one, I have no idea what you're talking about. Or number two, significant mistrust in the healthcare system or with big pharma. And so there were a lot of questions that were sort of firing at me in terms of, how do you start to demystify some of the notions, preconceived notions people have about clinical trials and big pharma for that matter. And so there was a level setting and education that needs to be done at the community level. And that's where we're leveraging our pharmacies as an opportunity to educate people, particularly areas that are foreign to the concept of clinical trials, using our pharmacists as a means to have that dialogue and to get them engaged, and at least to level set what a clinical trial is, the benefits and the value for them to participate, and what their participation is going to do in terms of, collecting information that's more representative of the US population. Number two, as the trial carries forward, that's when our community partners will become key to us and our success, and working very closely with the local pharmacy care teams. And so, number one for us is about bringing those patients into our local pharmacies, the point of care, and to be able to have that pharmacist have that dialogue and to be able to conduct the visits. It's going to be a critical piece for us. Now, look, we're new and we're going to be measuring. And I was just talking to Stan about this, sort of the effectiveness, from a patient satisfaction perspective, and then the overall operating model. What does that look like for the industry overall? So, as we start to go through trials, we are going to be measuring this very carefully, and be publishing along the way in terms of the effectiveness of this model go forward.
Obviously, this is a digital health meeting and a digital health day. And it would be irresponsible for me to not talk about digital technologies and how they help enable things like patient adherence, like what we just heard about from RWJ, and how digital technologies in pharmacies and digital technology. It's almost like 1 + 1 would equal 3 if digital technologies like even like information mediary corporation with the digital pill pack and things like that, where there's adherence that's enhanced by this kind of relationship with the pharmacist. And now there's adherence enhanced by these digital technologies in the supply chain. Has that come up at all in any conversations you've had, and how does Walgreens really leverage those technologies to help really empower patients and patient adherence in clinical trials data? Like Bill Toronto from our Global Fund said earlier today, data is the new currency in healthcare. And how do these digital technologies enhance the data equation with Walgreens?
Yeah, on two fronts. I mean, obviously, as Walgreens go through this massive transformation and move into healthcare, our front store activity with our consumers is changing along the lines. You know, you'll start to see more of the digital signage. We've got boards that are being placed into a lot of our Walgreens stores, so we can start to engage our consumers, you know, more holistically. We have tremendous information on purchasing, patterns of a consumer. If you walk into a Walgreens, we can start to understand the types of, retail products you're purchasing, your prescribing patterns, et cetera. So we're leveraging a lot of the technology at the front store as we engage our consumers, because we want our consumers to have that stickiness with the Walgreens, and then be able to use that information as we start to understand from a patient's perspective. When a patient picks up the script, how do we make sure that we improve on adherence? How do we make sure that the patient stays on with the trial, for example? So we are leveraging, and you'll start to see more of that change within our front store activity at the Walgreens, and we start to bring forth a lot more digital tools. And we're still looking at different modalities that's going to engage the different communities as well. So it's absolutely a part of our strategy. Not going to happen overnight, but we're learning. We're doing a lot of market testing in the different markets across the US on what works, what doesn't work. Again, it's not going to be a one-size-fits-all strategy across the different communities in the nation.
Well, this has been fantastic. A round of applause for Namita Tandon from Walgreens. Thank you for joining. And with that, we have next up. Again, if you have questions, don't be afraid. We have the mics for questions here at the front of the stage, and we are always interested in hearing from the audience. Again, just incredibly honored to have so many leaders from around the country, really around the world, with people flying in from overseas to join us today, and hearing about what is happening in your regions, in your ecosystems, and how it's affecting, and again, the evidence that we're seeing for digital health adoption, what technologies in this digital health reset are actually being adopted, and we're seeing the essence of change in over the next 10 years, and which ones are seeing slower adoption rates and are not looking as strong. And two tremendous guests for our next discussion, next interview. First, we have, of course, Krisanthi Dori from Metadata, who leads up data sciences at Metadata, which, of course, for those of you who don't know, if you're from the provider side, perhaps, or the health plan side, Metadata is the world's leading clinical trial software company and has about 70% of the clinical trials running through their servers. And again, based in New York City, again, New York City Digital Health Hub, just throwing it out there. And then, of course, we have Joanne Waters from Information Mediary Corporation, the leading digital health technology platform for medication adherence. And looking forward to this conversation. Krisanthi, Joanne.
Thank you, Stan. Very nice to be here. Very nice to meet you. And I'm welcoming the conversation we're going to have over these next 15 minutes. I have been working in innovative technologies for well over 25 years. The last 17 of those have been in healthcare, monitoring adherence through smart packaging and digital solutions. And I'm very excited to be hearing about our AI and data science discussion here.
Hi, I'm Krisanthi Dori. I led technology in many different companies, currently at Medidata for the last 2 years. I've been on the sponsor side as well for 8 years in clinical data science and analytics, dealing with the diverse data sources. At Medidata, we have 26,000 clinical trials we had done, 70% of the global clinical trials are passing through our platform, and we really deal with 8 million patients in population.
Yeah.
Pleasure to meet you.
Yeah, thank you. So in case some of you are not familiar with what it is that we do and how it connects with Medidata, is we are start with the very basics of smart packaging designs for a clinical trial sponsor, for an investigational medicinal product, or a product that is going to be required to understand adherence and how patients take medicine. So we do that through smart packaging that actually will record through a printed sensor or an optical sensor in a pill bottle or a blister card that will detect the dose removal with the date and a real world timestamp, and as well the dose location as well as temperature. So these objective timestamps are critical into the insights that help research teams and drug development teams understand how patients dose when they're not in front of you or when they're not at the clinic, and when they leave the clinic and go home. We provide objective adherence data to help feed into systems like the Medidata platforms and other research teams around through clinical trials and drug development. So that's smart packaging at a very generic level, but that'll give you an idea of how the conversation will go and how those timestamps can really help the AI algorithm process and the strategies that clinical trial supply teams and clinical operations will benefit from using such a combined system.
Yes, and we deal a lot of different data sources that we can see actually the modern clinical data management domain. If we look at it, we have various stakeholders with different priorities, and introducing technology in all of those proposes different challenges. So if we are on the site has different EDC solutions. They look at two-factor authentication. They care about the compliance and security of patient data. They also receive electronic health records. If we look at the patient population, they're looking of precision in medicine. The same with regulators and payers. They're looking for value differentiating treatment solutions and precision associated with that. There is a patient-centric approach overall in the healthcare system, which moves us to decentralized clinical trials, which means now we have to deal with electronic consent, patient-reported outcomes for be able to collect subjective data. We have imaging data that are coming that we have to deal with. We have sensor data taking vital signs. We saw teledoc here presentations. We have medication adherence data. All of these data streams that are coming, they pose so many different challenges for all the stakeholders and the different engagements. And even if we look at the CRO, because most of our clients are major pharma companies, they are CROs, they are biotechs, each of them has different challenges. We heard a lot about the sponsors and what we said about medication adherence. Do the patients took the drug and all of that? But we look also at the CROs. CROs have to deal with different URLs, different processes, different technologies. The turnaround time through the vaccine trials, we saw that during the COVID-19 pandemic, are squeezed now. And now we even see mid-sized companies who do vaccination trials wanting to do interim locking. The minute they see the endpoint that they want to submit to the FDA, they want to lock and submit the data. So there are a lot of different challenges.
Yeah, it's we as a company, we've been providing these solutions for over 20 years, actually. And so as the world has become more digitalized, we have been the leaders in the forefront, the leaders of that, where it comes to decentralized trials, remote monitoring, so you can actually have a more diverse population base and have a better outreach for that. In the data side is interesting because what happens is this: the adherence data that people can see today have never seen before and it's clean data to help with the data collection and the data analysis. So it actually can really benefit teams like Medidata, where they get this data source and it's such a solid piece of data, reliable objective data, that they can focus on different types of analyses when they have this type of data. So you could actually take, if you have different sites across the globe, and you can see adherence rates based on that patient population, and try to understand why that patient population is, either doing poorly or trending down or trending up when it comes to adherence in the analytics. And all that data is happening in real time. So this, you talk about a delay in that, but this is something that can really advance that analysis. And then with the AI, feed that through and really help to bring it quicker to the FDA, to the lock, to the drug approvals, and to better health outcomes for the patients.
Yes, and this feeds into Medidata's objective to create what we call the patient 360 view. Be able to integrate electronic health records, be able to, through tokenization, be able to integrate real world data with the clinical trial data. We also work a lot around integrated evidence, where we have synthetic controls from 26,000 trials across 7 million patients. So instead of having a control arm now, sponsors can use this synthetic control data to bring the data to the market much faster. And there are a lot of challenges, as you mentioned, bringing the raw data all together in the stream, have the right technology platform where you can scale, you can aggregate the data, transform them in common models. And we heard before someone saying, fall in love with the problem, not with a solution. The question always around AI is, what problem are we trying to solve? What question are we solving? What question do we need an answer for? And there are a lot of challenges around that. And we know in different stakeholders, like the sponsors, there are a lot of different technologies that they are not talking with each other. They're not integrating together. They are more from different vendors and legacies. So having this different cross-study data to be able to populate your clinical trials, bringing electronic health records, adherence data around medications, be able to transform those, but provide real outcomes, analytics, it's the key, I think.
Yeah, I think it is the data side of it is the power of the data and how you analyze that data and understanding the validity of the data for certain, and how patients are actually doing what you would hope they would do, but they actually don't. And that is the type of data that will power any type of clinical trial. When you talk about the workload of the site, the clinical staff, when they have so much work to do, they do a lot of, double entry, manual entry. So it's a risk there, of course, of errors and these types of things that happen. For drug accountability and reconciliation, which is a big cost in a clinical trial, right? Trying to get down to either a kit level to figure out where the kits are, how many were used, all of this. When you use smart packaging solutions, each one of those has a unique identifier for like traceability, for that sort of thing. So you can trace right down to the last pill by simple tap, and then feed that data into these systems. And then that gives them more power and also more other areas of opportunity to focus on using these types of data to really understand the patient. And again, bringing the patient, the center of the patient closer, remotely, but closer, through these technologies where it's empowering the patient and also providing wonderful data and easy data for the CRO and the sites and the sponsors. So,
yeah. So some of the challenges usually are ingestion of all this data, because each of them has different granularity. Some of them are coming already aggregated. Some of them are coming extracted once a day on the sponsor side. Some of them are coming raw. Then you really have to integrate them, transform them, put them in a common data model, and have intelligent approaches, not every data point has the same value. We have to be able to have risk-based data management to understand which are the important data checks to focus and which ones are not. And we have to be able to show outcomes and visualizations of the data that are based on user workflows. Who is our user that wants to be able to look at these outcomes and make judgment calls? Is it a CRA? Is it a medical monitor? Is it a data manager who wants to do clinical data management review or clinical data review? All of this is very important. But as I mentioned, there is also the fact that even if we get all that data, in order to transform them, bring them in the stream, we're going to see duplicate data. So there is significant data cleaning, data modeling, data transformation, and then the visualization portion.
It's an interesting point on that is what we've seen is something called deblistering. So as an example, a patient can go home and they have, let's say, three packs of 10 doses each. So they have 30 doses in total. So we see some of what the deblistering is, where a patient literally pushes out every pill when they get home, and we don't know what they're doing with it, right? So when you're having an investigational new drug, you have to be concerned about the stability of the product, worried about ingestion and that sort of thing. So we want to make sure that it's safe for the patient once it gets out of that safe thermoform blister. And so we see they punch out every one of those. And if it's a titrated product, then it's a risk to the patient. So this is the type of data that can help with patient safety at the sites. When they see this type of behavior happening, it's an opportunity for education. And it's also an opportunity to help the patients understand why it's so important to take medicine as they should and as prescribed for the betterment of their health.
Yeah. And this is really easing the burden, keeping the patient conformant to the drug and the therapy. And when we talk about patient-centric approaches, this is one of them. We talk a lot about decentralized clinical trials, and we see now that only 30% of the data are going through EDC. The rest of them are going to be around digital health technologies in the future, because we really need to reach patient population which is more remote and remove the bias from the clinical trials. And that brings us the opportunity to do so. And what you described here about medication adherence and raw data and data cleaning is very similar what happens with sensors also. In the course of decentralized clinical trials, we want to be able to have objective and subjective data. And what we call objective data is, I'm a patient, I want to tell how I feel during the course of my day. Let's say I'm a heart failure patient. Did I exercise today? How many steps did I go through? At the same time, I have to have, apart from the objective data, subjective data that shows the steps, shows the bouts. I can have electronic health records and real world data or data from patient registries. So now I have a wealth of information to build more of a personalized care, phenotyping the patient as opposed to be under a clinical trial with a patient population that it's not fit for all.
Yeah, that's the exciting part. And it is something that with using smart packaging data, the efficacy of the data, the strength of the data, and what it can do for the patients is something that is critical for clinical trials and drug development, as well as, perhaps very interesting with Walgreens that they'll be participating in clinical trials, which makes total sense, right? They're right around the corner pharmacy, easy for the patients to access and go from there. So I think AI is there. It's not going anywhere. I think how we work with AI and when we can integrate such things as smart packaging solutions as another layer, a very critical, important layer to feed into, the wearable data, the other types of data will be a solution that a lot of the pharma will be, and are using to help along with the drug development and get those drugs out that work and that will help cure the patients who need them.
And of course, privacy, security, and compliance is at utmost importance and storage. We heard about the FDA guidelines. We hear about EMEA, access to patient data. All of that is very important, and scalability, of course.
Yes, yeah, absolutely. I think our time is up. I'm not sure. So if there are any questions, I think, do we have, okay, go ahead.
Hi, I'm Greg Bauer from HITLAB, strategist and fellow. And I am interested in your comments about patient convenience, because as the FDA, of course, has expanded the mandate around rural populations and making more diversity available, the convenience of the technology for the patient is really important, because that's what's going to drive the adherence ultimately, right? So maybe before your final comments, if you could just speak to how your technology works to enhance the ease of burden on the patient to ensure that adherence.
Yeah, absolutely. So we like to keep it as a simple experience as possible for the patients and take medicine as they normally would. So the best thing is you can have patients that are very remote. The most important thing that's going to possibly keep them in a healthy state is, did they take their medication, and did they take the right medication, and did they take it on time? And that's the basically, I guess, the foundation of reaching a population that's so rural and helping them to come into the clinic virtually. And then, through other solutions and integrations, it just makes an overall better experience for engaging the CRA team or this pharmacist team remotely with the patient. So I think overall, the hybrid solution of remote monitoring, decentralized trials, you can either stay remote and maybe have less clinic visits, less blood draws, all of that, which actually is such convenience for patients. And it might reach a wider audience that maybe they don't feel so overwhelmed to enter into a clinical trial.
Yeah, and we are very serious about the decentralized clinical trial approach. We have electronic consent, we have patient-reported outcomes, clinical outcome assessments. And in terms of medical devices, sensors, medically approved devices, we integrate a lot of them through a common API that we allow medical device developers to integrate with. And why this is important? It is important because when I was on the sponsor side, we would distribute 2 or 3 different devices that they don't integrate together into the site. And there is a lot of patient burnout on this. Patients will be wondering what is happening in the application, why they are getting all these alerts when they go offline, for example. And then the sensors sometimes will not push the data into the cloud. So we don't know what is happening there. Or you go into a hospital somewhere in Europe and the data cannot be transferred into the medical device cloud provider because there is a firewall. All these different things. And at the same time, you see the doctors who are, for example, in the heart failure area, admitting heart failure patients, and they have to administer these devices. It's quite embarrassing, actually, the burden there. So we take it very seriously, and we have patient advocacy groups that we run our technology with to give us feedback, constant feedback.
That's fantastic. A round of applause for Joanne and Chrysanthi. With that, we're going to take a 15-minute coffee break, juice break, whatever you need break, and then we'll reconvene at 3 p.m. Thank you. Doesn't that?
¿Pero qué pasó con este jefe?
Oh.
Good afternoon again. Digital Health Day at Columbia University. Welcome back to the 9th Annual HITLAB Innovators Summit here in Lerner Hall. We are really excited to have our next panel talk about digital health's adoption rate and digital technology adoption rates around the world. We have a highly diverse panel here from not just New York, but from Argentina, Latin America, and other parts of the globe to talk about the adoption rate of digital health technologies in different urban communities. So with that, please welcome a panel that'll be moderated by Dr. Sarah Chotsky, Director of Research at HITLAB. Please welcome them.
Wonderful. Thanks everyone for joining us as we start to finish off the afternoon today. I'm super lucky to get to be part of this conversation with Peter, Francisco, and Michael. Today, we're going to talk a little bit about fragmentation in the system and access. We're going to unpack access a little bit and talk about a little bit more specifically about what solutions are out there to solve specific problems that stop some people from seeking care and getting care. So that's our topic for today. But I'd love to just start off and have everyone hear a little bit about who you are. Peter, would you like to start us off?
Sure. Hi, my name is Peter Niemi, and I'm with Recovery Plus. That's recoveryplus.health. Company that owns recoveryplus.com wanted $500,000 for the domain, so it's recoveryplus.health. We are a home-based cardiac rehabilitation, a virtual cardiac rehabilitation company.
Okay, thank you. My name is Francisco Primero Narvaez. I know it's a mouthful in Spanish and in English, but I am from Buenos Aires, Argentina, and I am the founder and director of Axon Digital Health, which is a consultancy company that helps healthcare companies deliver in the technological environment. And I am founder of Catalysia as well, which is a company that uses artificial intelligence to help patient adherence.
Great. Hi, everybody. My name is Mike Norson. I work for a company called Alexandria Real Estate Equities, which is the largest owner and operator of life science real estate in the country. And specifically, I work for our venture capital arm. We have a corporate venture capital arm that invests in early stage biotech and healthcare companies. We've been given the honor of being for the seventh year in a row, being the most active life science VC in the country. And we also have an early stage platform called Launch Labs that we work with early, seed and Series A stage companies to help them get started in their early kind of formative years. And we have these Launch Labs platforms all across the country. And specifically here in New York, we have two, and one is up on the University Medical Center campus here at Columbia.
Awesome, great. And for those of you I didn't meet this morning, I'm Sarah Chotsky, Director of Research here at HITLAB. So access. We have already this morning talked a lot about issues of access, equity. What do we mean by access? Can we talk a little bit more specifically about what are the challenges with regard to access that we see? Peter.
Sure. So being in the cardiac rehab space, we are kind of in a niche of the healthcare market. And there are huge problems with access. Cardiac rehab is only used by about 20% of the people who it's recommended should be in a program such as ours. This is despite the fact that it is known to reduce hospitalization rates from about a 25% risk to ours at the last survey we did was about 2.1%. So it's a big reduction. There's a big motivation to do it, but compliance is terrible. And there are a bunch of issues that are they're similar to the broader issues of access. With us, it's distance. That's the biggest one. There are not enough rehab centers in the country to service all of the need. That's why we created this company in the first place. For example, one of our partners is up in Dumas, Texas, where there are 3 cardiac rehab centers in an area that's about the size of Maine. So it's just not realistic that you're going to be able to go to repetitive treatments. The other thing that we face that I'm sure is common to most of you is inertia. Our patients are not people who are excited to get back to the gym and work out and lose 10 pounds. They're scared. They're worried that they'll have an adverse event. They're worried about going to treatment. So between distance, inertia, and the need to go to repetitive treatments, the access to care is really kind of heightened in the cardiac rehab field.
Awesome. Anyone else want to tackle that a little bit?
Yeah, sure, happy to. So on the venture investment side, we've seen a lot of companies at their earliest stages being very focused on integrating data. So we heard about that from the past two panels. So we're very focused on supporting companies that are integrating all kinds of data, different genomic data sets, different EHR platforms, and the ability to integrate and mine that data to get really meaningful insights. And that can range from everything from early stage drug targets all the way to stratifying patients for clinical trials, but then also for stratifying patients for actually prescribing therapeutics that are actually going to work. And then taking all that information and putting that into kind of your drug development paradigm to continue to develop those drugs. And I think it's just not enough to develop them, but how are physicians being able to integrate that data and real time understand where a piece of information or piece of data that a patient might have in their medical records and their genomic records, and being able to use that to actually, what I would say, kind of really codify the idea of personalized medicine and bringing those therapeutics to the right patient at the right time. I think we have so many different data sets that are very fragmented, as we talked about earlier, that are on different platforms, and the ability to aggregate those, mine them, and come up with meaningful insights, whether that be in an oncology HR, for a cancer doctor to really have a meaningful, insight from a set of data. I think that's really where a lot of our efforts should be focused. It's what we're looking for in terms of the companies that we're seeding.
Okay, so it sounds like, kind of a theme I've noticed all along is, the technology is there. It's about now how to get it to the right people at the right time in the right place. I think we're platforms like Recovery Plus, and a lot of the telemedicine solutions we've been talking about are super helpful for things like distance, right? Or physical challenges. Because I was thinking, we were laughing earlier because our title for the session today has roamed a little bit. When we were first talking about the session, we were talking about fragmentation. And I know Stan also brought in this idea of rural versus urban. So, can we take what we've talked about here, these issues of access, and talk about that dichotomy a little bit, and how is access different for urban populations versus rural populations? Peter, you were talking about, a platform like ours is great for specialist shortages, right? There's just not enough physicians to go around, so we offer a platform. So we don't need physical proximity to see patients. But again, we see even in urban spaces like New York City, where everybody's, I could walk to a cardiologist right now or a rehab facility. Doesn't mean I'm going to do that. What else is going on?
Sure. So short answer, and absolutely. And I live in the city too, so
Yeah.
I'm one of those people who has the access, and that's really what we set about doing. This is, of course, much more profound in rural areas. It's also more profound with lower income individuals. So that's the solution we've created. The reality is that you talked about physician shortage. You'd have to have 5 times as many clinics in the US to treat all of the patients. That's just not realistic. That's not going to happen. So we have built a distributed platform. It is a virtual platform. And then getting over that inertia, this is not some asynchronous exercise on your own. You are connected with an exercise physiologist who's reassuring you as you go. You're wearing a heart rate monitor that everything is okay. And if it hurts, then we dial it back. And once you get stronger. So yeah, that's exactly it. We've kind of methodically gone after what are these barriers to care. And that's what we do every day, is work on figuring them out and coming up with a solution.
Yeah. In my perspective, I come from Buenos Aires, which is a huge city. It's really big. And we Argentinians say that God is everywhere, but he has his office in Buenos Aires. So the thing is, you've been there and you know why. But thing is, we have seen, and it's a common thing, to have people come from all around our country to Buenos Aires to have a doctor's visit, because the best of the country are there. Thing is, that's been happening for a long time, but now you have technological tools that brings you the opportunity not to do that, to access to some other services and some quality service from a virtual perspective. So thing is, what I'm trying to say is that we should have a shift in the point of view, because you are catering people who had no solutions before. So that's really interesting. We are working on a program with a very large NGO in South America called Fundación Boom Hayborn for an endemic disease, which is called Chagas, which is from the north of South America, or the center of South America. And these people, have no access to doctors before the efforts that this ONG is doing. So the thing is, I would shift, this perspective and be grateful for what technology is bringing to these rural areas or these distant areas.
It's interesting the way you put it is similar, but a little bit different in the sense that you're kind of saying, like, we've been doing this. This isn't new. It's now just thinking about building the tools to make it easier.
Right.
So time flies. I just got the 1 minute. I would love to hear, Francisco, if you want to talk a little bit about things that you see from outside of healthcare
Yes.
that might help us deal with this access issue.
Yeah, I come
access
from the
issue.
technological world, and I got into healthcare. And I think that the key word or the keywords is, open ecosystems. Every technological breakthrough or every technological company that got, to thrive, they built open ecosystems. Take Apple, for example. Apple made it possible for app developers to, go through their, obviously, the very much controlled environment, but those ecosystems help people, adopt the technology, help people understand, help companies understand each other's. And it comes not only from the ambition of companies like Apple or Google or Tesla or whatnot, but also, from their humbleness in recognizing that they cannot do anything, everything, they don't do everything right. So they bring the tools for other companies, small or big, to, provide the services that they are not focused on.
Great. Partner. I love that. So just before we end, Michael, just because I know you see so many different startups in your work, any comments along the lines of what Francisco is saying in terms of who else is kind of dealing with access in a way that when you look at companies and think, who you think is going to be successful, what kinds of things do you look for?
Yeah, so access on clinical trials is something that's really important. And we talked a little bit about that before. And the ability to use technological solutions to reach people, rural, urban, maybe people who have debilitating diseases that can't get access to a clinical trial, or maybe are in some sort of socioeconomic, area that just doesn't have access to knowing that those trials exist. We're seeing a lot of technology out there that are helping us access those folks. I think it's helpful for patients. It's also helpful for biotech and pharma companies to be able to be more expansive in their trials and also be more inclusive to get better results so we can get patients to or treatments to patients, more quickly. So we're seeing a lot of those, companies that are starting up, and I think that's going to be a good thing for everybody.
Great. So, well, that's all the time we have. Michael, Francisco, Peter, thank you so much.
Thanks, sir.
Thank you, sir.
Okay.
Thank you, sir.
Thank you.
Thank you. All right, so we have now a very nice transition to go from what's happening with digital health technology adoption in different parts of the world, urban, suburban, rural, different parts of those communities, to now a major thread of research within HITLAB around age tech. And some of our partners from the World Bank and some of the folks that they're working with are here to talk about what is being adopted and what's being utilized with this digital health reset on the age tech front. And by the way, go to hitlab.org. We do have a new challenge with AARP in age tech technology, digital technology challenge. So please, if you have any kind of an age tech platform and you want to enter for all kinds of amazing prizes, check out hitlab.org and apply for those through the AARP Age Tech Challenge. And now up we have our colleagues from the World Bank to talk a little bit about what they are doing in age tech. Please welcome the World Bank.
Hi, good afternoon. Can you hear me well? Yes. Let me check the clicker and see my presentation. First, my name is Xiahui Ho. I'm a senior economist in the Health, Nutrition, and Population Global Practice in World Bank. So now we're shifting our lens to the older adults and looking at the longevity economy, not just in the States, but also across the globe. Oh, great. So first, I want to show a couple of the stats. Okay. Many of you have already know the pace of the population aging is much faster than in the past. And in 2020, the number of the population aged 60 and over actually outnumbered the population 5 and under. The UN estimated between 2015 to 2050, the proportion of the world's population aged 60 and over is almost doubled, and from 12% to 22%. And in 2050, 80% of the older population is going to live in low and middle income countries. So that is a large untapped market. I'll quickly go through some charts. This is a distribution of the older population across the world. And although now it's the dark blue are the where the more older people, but the countries now in the light yellow color or light blue color are going to catching up very quickly. The looking at the disease burden, there are a lot of speakers have talked about this morning as well in terms of the chronic illness, namely, for example, the cardiovascular disease account for 30% of the total disease burden. When we're looking at the data in terms of the older population living home alone comparing to younger population, we find actually more older population living alone, which requires a lot of the assistive technology to enable them to live by themselves safely. So, overall, the United Nations also called the investing in healthy aging. They declared from 2020 to 2030 as healthy aging a decade. So that is related to the UN SDG, Sustainable Development Goal, as well as universal health coverage for all the population. So, not just the bank, but also other UN sister organizations are also working on that. So part of our work, we developed a FAIR framework looking at the primary health centered care, where the primary health care is in the center, and we hope the service delivery model can be more integrated with the long-term care, secondary and tertiary care, and the community care. I don't know whether, you know, yeah, the centered care. This care model has to be based on the demand side preference, based on the national policy, national strategy, as well as country own demographic, age and gender, and also their culture. Because in some societies, home care is certainly much more preferred comparing to institutional care. And mainly on the supply side, we're looking at the finance, innovation, regulation, and evaluation, the FAIR framework. So those are the main levers that we are working with the developing nations to strengthening their care for the older population. Under the innovation, we're looking at the innovations in different organizational forms, but also quite importantly, the digital health innovation. So as a couple of the speakers have mentioned this morning, so we're delivering care in a digital world because the rapid advance of digital health technology and the virtual technology, and also the great awareness and demand for person-centered healthcare, which we listened this morning as well from Amy West. So there are a huge trend in terms of customized healthcare to accommodate a personal preference. So this is just not in OECD countries, but also in many low and middle income countries that we are trying to emphasize. So for the digital health technology, we broadly categorize it into 3 categories. We tend to do more of, frameworks or categorizations. So one is the clinical applications, which assist diagnosis and treatment using digital technology. And the second is more in terms of the data, information integration, and data case management. The third category is convenience application, which focused on the customers in terms of the virtual coaches, application using nudges, etc. And for the older population, we use the terminology called assistive technology, which basically assists older adults to have a more safety living in home or in institutions. Of course, there are lots of the barriers for the older population to use digital technology. One is affordability, whether the users want to pay for it. And also quite importantly is whether the payers, either through health insurance company or third-party payers or public finance, would be willing to pay for the digital health technology. So that is the area that we are also working with the government in terms of financing and the payment and the benefit package. The second is the ease and use of the support. The data actually shows in the States and more severe in developing nations, the older populations, their utilization and the knowledge acquisition of the using digital technology is fairly limited. Of course, there are like other, barriers as well. However, independent of all those barriers, the market data has shown there is a huge increase and a potential in terms of assistive technology in the States and also, for example, in China as well. As the aging, we know that in Latin America and the East European countries, there is also a huge demand. So now I'm inviting my colleagues, Kiyoko Tokuda, to introduce the HTAC in Japan.
Thank you very much. Let me quickly introduce some HTAC being implemented in long-term care facilities in Japan. Clinical applications on your left. This remote monitoring system detects the elderly's irregular move on their bed and notify caregivers to prevent injuries. This system can also analyze the elderly's behavior patterns, which allows caregivers to avoid unnecessary visit during their sleep and then ensure the elderly's quality sleep. According to a survey, 60% of caregivers felt the reduction in their mental and physical stress by installing this system. From the return on investment perspective, this system is expected to cut off numbers of the caregivers during the nighttime. Next in the middle, information to integration. This system can import behavioral patterns analysis sensed by the sensors and integrates health data with care records. Such real-time information technology and information sharing enables caregivers provide a tailored care and reduce staff meeting and reporting time. Moving on to the right, consumer application can maintain autonomy and dignity of the elderly people, which is very often neglected, but very important. A university startup, HAL, developed AI embedded wearable cyborg to empower both caregivers and care receivers. This device can detect faint signals of wearer's intention from the surface of their skin and strengthen independence of the elderly people. Lastly, a prestigious bed manufacturer, Permanent Bed, and a robot company jointly developed a smart bed. This bed has an odor detection system, which enables caregivers to provide timely care to the elderly people, which actually help elderly people's dignity as well. Behind the scenes is this cross-ministry collaboration and multi-sectoral partnership. In Japan, the Ministry of Health and Ministry of Economy jointly assisted the development of age tech to fill the gap between the supply and demands in advanced silver economy. We can apply this FIRE framework to analyze what's to be considered to advance age tech. I'll stop here and hand back to Xiaohui.
Thank you, Kyoko. And for this framework, we are not only just apply it to Japan, but also to a number of the countries across the world, including Mongolia, UAE, Bangladesh, etc. So just a couple of more examples. For example, like in Singapore, in the community, in the elder care center, in the room, they have different sensors, so which can detect a person's fall or movement. And also in Singapore, the facility also collecting the information, so they can analyze it to be better predict in terms of the accidents or incidents. Kyoko already described some age tech in Japan, so I'll skip it. And in Russia, they started telemedicine in 2020. But more importantly, is that in Russia, they ask the health insurance agencies to include telemedicine as part of the benefit package. So that become mandatory for a number of the states. Once there is a financing and an incentive that provides a more enabling environment for the adoption of the digital technology. And in the States, we already heard a lot in terms of the using virtual reality for dementia and also for other disease. In Taiwan as well, it's more integrated data system. So the patients and the different types of the providers, they can look at the patient information more simultaneously, so they can make a more comprehensive, they can make the clinical decisions based on more comprehensive information. So overall, when we're working with the developing nations, we use this framework, which was published in the Lancet in terms of adoption of the digital technology and looking at the population, trying to really understand the preference of the population. And the bank and other agencies working with the government in terms of the governance structure, in terms of the regulation and also data security. Financing and the incentives, we are looking at the benefit package, trying to see that whether we can prioritize interventions, including digital health interventions, to be included in the benefit, also looking at the unit of the cost and the effectiveness, and the training of the workforce, and help them to establishing platforms and tools for quality assurance. So overall, in order to transform, transforming to enable the development and the uptake of the digital health technology, We see that in terms of the bank and other agencies at the macro level, we are working with the government to provide more enabling ecosystem. At micro level, as we have a lot more tech companies and investors here, I think you know more about the technology innovation, but also on the societal level, we think that building digital skills of the patients, healthcare workers, and building a more enabling ecosystems are quite important. So that's, I think, what HITLAB do is to bring every sectors together in order to have a more transformation impact. Thank you so much for your attention, and I think my time is up. If you have any questions, feel free to stand by.
So there you have it. It's again, just another piece of evidence about what digital is doing around the world now in a different population, age tech, and understanding the importance to recognize, first of all, the need, and then number two, to make sure that we're aware of, from an empathy standpoint, how people that are in the age tech category are adopting their technology and ensuring that we're designing, again, patient centricity and UX UI factors being front of center, making sure that we're designing technologies and platforms that fit their socio-technical needs and their socio-technical abilities. So around that frame and just really carrying forward on that thread, one of the things that we have seen is some of the leading signals of digital health adoption and digital health technology usage and overall efficacy comes from the venture world. And so we're really happy to have with us again the president of the Merck Global Health Innovation Fund and another leader that works very closely with Merck and with a number of other companies in digital health, not just recently, but over the last 30 years, Piper and DLA Piper. James Fisher is, again, a local digital health community leader, and we're happy to have the two of them here to talk to us a little bit more about what's happening with digital health adoption, particularly when it comes to legal issues and how some of the legal issues that have to be addressed by either executives in major healthcare enterprises or in startups, with startups, and obviously with investors. So with that, let's welcome James and Bill back to the stage.
So thanks for having us back on stage. I was fortunate earlier to be on the panel with Paxton and Ian, and we were talking about the viewpoint of 22 and 23 and maybe even to 24 from the investor perspective. And what I'm going to talk to Jim about is let's talk about not only from the company's perspective of what happened in those years, but what is he seeing from a legal perspective that affects both the investor and the company. So we're kind of turning the tables on the first panel that I did earlier. But Jim, before we start, why don't you introduce yourself to the audience, a little about your background and who you are?
Sure, happy to. Thanks, Bill. So my name is Jim Fisher. I'm a corporate partner at DLA Piper here in New York and in Short Hills. I practice in the M&A space, the venture capital space, emerging growth, and the corporate venture capital space. I've been practicing for about 20 years or so right here locally, and was born and raised in New Jersey. So I'm happy to kind of be able to stay local and be part of the community and get to work with Bill and many others in the community and learn a lot from coming to these events and listening to what you all have to say. And we'll try to do a good job of giving you a different perspective on what you might have heard earlier today.
All right, thanks, Jim. So let's take a look back first. What major changes have you seen in the legal environment for the digital health companies in the past 12 months? Let's take a look at 2022 and what you saw happen.
Yeah, so if we go back a year ago, you all probably noticed it, I'm sure. We certainly did as lawyers. The fourth quarter of last year was a very vivid time, a very quick time, and it was probably unsustainable in many respects in terms of just how people were exiting, how they were raising money. And you fast forward a year through, a bit of a difficult year and a difficult process, and you're starting to see sort of a little bit of the opposite of that. So from a pure valuation perspective and things of that sort, from an exit perspective, obviously we're still, we don't look at it as a downturn, but more of a transitional market that we're in at the moment. And that's true from the business side, but also from the legal side. So we are certainly seeing, deals that are stretching out longer. It's taking longer for buyers to get comfortable with exits. We'll talk about that. It's taking a little bit longer in some respects for money to be invested in or that second round to come in. And it's not because the companies aren't properly valued or sort of worth the investment, but there's a little bit less urgency in some respects to depositing that money as quickly as there was, say, a year ago, even 18 months ago. And there's also an interesting sort of, I guess, change in terms of many farms are raising money right now. There was so much money deployed last year that many have said, okay, let's sort of take a step back. What did we do? What's working well? What's not working well? How do we kind of strategize with our own portcos in terms of making sure that our portfolio looks the way it should and is growing the way we want it to grow? And then in terms of just the market environment, and I'm obviously not a financial advisor, but from what we hear and see from bankers and friends in that community, there's still that desire for alternative investment vehicles, and so you're starting to see a lot of funds go out and raise that second, third, fourth fund. And in your space, obviously in the CVC space, we're certainly seeing that same kind of commitment to where do we go from here? So I would say that's where we sort of are seeing things, a year ago to today. In terms of just deal terms, certainly things as markets tighten, obviously the company can feel a little bit more constrained in what it can do. It might feel a little bit less in terms of who's at the table, how vigorous they are, what kind of terms and conditions they want. If there's commercial arrangements, what do those commercial terms look like? What can they benefit from? What can they show to the investor that maybe somebody else can't? Whereas last year, that was probably a little bit less of a focus because there was such this urgency to kind of get money committed and get it done by the end of the year. So certainly seeing a little bit of that transition.
So I mentioned in my panel that as a fund, we did a lot of notes last year.
Yeah.
And I'm curious what you might feel as, or what you might see potential ramifications of the companies doing those notes because they couldn't necessarily fundraise, and what are maybe the consequences from a legal perspective of from the company's viewpoint of taking those notes?
Yeah, so I think a lot of companies, over the course of this year found themselves in a position where they frankly would like to have gone out and raised more money, but there are two things that kind of happened. One, they might have raised money at a very high valuation, say a year ago or 18 months ago, and they set that expectation, which is always sort of an interesting conversation. Again, as lawyers, we're trying to help our clients as best we can in all facets, and obviously our principal idea is to provide legal advice. But there's always that sort of challenge, and you're talking to people about, do you really want to set that valuation that high? Because you're going to have to demonstrate where it goes from here. And that we've seen, because of that, in many cases, people weren't able to kind of show that valuation. They didn't want to do a down round. So obviously a down round or a flat round is never sort of a good sort of situation for somebody to be in. So income, the notes, and also safes, as you all have probably kind of seen. And I think the repercussion of that, I think, is largely sort of, I would say, as we move forward into next year, it's in the market. People know, I think, that are in this space that, many companies did that for various different reasons, but principally because they either wanted to raise more money and couldn't. The round that they raised wasn't enough, so they needed a bridge before they kind of create that more, that sort of ramp in their valuation come a year and a half from now, or what have you. Or generally speaking, and hope this is not the case, obviously, but there's an element of we need this money or we can't really evolve forward. And I suspect you'll see that going into the next quarter or two as well.
Okay, let's look forward now. Let's think of the next 12 to 24 months as we move forward. What do you kind of see as the legal outlook for the companies and for the digital health community going forward?
So I think one of the things that we're really focused on, and I'm fortunate to work for a global law firm. We have offices in 90 countries around the world. I should say 40 countries around the world, 90 offices. And many of those countries, we have an FDA-like practice. And so we're seeing a lot of focus on what the regulatory environment looks like in various different jurisdictions. And not just what you would think about in terms of the regulatory environment, not antitrust issues and things like that you all are accustomed to, but more of the real sort of diligence into, okay, how are these products evolving? Who are they servicing? Where are they servicing? Where is the cross-jurisdictional issues coming into play? And we're sort of really focused on making sure that people are prepared for those issues, because as you think about how the companies evolve over time, if they haven't laid that groundwork on some of those issues, that can really become a problem later on. We hope to help you in the beginning and not, at the end, rather kind of prevent the problem than have to solve for the problem. We're certainly seeing a big uptick in sort of regulatory matters and just, I would say, diligence in general. When you sort of in a position where the markets aren't quite as frothy, people do tend to take a step back and they're willing to kind of pay a little bit more attention to diligence, principally because they might have a little bit more time. And maybe we're talking about a week or two as opposed to, I got to get it done tomorrow. But that week or two can probe and they can look to questions and things of that sort. And we'll talk, I think, a little bit about kind of what we would suggest people do. But we're certainly seeing more of a level of diligence. I expect that to continue. I expect people to be a little bit more probing in kind of how they think about what the companies are doing. And then I would say many times we're fortunate to be in the investor presentations, which is always sort of an interesting viewpoint for us because we learn a lot. We're seeing a lot more questions that are very targeted and direct, as opposed to a little bit higher up in sort of the elevation.
So you mentioned regulatory. Can you go a little more detail of really what you're seeing, as it relates to funding opportunities?
Yeah. So, in terms of, and when you say funding opportunities, you mean certainly people investing into companies. So I think it depends largely on what stage of the investment you're in. And if we talk about very early stage companies, I think it's the key for them is showing the path forward and what the plan is with the money, and that the money is actually going to be used in part, not only to obviously raise the profile of the company and the product line and things of that sort, but that you've laid the groundwork so that you're not fixing problems that could have been dealt with on day one. And in the regulatory environment, largely that is, are you getting your products, approved in a certain way? Are you thinking about kind of what other applications could exist that might lead to different sort of legal scenarios or challenges? Are you engaged with counsel that can kind of provide a broader brush of focus, right? Not just a fund lawyer, or not just a transactional lawyer. And again, I'm fortunate to be at a firm where I certainly don't know everything, and being able to bring in those regulatory lawyers, whether it's FDA lawyers, whether it's antitrust lawyers, whether it's cross-border lawyers, to sort of have those conversations more globally is important. And frankly, I think it does help us kind of stand out a little bit in that regard.
All right, let's talk about the exit market. How, if we look at, the funding going forward, we had mentioned earlier in my panel that the sort of the healthcare SPAC market wasn't really that good. IPO is a little on hold, but how are you sort of projecting and advising going forward your companies as they think about exiting?
Yeah, so let's talk about SPACs for a second. We've all seen them, we've all heard about them. If you had asked me that same question, last year, I would say we are doing SPACs every day of the week, whether it's forming them or de-SPACing, or taking a company that was, a SPAC back private so that it becomes a SPAC again. It was sort of this cycle. That cycle is clearly depressed in two ways. One, the SEC, FINRA, other regulatory agencies are very focused on the accounting of SPACs and sort of what's happening along those lines. So what I would say is if you were thinking about an exit and the SPAC being that exit, that is going to be more challenging over the next period of time. I wish I could tell you how long. I don't know for sure, to be honest with you, but I don't think you're going to see a robust SPAC market in this coming 12 months. And you're unfortunately seeing the worst case scenario in some respects, which is SPACs just sort of saying, okay, we're actually going to shut down. We're going to return the capital before their window closes. So that's never sort of a positive sign, unfortunately, in the SPAC market. The other thing I would say with SPACs, and then we'll move on quickly, is I would just be careful when you're talking with a SPAC about their motivations and what they're doing and not doing. How quickly can they get something done? How many deals have they done that didn't sort of happen or didn't close? So it's a fragmented market. The capital market's a little bit challenged at the moment in terms of certainly the IPO market and the secondary market. But I would say the M&A markets are still very robust. We're fortunate to be very busy. We're still doing a lot of exits and a lot of sort of whether they're small exits or large exits, and they're global in nature. So I don't see sort of the same sort of scenario with SPACs or the capital markets as we do in the M&A markets, largely because there's a lot of money that has been deployed, and obviously there needs to be an exit.
Okay, well, last question, because I know we're just about out of time, is what advice would you give, a CEO or CFO who's looking to exit next year?
Yeah, I would say use this next period of time to be as prepared as you can possibly be. make sure your diligence is locked down, make sure your investors know kind of what is happening, make sure your advisors are aware, don't bring them in at the last minute. I understand that that can cost some money, but I'm telling you, I really sincerely believe that the earlier you advise, you get your advisors involved in the process, the better off you'll be. They can help you to prepare for some of what they're seeing, some of the questions that you might be able to kind of answer in preparation for what they've seen or will see. And it makes you look as though you're standing out. You've prepared, just like any of us would do to prepare for our work day. It puts you above that person who has to say, well, let me get back to you. And so I would say prepare.
All right, well, thank you. Thanks, Jim, for sharing your
Thank you.
insights today, and thank you for listening.
Thank you.
Appreciate it.
So we've got just a tremendous amount of energy right now built up around these ideas of that we're in a down cycle. There's a recession coming or something like that. And really what we've seen today is that it's really not a recession. It's not even a down cycle per se relative to 2019. What we've seen with 2022 and the digital health reset is that it is now more of a transition to above normal. So we're not at 2021 or 2020 when it was ridiculous. And we're not at 2019, we're above 2019. So this digital health reset is now looking at, and really the evidence is pointing toward having a lot of digital health technology solving major problems and doing it in a stepwise fashion so that it's not going to be overnight. It's going to be over the next 3 to 5 years. And we are seeing this digital transition of the healthcare economy and taking place. But one of the themes that we found in our research was that there's also this fragmentation taking place. And we saw a little bit with the World Bank and what they were talking about with HTech, because we don't have a one-size-fits-all digital health solution. Really what we have are different types of versions of digital health for different populations, really not just in the US, but all around the world. And to talk a little bit about that, we have 3 guests here in a panel that'll be moderated with April Smith-Harrack from Health and Human Services. She's the Northeast Regional Manager. So please welcome our next panel to talk about the fragmentation of digital health.
Thanks, Dan. So I think the first thing we're supposed to do is introduce ourselves. So I will go ahead and go first. I'm April Smith-Harrack. I am the Regional Health Administrator for New York for the Office of the Assistant Secretary for Health of the U.S. Department of Health and Human Services. And a little bit about myself and how I got here. A lot of what we do is really basic health policy. It's everyday public health. And over the course of the pandemic, I started looking around and saying, we're really in the precipice of an entirely new way of practicing medicine and thinking about health. And innovation and technology is a big part of that. And as a government, if we don't think about how we bring that forward and work within the new system and work complementary to that new system, then we're missing an opportunity, especially as it relates to equity and underserved populations. So that is how I came into digital health about 3.5 years ago, 3 years ago now. And I've spent a number of wonderful hours speaking with founders and funders and academics and all sorts of players in the digital health field. And it's really interesting to be able to sit here with both of you today and speak about digital health and fragmentation of the health system. So I'll hand it over.
Sure. My name is Kyle Christopher. I'm the current CEO and founder of Smart Care 360 and MRG Health. We're a disease-specific and determinants of health-specific virtual care management platform and clinical call center solutions company. Prior to MRG Health, I have a formal degree in vascular, general obstetrical, and cardiac sonography. I also helped commercialize a molecular genetics and pathology lab with a triple board Johns Hopkins trained doctor in molecular pathology and immunology. But we're on the forefront of this thing we call digital health. We've been at it for a while. There's over 500,000 patients using our technology now. We have about 2,000 on the managed care model. And over the past 4 or 5 years of doing what we're doing, we've been able to work towards getting a 90% adoption. So 9 out of 10 people we talk to opt in, 80% compliance, and less than a 5% monthly drop off through really personalizing almost a patient specific or patient centered avatar and taking into consideration determinants of health, risk factors that will address adoption, adherence, and clinical outcomes. So happy to be here and great to be on a panel with you guys.
My name is Theo Borgavon. I straddle two worlds. I'm a medical oncologist, and I also work in the big pharma sphere where I'm a medical director managing clinical trials at multiple phases with a special interest in lung cancer. And I think I have a special viewpoint when it comes to digital health and the lacks that we have within the healthcare system at a patient-based level, as well as at the clinical trial level as well.
So I know that we're here to talk about the fragmentation of the health system. And I think from each of our perspectives, it means something just slightly different. So from my perspective, I take a 30,000 foot more policy view. And when I think about the fragmentation of the system, I think more on a global level of a number of digital technologies, EMRs that don't necessarily speak to each other, data sets that don't line up, and overall lack of access for patients and a lack of clarity into their medical care and their data that relates to their health. But I think for each of you, it has slightly different meanings. So perhaps we could talk a little bit about that.
Sure. I mean, the digital health space, as most of us probably know, is very fragmented, right? You have all these different chronic diseases, you have remote patient monitoring, you have chronic care management, you now have remote therapeutic monitoring. All these codes are time-based, so you're having to track time, billable instances. So it's like, how do you encompass all of the different diseases or all of the different virtual care fee-for-service opportunities in one platform? And I think that's what I define as solving the problem of digital health fragmentation, is a consolidation of one platform that has several of the different capabilities that a lot of them out there do. I think also you have to look at the staffing issues. Without people, this stuff just doesn't work. You have CPT codes, again, that are time-based. You have to spend a certain amount of minutes either reviewing information or with the patient. You get, 100,000 patient, deal with a payer or a large health system, that's going to mean 150, 200 jobs. So who's going to source those people so that you actually meet the reimbursement guidelines and it's not just a complete waste of resources? So I think technology consolidation and staffing is one of the biggest fragmentation issues that I've encountered.
I would agree. I think at the patient level, the intricacies are complicated. I would say fragmentation for me at the patient level means multiple things. And the first one is lack of patient trust. So I think when a patient comes to you for the first time and you're spending half the time trying to consolidate data from multiple EMRs, it just looks bad, I think, for the system and for the practice. And I think it makes the patient lose confidence right away. And second, I think it means not delivering the best care. I think that if we were to limit fragmentation, you could limit how many duplicate tests are run, for instance, or the need to run either certain pathology samples or certain panels of tests that haven't been run, or perhaps if they have been run already, what are the limitations of that? So having a full picture across at your level and across multiple EMRs right away in front of you, I think is absolutely key. And the last one is efficiency. I think if I were to sit down with the patient for the first time and the patient has been across multiple platforms, but I have all the data there in a digestible manner, it would make me extremely more efficient in regards to how I were to treat that patient going down the line. At a clinical trial level, we talked about health equality and access to not just medical care, but actual clinical trial care. I think there's a lot of underrepresented populations within the clinical trial world, and abating fragmentation on that level, I think, would allow more of these people to come into clinical trials. And that emboldens clinical trials, and I think it emboldens the outcomes if you were to more generally represent the population at large, rather than a specific subpopulation.
incredible. And I think that Kyle, you had another question about how we prevent abuse of the systems from this fragmentation.
Yeah, I mean, one is just reporting standards. If you're billing these new CPT codes that have been around for a few years now, they're all time-based. There's a certain amount of billable instances. So I think, mandating more stringent reporting guidelines that tie to those billable encounters is one big way. I think really protecting the patient data, how many people like actually read that terms of service agreement when you check that box, and patients are skeptical in this day and age of digital health. And so making them feel comfortable that, hey, we're not going to go sell your data. We're using this to improve the program or to improve clinical outcomes or the overall experience, not to go sell it to big retailers or what have you, is another big way. And I think just, giving the technology companies the ability to really perform the services that they, or not the technology company, but the services that technology comes to perform the services that their systems are built for, and make sure that when doing that, that they have the proper workflows, protocols, things that the doctors are expecting, because if they don't feel comfortable, then they're not going to adopt it. So I think those are some important factors.
Yeah, I would totally agree with that. I think there has to be proper and consistent communication in between the healthcare provider and everybody else. There's so many data points that everybody needs to be educated in terms of what's important and what's not. And when those data points come together in front of a physician or a medical provider, they need to be important and make sense. So I think communication is absolutely key in that sense.
We have some other questions that were posed to us, and I think that there are particular things that each of you were interested in sharing. So would you like to go ahead and maybe share something from our list of questions?
Yeah, one with the questions was, how are we gonna, get patients to adopt this stuff? If patients don't use this, we all lose, including the patient. And so I think it starts with just personalization. You have to take into consideration the fact that, determinants of health, or if someone has certain risk factors, for instance, transportation, or, they're not set up on food stamps, well, then you can't try and promote them to eat healthier if they don't have the resources to even get to the grocery store or even get the food that they need. So taking into consideration, those social determinants of health to really drive adoption, also making sure that the patient just understands what they're dealing with, and educating them on certain basic things that they might not have the right information on, really helps drive that adoption, because it makes them feel like you actually care and you're not just trying to put something else in front of them. But I really think it's patient-centered care and really team-based care. There's shortages all over, and having the right staffing ratios to patients is very important too.
Absolutely. I think we spoke briefly backstage about knowing who your patient population is. If you're delivering a digital platform to, for instance, an oncology population, you're going to expect that the majority of your patients are going to be on the older side, many of which are just not comfortable with technology. And so if you have multiple layers, for instance, that require logging in or accessing your account, or the patient interacting with the system in multiple ways, you have to be able to tailor the software to the patient's skill level and to the patient's needs. So knowing your patient population is absolutely key when it comes to technology.
We really, as a federal government, promote what we call culturally and linguistically appropriate standards, class standards. And integrating that into digital modalities has been really interesting. And some of the types of adjustments that might need to be made in a digital environment are a little bit counterintuitive and sometimes surprising. But even down to sometimes the background color of a screen that may, for certain cultural groups, a particular color may be very off-putting and discourage them from engaging with the technology. So having the ability to address some of those different needs in a digitally competent way is really interesting for each of those populations. And it's also an interesting challenge to be able to accommodate all of those needs while reducing fragmentation. So it's more of an integrative while addressing needs than this program over here for this person and that program over there for that person. It makes it a little bit more
Right.
challenging.
I think it needs to be a balance. Kyle, let me know what you think between patient accessibility and security. I think as we take away, for instance, these firewalls or these passwords to make the software more accessible, perhaps you lose a little bit of security. So it has to be a little bit of fine balance between both.
Yeah, I mean, security is obviously, top priority when it comes to patient and just the data in general. You have to make it easy. If you're taking, vitals on remote patient monitoring and a patient's having to pair their device and do all these different things in order to just get the reading in, they're probably not going to, be using it very long. So I think Bluetooth is kind of dead in digital health now. If you're not using cellular technologies, then you're kind of out of date, and that really drives adoption. We're at a point now where even if a patient doesn't have a smart device or they don't have Wi-Fi or internet, we can still see whether or not they took their vital or activity or certain things. Even if they don't have a Fitbit or a Apple Watch, they just need whatever device we're tracking their vitals with. And so that really gives us just more visibility and able to take more of a proactive preventative care or approach on the care instead of a reactive treatment-based approach when it's already too late. So I think that's, definitely security is important, but you also have to make it accessible.
Right.
And I think that we're just about out of time, but I wanted to see if we had any questions from the audience. Yes.
So you're an oncologist, you have protocols, oral and infused therapy. Oral comes from maybe a Walgreens specialty, you're doing the infusion. Fragmentation by providers. How do we address that?
I wish I had a short answer. I think we've touched them on certain points tonight in terms of where to start. The main one is knowing your patient population, knowing what type of access they have to digital health and perhaps what ability they may have when it comes to accessing this digital health. The most important one for me is delivering data points and delivering information that's digestible and important to the medical provider and easy for them to digest, whether it comes in the form of, just think about a display with multiple vital signs, a display showing liver function. Rather than throwing all the data together at once and just putting it in front of a provider, knowing what's important and how the provider wants to see things, perhaps trends through time, is also important. So knowing the patient population, delivering important data that's digestible is perhaps the best place to start.
Do we have time for one more question? Anyone else in the audience? Well, I will ask you to wrap up by sharing what your view of an ideal non-fragmented system would look like from both the patient point of view and the business point of view.
Yeah, I mean, you have to take into consideration a patient journey, right? They're going through their daily, personal lives. They have their clinical stuff, and so personalizing things around their activity levels, their languages, the availabilities, the type of engagement, mediums that they prefer. It all goes into effect. It's like an omni-channel kind of avatar type of communication and engagement, and that's where we've really been able to see adoption, adherence, and compliance.
Yeah, what about you? What does it look like in an ideal world?
I'll speak very idealistically, and you mentioned centralization. If we had an ability to centralize all of this, that would be the dream, whether it's across multiple pharmacies pulling in IV medications and PO medications. But the ideal scenario for me would be I log in, I have the complete patient picture the way I want it, the charts the way I want it. And the most important part is whether the patient's been to multiple medical facilities and has interacted with multiple providers that each use different EMRs. Those EMRs now come into my system seamlessly. So for instance, I can give you an example. I use one EMR in a certain hospital, and the outside EMR comes in as a PDF, and I can't scan it, I can't find it, so I have to literally go through pages of PDFs. If that were to come in and integrate with my system seamlessly, and I have all the patient information and data right in front of me, that would be the ideal situation.
And it's very similar to yours, I think. Yeah, I think for a patient and a doctor to be able to identify all of the relevant information, all of the history on a single platform with all of the AI and digital accessories that might be able to aid in their health. And also for that patient to have ownership and understanding of what it is that means for them. So that the medication and all of the clinical care then becomes a conversation and a team effort really between like the entire medical team and the patient. That would be my ideal world. So I hope we can get there.
Yeah, me too.
Thanks very much.
There you go.
Thank you. That is fantastic. And again, I think the thing that we're seeing in digital health and what we're about to hear now from Professor Katane from Columbia Medical Center now talks about the use of digital in cardiovascular care. And as one of the leading researchers at Columbia Medical Center and a professor of cardiovascular medicine at Columbia, he is one of the folks who is doing a ton of studies again, around heart disease and seeing where the opportunities for digital technologies to be adopted are, but also some of the obstacles. And obviously doing so many different FDA studies, he's able to understand where the agency, the FDA, is actually providing more leeway or asking for more digital biomarkers in the studies, whether it's medication adherence through smart medication packaging, or whether it's using more real world data with home blood pressure kits, home scales and things like that, activity monitors, to understand how and where digital can lead to better data, either in a phase 3A or B or in a phase 4 post-marketing study. So with that, please welcome Dr. Katane.
Well, thanks so much. It's a real honor to be here and super impressed with the program so far. And I'm a clinical doctor, so we'll keep this relatively straightforward and based on clinical medicine and talk a little bit about hypertension. And so at the very end of this talk, even if you've learned nothing about digital health, at least you'll know something about blood pressure, which we can all take home to either ourselves or our parents or someone else like that. So if I can get my slides up, that would be great. Perfect. So what I'm going to talk about is blood pressure as a model for where we can really benefit from the use of digital health. I have a variety of industry-based grant support for the trials that we do. And I just want to credit one of my colleagues, Naomi Fisher from Boston, for a lot of the concepts and slides that I'm using in this talk. So just to start off with, I don't think I have to convince people that much about blood pressure control and how important it is in terms of reducing cardiovascular events. Just simple increases in blood pressure dramatically increase cardiovascular mortality. Now, I don't know if any of you were following the US World Cup game, but that was actually going on and it just ended. I think the US just won. But the other reason that blood pressure is important is that it's episodic. And this is just an example of a paper published in the New England Journal of what happened in Germany during the World Cup games. And the red spikes are all the German games. And on the y-axis are admissions to the hospital for cardiovascular events. So you can see there's a pretty clear correlation there. It's problematic. And so this is something where a lot of patients come to see me in the office and their blood pressure may be fine, but or it's elevated and they say, well, that's just because you're wearing a white coat. Well, the reality is I'd like to think that I'm a lot less nerve-wracking than the cab driver who cuts you off when you're trying to hail a cab or trying to cross the street right here. And so at home, blood pressure is spiking all the time. And so it's really important to get measurements of blood pressure beyond the office. And simple decreases in blood pressure, just 2 millimeters of mercury. If I were able to do that in all of my clinic patients in the hospital, I would reduce their stroke and cardiovascular mortality by 5 to 10%. These are whopping drops in terms of public health outcomes, especially considering how prevalent hypertension is. Despite the fact that medicines are generic, despite the fact that in areas like this, access to care is very, very good, we see that rates of blood pressure control are awful. On the left of the slide is blood pressure control among patients with hypertension, and it's languished despite the fact that we have all these tools and on patients and doctors to see them. The idea here is that less than 60% of patients have their blood pressure controlled, and even those who are on medicines, it's still pretty terrible as a whole. So here's a good example of why that is. So this is just a patient that Naomi saw up in Boston who came in to see her. And just so you know, to center and level set, blood pressure should be 120/80 and at most 130/85 or so. So the patient seen it and had a blood pressure of 144/92. And at the time, Fenway traffic was busy as the Sox unfortunately beat the Yankees. So the patient didn't want anything to be done because he said it was because of the Red Sox. 2 weeks later, the Red Sox won and the blood pressure was still elevated in the office when she saw him. She said, come back in 2 weeks, your blood pressure is still elevated. He says, oh, it's because the Sox won the series. Then after that, the next time the patient was seen, the blood pressure was elevated, but he was having arthritis pain. And then the elevator was broken, so he took the stairs. And it's excuse after excuse. And blood pressure is called the silent killer because nobody feels these symptoms attributable to blood pressure. But yet 10 years down the line with untreated blood pressure, cardiovascular events are accruing. And this entire saga goes on and on. Finally, he agrees to take a prescription of no more salt. 3 months later, joining a gym. And you don't know how much time has elapsed for this patient who's coming to the office repeatedly. Think about the ones that don't even come to the office and what happens with their blood pressure over time and their side effects associated with them. Now, the other part of this is that there's differences in perception of what we as physicians do and what our patients do. So on the left is the doctor who says, just take these medicines I prescribe, uses an antiquated, many of you may not even know what this is from, Wayne's World. This is all good. The patient's going to be treated for blood pressure. And the patient's perception of what's going on is very, very different. Why am I taking all these pills? I go to Dr. Google online. There's a million side effects associated with them. I don't want to take them, and I'm not going to take them. And so we have to come out of this outmoded view and actually see the adherence piece of this and talk to patients about why it's important to take medicines for a condition that they don't even feel. And if you look at this published data, it's really bad. 50% of patients stop taking their blood pressure medicines within a year. And this is people that we just assume are on it because every time we look at the EMR, we say they're on the medicine, fine, check, but they're not even taking it. If you actually measure adherence testing for people with elevated blood pressure, you actually look at the urine of these patients, less than half of patients are actually taking the medicines that we prescribe them. I know for a fact that if I write a prescription, probably not me because I'm a better doctor than this, but many people, my students, if they write a prescription, the likelihood that someone actually fills the prescription is 2 in 3. And the likelihood that they take it as prescribed, even for a once-a-day medicine, is 2 in 3. So if you multiply those two together, you get about 50% adherence to medicines we prescribe. And as physicians, we need to come to grips with that and do better for our patients and then for our populations in clinic. Even in the context of clinical trials, the SPRINT trial was a trial that many of you may have heard about. It was in the news, looking at control of blood pressure intensively versus conventional control of blood pressure. And what they showed is actually a reduction in cardiovascular events. It wasn't just a reduction in blood pressure. But the sobering part of the SPRINT trial is that when patients stopped being in the trial and they just went back to their normal routines, at 10 years, their blood pressure had drifted back to where it was when they started the trial. These are patients that were initially enrolled in the intensive arm who knew that they were going to get cardiovascular benefits from having their blood pressure better controlled. So that's a problem. So what do we do about this? Well, we've heard a lot about digital health and ways we can monitor blood pressure at home. And I'll talk to you a little bit about two sort of aspects of this. One aspect is sort of what we know. One aspect is more experimental and what we could do. So on the left is digital health. On the right, these are kidneys. There's a way to actually treat the kidneys to reduce blood pressure. So first, how about taking care to the patients? There's a really important study that was published in the New England Journal by Ron Victor, who subsequently passed away, where he actually went into the Black community and had barbershops be the ones administering care to patients. They brought pharmacists into barbershops and had the pharmacists talk to the patients within that specific location to lower blood pressure in that community. And what they found is that 60% of patients, 64%, had control of their blood pressure versus just 12% in the regular education group. So this was important, but this is difficult to scale. So is there a way to do this digitally so people can be seen in their communities, perhaps by video or otherwise, to be able to get better control of blood pressure? That's something for food for thought. Another thing that's being done is at the MGH Brigham system, and this was just published in JAMA Cardiology, which is why I'm showing it, because there's outcomes associated with it. They basically did virtual health clinical visits by people who are volunteered out of college. This was done in conjunction with pharmacists, in conjunction with physicians as well. But the idea is to take patients, give them home blood pressure cuffs, see them, have them look at them, monitor them, and then have an algorithm feed the readings to be able to control their blood pressure. And by doing this, what they actually showed is a significant reduction, statistically significant reduction in blood pressure compared to the usual care group. That's why I'm showing it, because normally we hear these things as pipe dreams without actual outcomes. And in this case, they were able to demonstrate good outcomes. Beyond that, and sort of to conclude before we take some questions, I'll talk about this technology, which will likely be approved in the next year or so here in the United States. Most of you are probably not familiar with it, but there's actually ways that you can downregulate nervous signals from the kidneys by essentially zapping those nerves. The nerves travel around the kidney arteries themselves. And what the device specifically will do, this device, there's other devices as well, heats up those nerves and deactivates their signaling. And that is an adherence independent way of controlling blood pressure. So instead of someone having to take a medicine every day, they have the procedure done, their blood pressure gets lowered, as we've shown in sham controlled trials, and that allows blood pressures to be lowered. But even within the context of these carefully conducted sham controlled trials, we observed an interesting phenomenon. So what we did is we measured pressures at home in the 7 days prior to a follow-up clinic visit. And because this was an FDA-sponsored device, under the auspices of the FDA device-based trial, we had patients come in every month and they had home blood pressure taken for 7 days. Then they came in for their office visit, at which point we looked at their urine to see if their medicines were being taken, and they knew this was happening. That was the office visit. And then we actually sent them home with a blood pressure monitor that did blood pressure every 12 to 20, every sort of 30 minutes to an hour to then look at their ambulatory blood pressure. But importantly, this thing got placed in the office after they took medicines that we witnessed them taking in the office. So what do you think the results showed? What they basically showed is there was greater separation in the home blood pressures before they came in for their office visit when they were doing what they were doing. And actually at 6 months, while medicines were greater in the sham arm compared to the denervation arm, there was actually not much of a difference seen in the office. So what we're seeing in the office may not reflect what people are actually doing at home, even in the context of a carefully controlled clinical trial. So to sort of conclude, I just wanted to use hypertension as a base case to give you an idea of where innovation is still sorely needed. We know that hypertension or high blood pressure it should be easy to treat. I mean, this is not hard. They're generic medicines. They're super cheap. You can take them without any issues, and access to care for certain things like this, even in geographies where it's good, shouldn't be an issue. And yet we're terrible at it. So we definitely need innovation to be able to help us. Where is the innovation needed? I think the most important thing I can tell you as a clinician that's been in practice for now 20-something years is that empowering the patients to be in charge of their own decision-making, having them actually see the blood pressure numbers and understanding what that risk is to them over time is game-changing in terms of their behavior. We see this across the board in cardiovascular disease. We'll see it with CAT scanning. When you look at heart arteries, if you see plaque, patients are motivated to do things. If you just tell them, we need to lower your risk, they're less motivated. So that's really important in terms of empowering patients. We have many digital health strategies to do it. Adherence is another real big issue. And even novel therapies, which aim to sort of short circuit this whole adherence pathway, this feedback pathway, such as denervating the renal nerves, still need digital health to be able to monitor their effectiveness in the outpatient setting. For that reason I mentioned before, that if you do that and you only monitor them when they know when they're coming in to be monitored, the behavior is different than if they're truly at home in their element. So with that, I hope that was helpful to you in terms of talking about hypertension as a case study. I hope that there's a lot of investment in this area because we really need it. And from a population public health standpoint, there's nothing more gratifying than helping a large number of patients. So thanks so much for your time.
That is amazing. All right, so we have just come around full circle now from talking about some of the global issues with age tech and what we're seeing with fragmentation of digital health technologies in different communities to now understanding some of the nuance to digital health technology and cardiovascular care. And we are going to now talk about something that I think everyone is hearing a lot about and would like to understand a lot more about, which is value-based care. And so one of the more novel models that the HITLAB has found over the last year is around this idea of value-based care and how digital health infrastructure has been developed now to help promote value-based care, to support value-based care. And one of the national experts in this area is Scott Kornhauser, who is someone who has proven himself over the last few decades as an executive who understands market demand and is one of those very unique executives that has an understanding of how the healthcare services in the United States are delivered and, more importantly, reimbursed on a scalable and sustainable way. And that's why, in a lot of ways, we don't have a 16-year-old developing digital health unicorns or healthcare unicorns. Healthcare in the United States is so complex and so messy, if you will, that it takes about 20 years of experience to really understand it, and then to develop some of the billion-dollar unicorns we've seen over the last 10 years, particularly with companies like PillPack, Discount RX, both selling for about $1 billion to McKesson and to Amazon. And they were both started by teams of executives that were in their mid to late 40s out of Cardinal and companies like that. And so Scott has that kind of DNA. And so to really give us a lot more insight on what's happening with the digital health infrastructure and the digital health reset in conjunction and with this energy building around value-based care is Scott Kornhauser from Chicago, Illinois. Scott.
Thank you, Stan, for the generous introduction. I hope in 15 minutes I can live up to it. I want to first thank and introduce my partner, Bert Zwigenhaft. Bert is my co-founder in Clear Trust. We've been germinating this concept for over 4 years. Bert's work at the Association for Value-Based Cancer Care, where he is the founder, led to the genesis really of Clear Trust, as well as his work through Upstream Partners, his consulting firm, where he works with life sciences companies on their strategy around value-based care and contracting as it applies to the life sciences industry. And that work led to this concept of Clear Trust, but we'll talk about that later. So there's a lot of data on this slide, but the story is really in the top right-hand corner. By 2028, it's predicted that the US drug spend for pharmaceuticals is going to be close to $800 billion, if not exceeding. And remarkably, this year, the spend on specialty medications exceeded 50% of the total US drug spend this year. So relatively speaking, a handful of specialty medications cost more than all those maintenance drugs for heart disease and for diabetes and all those other maintenance conditions. On top of that, we have all these other data points. The number of Americans living with rare diseases is increasing. The number of medications to treat those orphan and rare diseases are being introduced at a breakneck speed as compared to what happened historically, as the FDA has now accelerated the approval process, and the pharmaceutical companies have gotten much more efficient at bringing these new agents to market. The government is not asleep at the wheel. Everyone is focused on value-based care for the last decade. And there's all kinds of numbers around the market in terms of what percentage of reimbursement today is under value-based agreements. Most providers will agree that over 75% of their income today is in some way, shape, or form based on some kind of outcomes or performance measure. And CMS has been increasingly writing new rules and legislation to encourage value-based contracting, value-based agreements, including in the pharmaceutical space, where just as recently in the last year, they made some really truly breakthrough new rules to pave the way with pharmaceutical manufacturers who previously were handicapped to some extent by Medicaid and other best price rules, which limited their ability to negotiate into creative new payment models for pharmaceuticals, especially the high cost ones. It's also important to note that as the cost of drugs has gone up for these specialty medications, and as they increasingly are a larger portion of the total share of total spend, patients are finding it increasingly difficult to pay for those drugs. The co-insurance alone for a high-cost specialty drug for a Medicaid patient could exceed their total income for the year. And so consequently, the number of patients abandoning these scripts is extremely high and at an alarming rate. So value-based care for a long time now, for over a decade, and there's no indication that it's going to slow, although it's been, like everything in healthcare, a complicated journey, is really at the heart of every value-based care model is a value-based contract. And at the heart of that contract is some kind of performance warranty. Somebody is warranting something in terms of a product or a service or an outcome. And pharmaceutical value-based agreements are warranties that tie the drug's payment to some kind of clinical or economic measure or endpoint. You could think of this as the anatomy of a pharmaceutical-based value-based agreement. It's complicated. We like to say that it should be complex. What we found over the last decade in value-based contracting in general, not just for pharmaceuticals, but across the spectrum, is that we have a tendency in the marketplace, oddly enough, in a market, in an industry that prides itself in its technology, we have a tendency to dumb these agreements down because everyone has been stifled by, afraid of the data. And so these agreements have been made really, really simple because everyone wants the measures and the data that supports the measures to be really easy to implement and operationalize and execute. And as a consequence, oftentimes, particularly in pharmaceuticals, we've found that the results or the value that's been extracted from these agreements has also been minimal. It's been reduced or minimized by simplifying these agreements because we've been afraid of the data. But value-based contracts for pharmaceuticals include both a clinical guarantee, what is the clinical value that the drug is going to produce, but also then potentially alternative payment models and pricing models that are paired with that clinical guarantee. And that can be very complicated, especially if the value construct on the far left-hand side that's being used to design that guarantee is on a total cost of care model, where the pharma is saying, we're not just clinically guaranteeing and warranting the cost of the drug therapy, but we're warranting that our therapy will reduce or avoid total cost of care costs, which implies, of course, a lot of complexity then in terms of data and performance measurement. So for over a decade in value-based contracting for value-based care, we've been suffering from these analog problems in this incredibly digital world that we've been talking about all day. There's been first a lack of trust because there's been such a lack of automation and digitization. There's a lot of distrust around how data is interpreted, how these measures are computed and calculated for performance and quality and outcomes. Consequently, again, creating a lack of trust between stakeholders at either side of that agreement. There's been a lack of automation, as I've already mentioned, and there's been a lack of complexity, as I've mentioned. Instead of having technology to meet the requirements of these, what could be, should be, would be very complex agreements with very complex measures, with very complex data requirements, we've again tended to dumb them down. A great example in pharmaceuticals in the specialty world, we see a lot of value-based agreements where the only measure is adherence. And contractually, these adherence agreements, all they require They require zero data. All they require is that the physician attest, sign an attestation form that the patient failed therapy and discontinued therapy, and here's why. And then lastly, there's been, and probably most importantly, a lack of timely performance insights. So for 4 years in our work at the Association for Value-Based Cancer Care and at Upstream and with life sciences consulting engagements, we've heard over and over and over again as we've interviewed the market, providers, physicians, specialists, hospitals, a common battle cry. For all of value-based care and contracting, we have to manage our performance through the rearview mirror. Because 100% of value-based agreements in the market for the past decade have been administered retrospectively. Everyone signs a contract, a bunch of data is aggregated for 30, 60, 90, 120 days. An analytic engine runs a bunch of measures and produces a scorecard. The provider gets the scorecard and says, okay, now I think I know what I have to do next quarter, and sets out hopefully to improve. So at ClearTrust, our mission, our objective is to go digital. It's to raise the bar, enable those insights, and to be able to inform every endpoint in the care delivery of a drug therapy to know when their performance is suboptimal, when they're doing something that could potentially void the warranty that the manufacturer has put on the table. You can't see the bullets at the bottom, but it's all about doing this in real time, providing concurrent feedback, situational awareness to every endpoint in the network, including the patient, when there's, again, something happening that's contrary to the rules or the terms of the agreement. So if you think about it, we're all familiar, we buy a toaster, we buy a set of tires, we buy a car, we buy a television set. There's a 20-page warranty with fine print, inclusions and exclusions as to the representation of the terms of that warranty. In healthcare, it's even more complicated, surprise. And so the goal of ClearTrust is to take that complexity, and instead of handing you a 20-page document with fine print, we turn that into a computable agreement, represented by rules and algorithms and measures that we can adjudicate in real time. And so we operationalize that complexity, not with big data. We're not about aggregating data so we can run a report card 90 days later, but it's about transactional analytics. It's about updating the patient record as they go through their journey. And each time that record is updated, present it to the contract rules engine. And again, determine if anything's going on that is inconsistent with the warranty. Not so that we can contractually deny claims, to the contrary, so that we can continuously improve care and outcomes. Because we can continuously inform everybody in the delivery of care when they're performing suboptimally. So if there's one thing we've heard today, probably 100 times, is it's all about the data. I said it's all about the blank data. I know what you're thinking, but that's not the word I was thinking of. The data is complex and it's ever changing in terms of its complexity. Every day, someone thinks of some new data element that's relevant to that patient journey. And depending on the terms of the value-based contract, likewise, that data can be relevant. But it's really all about the computable data. And this is what's been the greatest handicap in operationalizing and making computable these value-based contracts in all their complex glory. It's been that we've gotten really good at moving data from point A to point B through interoperability standards, which are now becoming ubiquitous. But what we've still continue to struggle with is once we land the data where we've sent it, making it computable and understandable is still a tremendous challenge. that needs to be dealt with not only in batch, but again, in a real-time transactional way. Lo and behold, our government comes through with the 21st Century Cures Act. It makes data blocking illegal. It accelerates the adoption of the FHIR standard for real-time interoperable movement of healthcare and sharing of healthcare data. And it makes patient access to that data the law. So Clear Trust is all about creating the data circuits to the endpoints in these tiny little networks that service these rare disease patients that are consuming these high-cost specialty drugs, brings that data into a data store that in real time transactionally can make that data computable by making it semantically interoperable, not just moving blobs from point A to point B, and serving it up then to a rules engine that in real time can transact that data against the rules that represent a contract. And if anything is detected that's inconsistent or inappropriate, it can communicate to that endpoint. So if you follow the wheel starting at the top, going clockwise, that's the journey and the workflow of a specialty drug therapy as the patient goes through their journey and as the drug and the product goes through its journey. And our job is to, again, ingest data from any endpoint in the journey that is relevant to the terms of the contract. From the payer to the distributor, the credentialing function to make sure providers know how to participate and sign up to participate, to the delivery of care down the bottom from diagnosis to prescribing to actual care delivery, to the whole patient support function, which in the specialty world is a whole industry in and of itself. There's over 50 specialty pharmacy hubs that exist just to onboard these specialty patients onto their complex specialty drug therapies. Through the dispensing and administration events, and then continuously we're communicating and measuring performance to the network until ultimately we get to a point of reconciliation, because it's all about, at the end of the day, tying reimbursement or pricing payment to performance. So it is complex, but we've just spent a full day talking about applying the digital world to the world of healthcare. There's nothing that I've just spoken about that is new technology. All the technology exists in the market. It's a question of assembling it, orchestrating it, and applying it to this use case. And so we take pharmaceutical companies through this journey. We help them identify and design a computable agreement without sacrificing complexity, which more often than not sacrifices outcomes, both financial and clinical, and create a digital design that optimizes the equation for all the stakeholders, including the patient, the payer, the provider, and the pharma. And I think I'm out of time. What, time for questions or no? Sure. Somebody's got a quick question. Yep. Any questions? No question. Thanks.
I have the enviable job of keeping you all in your seats for a few more minutes. I should say unenviable. First, thank you all. And thanks to all of our speakers. This has been an extraordinary event in terms of both content and insights. And I'd like everybody who learned something surprising raise their hand. All right, phenomenal success. Thank you all for that. Secondly, thank you for your patience. For those of you who are not data geeks, you probably didn't keep track, but I've been keeping track. We've sat on a chair for at least 7 hours. We've listened to 24 sessions. 19 of them were either presentations or panel discussions, and 5 were presentations of some really interesting and I think urgent new solutions to the broad needs of the healthcare ecosystem. I promised you this morning that we were going to explore, discuss, and possibly celebrate digital health. I think we did that. Digital health was the shorthand for tech-enabled improvements broadly. The key issues of success I asked you to keep mindful of, were: can it work? Will it work? Does it work? Does it work in terms of value and economic benefits? Is it sustainable? And what will it take to accelerate? So as I polish the rearview mirror and give you, one person's perspective on what we've done in the last 7 hours, keep that in mind. I've got 4 points that I wrote down as interesting to me, and I hope you'll find them interesting as well. Point number 1, the goal of sustainable health and high quality of life for 8 billion people in this world still remains unmet. Unmet needs are high and varied, and the need is greater, as the various things that threaten our well-being and health impinge on everybody. And so the unmet needs in healthcare are as great as ever. And Patrick, thank you for reminding us early on, it's all about the unmet needs. Secondly, the ambition for innovation to satisfy those needs spreads across the entire landscape of healthcare, from providers to payers, to product companies, even to patients. And it also includes large companies and small entrepreneurial startups. And so in essence, the landscape is rich with need, and it's also rich with interest and rich with opportunity. Third, and Scott just mentioned it again, data is increasingly being the currency of healthcare innovation. Got that? It's all about the data. Now I'm going to step off to the side for a second, hit the pause button on my comments, and say it was all about the data when we got excited about personal healthcare records 10 years ago. Where are they? It was all about the data when we got excited about interconnected health information systems to connect healthcare systems in local geographies. Where are they? Some worked, many didn't. So it's all about the data, but data is insufficient. So we need to be mindful of it's not just about the data. How do you get it? What do you do with it? And how do you deliver the value from it? But, big but, money remains the essential fuel of achieving those innovations. And that essential fuel is becoming increasingly difficult to find in the next few years. So data is great, data is necessary, but unless you've got fuel, you're not going to move. Fourth point. What are the factors of success? We've seen this from, a couple of dozen different perspectives. We've inferred it through the lens of our own experience. And so we've sort of had to walk around the elephant. We each see and hear and grab a different part, but I don't think we still understand what the elephant is. But there are some factors of helping diagnose that elephant or dissect the elephant that I think are important to remain mindful of. And the two most important that strike me are, first, you can't succeed without leadership. And leadership includes, again, Patrick, thank you, passion, mission, values, all focused on a commitment for transformation. In the absence of leadership, a good idea is just a shiny object. Secondly, a compelling business and financial model is absolutely necessary, and it's got to be clearly understandable, verified, because the model includes who gets the benefit and who pays for the benefit. And we live in a world where those are literally two different forces. I want the benefit as a patient. I want you to pay for me. And unless we create business models around these technologies that understand that dichotomy and that tension we're going to have a struggle. Now, there are unicorns and there are successful point solutions, and we're going to see those in the future as we have in the past. But if we're looking for having transformational innovation, we've really got to understand the value proposition of benefit versus payment. So with that, that was my takeaway. Hopefully it adds to yours. I've got a couple of other final comments. One, next year, we're going to put on 2 summits, and we've now got a commitment for a summer summit in June 20 to 22, 3 days. And we'll be announcing that more broadly as we roll forward from here. And we'll also have another fall summit. And finally, oh, I lost this one. Oh, my goodness. Oh, here it is. Most important one. Open bar. We have an open bar networking reception starting 10 minutes at the Heights Bar and Grill. And it's about a 10-minute walk, 5 minutes if you walk fast, 2 minutes if you sprint. It's 2 blocks south on Broadway, and I'm hoping that we all have the stamina and willingness to go down there and share a cocktail or two and reflect on what we've learned today. I think that, this has been a long, rich set of discussions and insights, and I can tell you one thing, the world will be different tomorrow because we're all going to go into tomorrow with kind of a new insight and maybe a new passion to bring about a change. So thank you all very much. My applause for you. The bar is open.